No, we've got and my senior colleagues, my respected colleagues, and all the delegates and all the persons involved in this meeting. Yesterday, it was a very successful meeting, and more than 1,400 delegates and faculties logged to the meeting, and it was everybody is telling that they are so happy that it was a very successful meeting. And we expect that today also the reputation will be same. And log hai nahi?
Raghu, please.
Raghu, but
please call.
3:25 is the time.
Yes, go ahead, sir. Go ahead. Please go ahead.
Okay.
Yeah, we're live. We are live.
Okay. So good afternoon, everybody. And this is my proud privilege to congratulate all of you for yesterday's attendance. It was more than 1,400 faculties and delegates and other paramedical personnel put together, and we got a huge response, and there were very good response regarding the quality of the meeting also. So we'll try to uphold the quality of the meeting today. And today we'll be starting with Dr. Professor Bahl, and he will be speaking on stable coronary artery disease, future of PCI in stable ischemic heart disease patients. And he is the principal director of cardiology in Max Hospital, Delhi. And he was also the ex-dean academics and ex-head professor of Department of Cardiology, All India Institute of Medical Sciences, New Delhi, which is the most premier institute so far postgraduate education is concerned in our country. So congratulations, Professor Bahl, and he's a very good friend of all of us. And it will be chaired by Dr. P.K. Dev. Just a minute.
No, it will be chaired by sir. You have to call Dr. K.C. Goswami, Dr. Shantanu Guha.
Professor K.C. Goswami, Dr. Shantanu, Professor Shantanu Guha, Professor A.K. Kaur, Professor H.S. Chopra, Dr. Shomitra Ray, and Professor Manoranjan Mondal. So there is no expert panel in this session because this is a guest lecture. And Dr. Bahl, please, and I'll give the mic to my chairperson, respected professors and chairpersons of this session to go and proceed with the session.
Should I take over?
Yeah, please, Dr. Chopra.
Dear friends, it's really a great pleasure and honor indeed to be here this afternoon on the second day of the first session of CSI NIC, and we have a very eminent speaker today. Dr. Bahl, past president of CSI, does not need any introduction for this audience. He is a legend and a luminary in cardiology. The topic is going to cover is a very, very important topic, future of PCI in stable IHD patients. Is there a controversy or there is a consensus on this? We'll request Dr. Bahl to start the presentation. Dr. Professor Vinay Kumar Bahl, sir.
Thanks, Dr. H.K. Chopra, for the kind words. Thanks to NIC for giving me a chance to be with you in this webinar. Now, the brief I have is to speak on PCI in stable ischemic heart disease. When it comes to acute coronary syndrome, there are no question asked. Acute coronary syndrome, PCI, saves lives, which has to be performed as soon as possible. But when it comes to chronic coronary syndrome or so-called stable coronary artery disease, there is a lot of skepticism in lay press regarding the utility of PCI in patients who present with stable symptoms. Even in the academic journals, you find there are critics of it. It was not long back, 2012, that JAMA, a reputed journal, said the PCI in stable patient is an expensive placebo for pain control. This is not my words, this is the editorial from JAMA. So when you are confronted with a patient who has a stable angina, how to treat it? There are various ways we can take a medical decision, but I think the most efficient way and most recommended ways is to go by the evidence. And I'd like to present you the evidence of doing a PCI in patient of stable angina. Why you perform PCI in any patient? there are two goals. One is a soft endpoints. Patient has symptoms and he wants a relief from his symptoms, and you want to reduce ischemia and improve his quality of life. But the hard endpoints are the death and MI. You want to prevent these so that the prognosis is improved. Let us see what are the evidence on the first soft endpoint of symptom relief if you do a PCI in a patient of stable angina. There are three important trials. Courage trial, 2008. In spite of crossover of 32% of patients at 11 months, by 3 years, there was a significant relief of angina in patients who underwent PCI, and so was the quality of life. Look at the BARI 2D. It's not a randomized trial, but if you look at this data, revascularization versus medical therapy, you again find the PCI was better in having a freedom from angina, as was the incidence of new angina, which was less in patients who underwent angioplasty as compared to the medical treatment. Come to the third trial, FAME2. These are the three important landmark trials on this subject. Again, at 1 year, you find the PCI relieves the angina much better than the medical treatment. So we know that PCI can reduce angina much better than a medical treatment. And this was borne by a meta-analysis of 12 trials involving 7,000 patients. And the guidelines say if there is an unacceptable angina, despite guideline-mandated medical treatment, go for a PCI. This will do good to the patient as compared to medical treatment. Some skepticism came from Orbita trial involving 200 patients. All patients had a severe stenosis. FFR was showing ischemia. They had a single vessel disease. After 6 weeks, what they find was the primary endpoint of total exercise time was no better in PCI as compared to a placebo group. Here, the difference was the placebo was a sham procedure. So the conclusion obviously drawn was that most of the relief is due to a placebo effect and not due to PCI. So there will be a lot of skepticism on this trial, but this is what was discussed at that time. So if patient has unacceptable angina, there is no question asked, you can do stable angina, but there are very few patients who, in spite of guideline mandated medical treatment, still continue to have angina. And angina relief is not the only goal for undertaking an invasive procedure. We want to improve his prognosis by reducing the incidence of mortality as well as myocardial infarction. So let us look at the evidence of PCI versus medical treatment as far as hard endpoints are concerned. Now look at the pre-courage area. Courage was the landmark, but before courage also, 3,000 patients, 11 trials, meta-analysis done. It showed that as far as reduction in death and MI is concerned, PTCA does not offer any advantage over medical treatment. Then came this landmark trial, which should have changed the whole scenario, but it did not. 2,000 patients, 4.6 years of follow-up or randomized trials. At the end of 4.6 years, death MI rates were almost identical whether patient underwent PCI or medical treatment. We have a follow-up of 15 years available. PCI 25% mortality, medical treatment 24% mortality. That means there is no utility of doing a PTCA in patients who are stable angina. But there was skepticism about this trial also, that this was a highly selected patients. They had a low ischemia. They were very low risk patients. The approach was not what is done today. Only 2.7% patients had a drug-eluting stents. Most of them had a bare metal stents. Success rate was only 93% and so on. Which trial does not have limitations? So it has its share of limitation. But this trial showed that medical treatment is not a poor cousin of angioplasty as far as patients of stable angina are concerned. Then look at this 13-study meta-analysis, 5,000 patients. Again, it showed that if you go for a hard endpoint, there is no reduction in death and MI, whether you do medical treatment, initial medical treatment, or initial angioplasty in patients of stable angina. Then came the BARI 2D, high-risk patients of stable angina with diabetes. If you look at the stratum who underwent PCI, there is no survival advantage of PCI, even in this high group of patients of stable angina with diabetes. There have been 61 trials. We came from a balloon era to bare metal stent, to drug-eluting stent, the first generation stent, the second generation stents. All the trials were conducted. This is fortunate aspect of interventional cardiology. Every aspect is studied. 25,000 of patients. Succeeding improvement in PCI technology did not produce any reduction in death and MI as compared to medical treatment. It should have been end of story as far as angioplasty is concerned for stable angina patient, but it was not. People thought we have a newer drug-eluting stents. We now understand the concept of PCI better, as if they were not knowing how to do a PCI. They should go for a complete revascularization. It should be ischemia guided and so on. Then came this trial, 95 trials meta-analysis. Meta-analysis is hypothesis generating. This is not conclusive. Yes, it did suggest that if you use a latest generation of drug-eluting stent, that is everolimus-eluting stent, the mortality and MI rates are decreased in patients who undergo angioplasty as compared to medical treatment. But we should not forget, everything new is not good. We have a bioabsorbable stent as a point in question. Absorb trials showed that these newer stents, which thought to be game-changing, fourth generation of stents, can. It was withdrawn from the market because after 2 to 3 years, there was a lot of stent thrombosis and myocardial infarction. Now, complete versus incomplete revascularization, there is a lot of controversy. But on a whole, whether you do a complete or an incomplete vascularization, there is no reduction in MACE rates. In fact, it is said that more the stents you put, the more the restenosis will be, the more the MACE rates will be. So the concept of complete revascularization is also questionable. Then people reanalyze, as they say, they beat the data. The statistics can produce whatever you want to see. They said that myocardial infarction are twofold. One is procedural myocardial infarction, another is a spontaneous myocardial infarction. Then both have a different prognosis. So by PCI, we reduce a spontaneous myocardial infarction, though we produce more procedural myocardial infarction, which are not prognostic consequences. Is it so? Not so. Look at the paper in October 2019, JACC. It showed that if there is a biomarker increase, CPK is increased as compared to TROP-T, there is a reduced, there is an increased mortality. So whether you have a procedural MI or a spontaneous MI, your prognosis is not good. So the theory that it is only the spontaneous MIs which are increased by PTCA and have no consequences on prognosis was not proved by this trial. Then people said you have to treat the patient who have a more ischemia, more than 10% ischemia, then you will get the benefit. And this was proven by a Courage Nuclear sub-study. The more the ischemia, the better the results. But when they updated their analysis, they find that whether the patient has mild ischemia, moderate or severe ischemia, there was no change as far as hard endpoints are concerned. Then look at the FAME2 study. They said that we can now better gauge the ischemia by FFR. They took the patient who had FFR positive and then subjected them to PCI versus medical treatment. There was no change in death and MI rate. The primary endpoint was basically changed by urgent revascularization. We also have a 5-year results of FAME2 available. And if you do a correction statistically, there is no change in myocardial infarction and death, whether you do FFR or not. Then came this meta-analysis of 5 trials, no change in death and MI, whether you do angioplasty or myocardial infarction. Many meta-analyses have been done. These are the 4 of them I have put in the screen. They showed that if you do an initial PTCA versus medical treatment, though there is no reduction in mortality and death rates as far as stable patient is concerned. All of us were waiting for ischemia trial. That was supposed to be the mega trial that would give the results in patient of stable angina. But before the trial was published, there was a lot of buzz in the Twitter. that they have changed the goalpost because they knew that the results won't be positive. And that came true. 5,000 patients, 3 years of follow-up. What the ischemia showed that if you look at the hard endpoint of death and MI, there is no change. What they again suggested was there is a crossover rate of 23%, which trial does not have. There is an initial procedural MI, and spontaneous MI are more reduced by PTCA. They had already undergone CT angio, and therefore they have excluded the high-risk patients of more than 50% left main stenosis or recent coronary, acute coronary syndrome, or left ventricular ejection of 35%. Given that, if you have a patient who fulfills that criteria of ischemia, should not we follow the ischemia and not subject these patients initially to angioplasty and put them on medical treatment? Then this is a meta-analysis of 14 randomized trials, including the ischemia trial. Again, no change in death and MI rates. Then there came the concept of imaging, physiologically as well as anatomically. But we forget that in between there are trials of OCT, 450 patients. It suggested that yes, OCT picks up the edge dissection and malopposition, but does not change the MACE rates. It was criticized that less number of patients are there. Similarly, FFR, future trial was halted because if you subject the patient to PTCA based on FFR, the mortality rate is going to be higher. Similarly, in medical group, we have now basically better treatment. We have PCSK9, which can reduce the LDL level to extremely low level and reduce the death MI. We have another theory of thrombotic events reduced by rivaroxaban. We have anti-inflammatory agents like canakinumab, which can reduce the primary endpoint of death MI and stroke rate. And its cheaper cousin like colchicine, which has been recently presented, which again can reduce death MI. So PTCA can do a greater harm than benefit in patients of stable angina as far as evidence is concerned. If you have to undertake a patient for revascularization, go for bypass surgery. If patient has triple vessel disease, if patient has a left main disease, as has been shown in historical data by VA, CAS study and European study, that if you do a bypass surgery as compared to an angioplasty, repeat revascularization rate will be less. As was shown in Syntex trial, though it used the first generation stent, but the death rate was reduced by 5%, myocardial infarction by 7.3%, repeat revascularization by 12%, if you do a bypass surgery as compared to PCI in multivessel disease. So was the results in 10 years, Syntax's extended study that there is the death rate is less with bypass surgery as compared to angioplasty. If you look at the freedom data, multivessel disease with diabetes, again we find that CABG is superior to PCI on long term, even in diabetics. Yes, they would use the first generation stent, but when they use the third generation everolimus eluting stent in the BEST trial, again the same results. Primary endpoint of death, MI, TVR was significantly less by bypass surgery as compared to an angioplasty. If you look at the left main subgroup, again you find the novel data, and there is some controversy in Excel data that the bypass surgery is better than angioplasty. And then now they have shifted the goalpost. They say, no, Syntax, you have to have a Syntax 2 score 2020, as was yesterday presented by Patrick Saraya, that you look at all these factors and then individually decide whether the patient should have PCI and CABG. We don't know. When we do a prospective study, they may change the goalpost again and say that there is another factor which has to be taken account. But we have to go by the present day evidence, and present day evidence suggests that there is no class 1 indication of PCI. I was looking at ACC guideline. I didn't find anything class 1. I looked at the ESC data 2019. Only group they say the angioplasty should be done is RC and circumflex, whether single or double vessel. In rest of the then bypass surgery scores over angioplasty. So it's not unnatural that Lancet in 2018 said there is a last nail in coffin for PCI and stable angina. They said that PCI is not a benign procedure. It can lead to death, myocardial infarction, renal injury, strokes, vascular complications. So when it is not indicated, this is the only procedure when the evidence says no, but the doctor say yes. Even the patient prefer angioplasty over the bypass surgery. So we have compromised, like PCI should be done by a heart team approach. That means patient's preference should be taken into account, surgeon should agree, angioplaster should agree. But the evidence is that as far as hard endpoints are concerned, in a patient with stable angina, initial PCI and initial medical treatment are comparable. Though both treatments, bypass surgery, angioplasty, medical treatment, obviously, if you ask the patient, he will choose a non-invasive procedure. He will prefer a PCI over bypass surgery. He may prefer a medical treatment over PCI if you present to him this data. Thank you.
Thank you very much, Professor Bahl. I think it was a brilliant talk. Very critical data analysis. And I think ultimately your conclusion was that we have to individualize our patient, because most of these patients are vulnerable, in the vulnerable age, with a vulnerable plaque, with vulnerable hemodynamics, and vulnerable hematology. They may have CKD and resistant hypertension and so many issues. And I think, Dr. Bahl, I think you gave a very good point on COMPASS trial. And I was listening to Deepak Bhatt only this morning. He gave, though it is not approved by FDA, rivaroxaban, low dose, 2.5 milligram BD, both in PAD as well as CAD, especially the stable angina. And the data is very favorable. I think we'd like to have your comments. What do you think the future is going to be? Along with the new medication which we can give, will rivaroxaban will be an agent of choice to reduce the ischemic burden and taking into consideration of cognizance of the bleeding also? Dr. Bahl, sir.
See, there are three new pathways which have been opened for a patient of stable angina as far as medicines are concerned. One is the thrombotic pathway. We always knew this may be a pathway. As you rightly said, the fear was it may produce a bleeding. So when they use a low dose of rivaroxaban with the aspirin, they did not find the bleeding is more, but you have to be cautious. The second pathway is the inflammatory pathway, as was shown by interleukin 2 inhibitors, canakinumab. But canakinumab was very expensive, to the extent that this company who makes canakinumab did not apply to FDA for stable angina. But we have a poor cousin. The next study was methotrexate, which failed, but the colchicine has shown promise. It may come into guideline, but it will be 2A guideline. It won't be kind 1A because the mortality rate is still debatable. The third pathway which is open is the very low reduction of LDL safely by PCSK9. Suppose tomorrow you have inclisiran or PCSK9, which is cost effective, and you have to give an injection every 6 months, and you can reduce the LDL to 55, 30, 35, and maybe you can take care of the coronary stable plaques. The plaques don't rupture and you don't produce acute coronary syndrome. So the vistas for medical treatment is all open. So is for angioplasty. But we know that we have reached a peak as far as angioplasty is concerned. We don't have now anything more as far as stents are concerned, though there are thinner struts. We failed on BVS. Maybe the newer generation of BVS will come. We know the technology. If you keep on adding, say, FFR, you keep on adding OCT, you keep on adding IVAS, the cost escalates, and with a very minimal benefit. Yes, it shows the anatomy better, but whether that translates to MACE, we have to have a large trial to show the mortality reduction, because in stable angina, the problem is mortality is already so low that to reduce it further, you have to have thousands of patients. Nobody will conduct that trial. Ischemia was our last hope, and ischemia did not show the positive results. Now you can beat the data. You can say it's a peri-procedural MI. But if you tell a patient within first 2 years, you are more likely to have MI or may die. But subsequently, if you survive, your chances of having an MI will be less. Will he accept? It is how you present it. Most of the time in India and other parts of the world, we say patient preferred. Whether how you put to the patient matters. So this is the evidence. I'm not saying the evidence is perfect, but this is the evidence which is available. We have to go by the evidence. Rest is our belief. We want to believe that PCI helps. Yes, in a type A lesion, if you have a type A lesion, you think you can do an angioplasty within 5 minutes without any complications. Look at the Orbiter trial. FFR, 4 patients developed dissection even by putting a wire. You can say those patients were not a very experienced operator, but they were patients who were enrolling for a trial. So they must have taken all the precautions. So every invasive procedure comes with a price. So you have to look into all these factors and individualize. Yes, you individualize the patient and tell him maybe scoring system will help, as he was showing yesterday that, but you have to have a prospective data. I am sure after 5 years, if it tanks, they will have another scoring system 2030. Who knows? Because they are changing the goalpost very frequently. And all of us are responsible for that, because we personally believe that angioplasty helps, and it does help, because in acute coronary syndrome, it has helped. Now people are trying to use even for unstable plaques. If you can diagnose unstable plaque, even if it is not obstruction producing, you take care of by doing an angioplasty. So this field is open.
Dr. Goswami, Sumitra Ray, and Dr. Mandal, please.
May I have a comment? Dr. Bahl, as usual, it's a great learning point by listening to your lecture, and the slides are so well organized. I have got very, very short 3 comments and your take on that. Number 1 is that all those trials which were comparing the symptomatic relief, medical treatment versus angioplasty, had average 2.2 of anti-anginal used. Now we have got so many anti-anginal, including ranolazine, trimetazidine, ivabradine. Whether we will apply those and an average patient takes 3 or 4 anti-anginals, whether angioplasty will have a benefit, even for symptom relief, we have no evidence. Number 2, at the same time.
First comments, yes, I fully agree. We do not know where to put these newer so-called anti-anginals. I am sure. That's why I said there are hardly any patients in which stable patients they are untractable angina. You are right.
Exactly. Second, sir, in Indian scenario, there is an opposite scenario. In angioplasty now, almost everybody gets it either free of cost or insure covered. But to get a 4 anti-anginal for next 10 years, nobody is covering you. Insurance does not cover outpatient treatment. So that calculation is different in India compared to a Western country. So maybe
your second comment is what we reduce is only a nitrate. We continue to give statins, we continue to give antiplatelets, we continue to give, if we believe in ACE inhibitors, we continue to give beta blockers. So maybe we reduce the dose of beta blocker and stop nitrate. That is what we do. Rest of the
other anti-anginals, they are pretty expensive. Trimetazidine, ranolazine.
Yes, maybe.
And thirdly, sir, what you said with this target LDL cholesterol, near anti-diabetic, antiplatelet, anti-hypertensive, event rate is so low in a stable chronic coronary patient. To show a difference between 2 arms of treatment is very difficult, sir, nowadays. Be it CABG, be it angioplasty, be it medicine. So I think it should be left to individual patient choice. But as you said, that the patient should know the proper data, not a biased data by the clinician.
My only problem is, suppose we were comparing 2 medicines. We would have believed the data and gone for the medicine which is showing a better results. But because this is a procedure versus medicines, we do not want to believe. We may be right that and nobody can produce the data differences because the mortality rate is so low. Statistically, you have to do 30,000, 40,000 patients. Who will recruit them? So ischemia was the only hope, and I don't think ischemia in future will be repeated. So we have to go by the evidence or by our knowledge of which we have accumulated over the years. Because if you don't learn from the history, you are doomed to fail again.
Yeah. So can I add something here?
Yes, please. Yeah, please.
Okay. So first, I must say that Doctor, his talk was perfect, and it told us absolutely the right message. Dr. Bahl has given us the right message that in stable angina, we all know now that it has not been shown that PCI leads to any substantial benefits. And of course, we had the benefit, and that is why we are extrapolating that benefit of ACS and STMI, where actually it was the reverse. So the only thing, for the first time, angioplasty was shown to be effective in reducing mortality, putting stents in acute MI. So we are in the middle of I think it's an evolutionary phase maybe, and maybe we are evolving, and maybe a combination of drug therapy and angioplasty could be a solution in these kind of patients. But certainly at the moment we will say that optimal medical therapy is the best way to go. It's class 1 for patients with a stable angina, and even CABG, if it is of course proximal LAD or a very high syntax score, very complex patient, then, and with low ejection fraction, then these patients get benefit with revascularization by CABG.
I agree.
And, you already opened.
Now, only thing I feel better is after reading this evidence is while working in the government sector, we don't feel by putting the patients on medical treatment, we are doing inferior job.
Absolutely.
So otherwise it used to be that we have not opened a small branch, another person has opened it. So we used to feel guilty that we have, because of money, we could not provide the optimal treatment. So optimal treatment is not a poor cousin of angioplasty, at least that everyone.
Of course there is. So it is for relief of angina only. If the patient is not getting relief, then only you can do it. So that is the only indication of doing it in stable angina, I will say as of now. And the last, one of the other points, which is that the NT-LP PLA studies actually, which failed initially, but I think one.
You're not audible, Praveen, to me at least. I can't hear you, Praveen.
Praveen.
May go away.
Sorry, Praveen, I couldn't hear your last.
So the last point I was making, that NT-LP-PLA inhibitors, which were initially tried, and that a TIMI52 study was done, and that was about 7-8 years back when it got published. And at this time, many trials were actually stalled because this pathway could not be taken further. But still, the research is on, and because that is for plaque stabilization. And it says that if you can stabilize the plaque, then events happen.
Yeah. If you read the first interview by Grunzik, historically, somebody asked him, what is the future of PCI? You can crystal ball. He said that I see a stage when non-invasively vulnerable plaque will be imaged, and then we will put a stent in proximal LAD, proximal RCL, left vein, and nobody will get an myocardial infarction. I think we are reaching that stage.
Yeah.
We are going to now diagnose vulnerable plaque. People are already tried putting stents in those vulnerable plaques so that myocardial infarction can be prevented in the prospect trial. So we may reach that stage by medicines or by so-called wonder stents which dissolve and don't produce any side effects. We are
Dr. Bahl, I have got a question to you.
Yes.
Do you think that this approach is same and pertinent to India as well as it is in the Western country? Because in the Western country, suppose a proximal LAD 90% lesion, we treat it both the places with adequate, medications. But still the patient has a massive MI. Now the patient is in Asansol, which is 250 kilometers or more than 200 kilometers from Kolkata. And there is no cath lab there. So they have to come from there. And by the time anything can happen. So should the approach be same? I think we need to have a, randomized trial in our country before committing something, which is because we are following blindly the Western, teachings, which is not pertinent to our country. I think the situation is quite different.
Coming from a leader from NIC who should be involved, CSI should be involved in such trials. But how can put the counterpoint? You put a stent, patient goes to Dhanbad and gets stent thrombosis. He's doomed. So this can happen. These are hypothetical situations. We can't deal with them. But yes, why not do a randomized trial in India? And I think in ischemia trial, 18% patients were recruited from India, because in rest of the world, there were hardly any patient they could get. That's why they had to change the goalpost. Even before publishing the result, they had to add more endpoints. They had to add, instead of the TMT was not first the ischemia indicator, they had to add the TMT. because it's very difficult to find the patients. No, if you tell a patient you have a proximal LAD, whatever I have given, but if there is a proximal LAD, you tell him there is a this trial, that trial, and any patient, any doctor tells him, see, you have a 90% disease and you can get, this can get occluded and you can die, he will go for a procedure. I'm sure it will be very difficult to convince the patients. So we take advantage of that. It is a very crude term to use, but we have to present all the data and let the patient take a choice, which he cannot take because he doesn't know the whole data. If we discussing in our forum cannot arrive at a conclusion, how the patient can arrive at it. But I think this only shows that we should not chase every small lesion. If somebody does a 90% proximal LAD, I have no questions. If he does OM3, PLV, PLA,
definitely.
That is the problem. So at least these trials will stop them from doing this.
Sure. Thank you very much, Professor Bahl, for your excellent lecture and for excellently answer all the queries, all the questions in a brilliant way, which you have been always doing. I also thank all the chairpersons present over here for their excellent comments, excellent deliberations, and it was a very, very good session. I thank you, everybody, and I think it's time we should proceed to STEMI interventions, and it is to be chaired by Dr. Shomir Dani, Dr. Thomas Alexander, Dr. Justin Paul, Dr. Subhash Chandra Banerjee, Dr. Subhash Chandra, Dr. Shivananda Datto, Dr. Shubhro Banerjee. And the expert panelists are H.S. Mardikar, Dr. C.K. Pandey, Devashish Ghosh, Sharad Chandra, S. Ramakrishna, B.P. Chatterjee, Saroj Mondal, and Jayanto Saha. So I hand over the mic to the chairperson, my respected chairpersons. So who is going to take the call?
So good evening. Good evening.
Yeah, Justin, please go on. Yeah, Justin.
It is my pleasure and privilege to we invite all of you for this wonderful session. After a great talk on stable CAD interventions, now we move into an area where there is a proof that angioplasty is the treatment of choice, and it has to be the treatment of choice in 100% of the patients. So what are the issues that we need to look into in this area? We have a great session ahead of us, and the first talk of this session will be by Dr. M.S. Hiramath. He'll be touching upon the area where PCI in STEMI, whether it's a multi-vessel or culprit lesion only, an area there has been evolution of guidelines and changing of parameters, and newer data have been coming till this year. So Dr. Hiramath, the mic is yours.
Thank you, Justin, and good afternoon, everybody. So this is an area, as Justin said, which have been swinging from one end to other. We all trusted that primary angioplasty is a better way to go compared to thrombolysis. However, pharmacoinvasive approach is also not too bad. And now the data is also emerging that in certain cases, pharmacoinvasive approach can even be superior. On that front, let us see if we are going to be better off doing just the culprit, or we are going to do the multivessels. So this is a case, young fellow at age 38. We have done the primary angioplasty to the LAD, and 6 or 7 years later, he has come with cardiogenic shock, gross ST elevations in the anterior as well as inferior leads, and predictably has infarct in the big circumflex as well as infarct in the LAD territory. So under these settings, we have no option but to go for both the vessels. And this is how we did an emergency angioplasty to the occluded stent as well as the occluded circumflex. Probably the occluded circumflex gave him a severe hypotension looking at the distal circulation, and that's why he had a thrombosis in the LAD, and it was probably not a primary LAD thrombosis.
So this was a case, no option, and you have to go for multivessel. In another case, patient came with just minimal changes in the inferior lead, and we thought we are dealing with an occluded distal circumflex. So probably nothing may be required. A patient could be managed with intracoronary lytics. However, as we gave a small dose of T and K in the coronary, we realized that there were two very important big-sized OM branches. You can see OM2 here and a distal OM here. So obviously, it's very important. Once you take a PAMI for the cath lab, I think the dictum is you must end up with an angioplasty. So we had to place a stent here. But look at the approach. Here you can see the ostial LAD, the distality of the left main. They are all diseased, including the proximal circumflex. So once we are faced with this, we are talking of a culprit lesion here, but there are lesions on the way. So to take a stent position here, we had to go through all these and thus ended up putting one stent here, provisional on the side branch here, and another stent from circumflex to first OM, and another stent from LAD to left main. So under these kind of situation, where presentation is a primary angioplasty, you are forced to put multiple stents. However, we are talking of this kind of situation where you have a juicy lesion in the right coronary artery, you open it up, huge circulation, patient stabilizes, going home. Another similar case, you have a perfect result on the right coronary artery. And both these patients, though the presentation was very drastic and with a severe hypotension, they picked up immediately after doing this. And the LAD stent was done on the next day, second day. So it was a staged angioplasty. So on one side, we have a culprit done on one day and angioplasty to the other vessels on the next day or 2 days later in the same hospital admission. While in this case, LAD was the culprit, but it opened up so easily that we had the courage to go for RCA, which looked like a CTO, and we opened the RCA2 in the same setting. In India, sometimes it becomes a cost issue, and that's why we take these kind of little chances. CTO, I would not do, but this was easy-looking CTO, and then that's why we did this. However, this is an inferior infarct, and look at the right coronary artery. It looked very, very diseased, and the left system is also heavily diseased, lot of calcification. And this patient was actually managed with staged angioplasty done about 5 days later. In this particular case, there was an infarct from the LAD territory, and we then had to do an FFR after stenting this. We did an FFR towards LAD, towards circumflex. Both were positive, as you can see here. So we had to revascularize the left main bifurcation during acute stage. So we ended up with a culotte stenting to this left main bifurcation, having stented the infarct-related LAD vessel. This was a right coronary artery infarct, 1998. He was lysed. Then when we took him up for angioplasty, there was lots of thrombus in the entire length. So we gave intracoronary lytics followed by GP blockers, and then maintained him on oral anticoagulations for a few months. He presented 10 years later, and this time the RCA is looking good. Mind you, this was not stented, it was just aspirated, and lytics were given, and it is looking still very good. But this time he has an infarct from the circumflex, which is flowing, but again, an easy lesion to stent. So we stent this, and we also have a totally occluded LAD, which is like a CTO. Now, whether you're going to do this CTO in this admission, or whether you're going to call him back and do an angioplasty at a later date, or maybe a hybrid Lima graft to the LAD, since it's a total occlusion. So we are trying to answer these kind of questions. We have had many studies in last many years, and there have been multiple discussion on these issues. But let's talk of this complete study, which actually looked at the timing of staged non-culprit revascularization in STEMI. So we are talking of complete revascularization versus culprit artery lesion revascularization. And whenever we talk of index hospitalization, culprit is of course done, but the non-culprit is done as a staged procedure, and sometimes you may do it as a one-sitting procedure. So this group, they had it in a short time, one day, while the other group, after discharge, average median was not for non-culprit revascularization was 23 days. These were some important issues like syntax score. After the index PCI was done, that means the culprit was done, was pretty low. The post non-culprit lesion index syntax score was again very, very low. That means it was a good, successful thrombolysis. And the you can see here, if you do culprit only, the cumulative incidence was better with the more complete revascularization. And even after discharge, same holds true that the complete looks much better. And now, when to do complete is again a discussion issue. But if you do it during the index procedure, there is a clear difference when you do complete revascularization compared to culprit only. And this benefit persists afterwards too. After discharge, also this benefit persists. So when you compare complete versus culprit only, you can see complete looks better on all fronts. Most of the time when you're trying to do complete in one go, that is along with the culprit vessel angioplasty, we are worried with contrast that we use. However, in these, there was no difference in the renal parameters. So when you talk of the landmark analysis between first 45 days and after 45 days, you see culprit and culprit only and complete, not too much different here. But after 45 days, you can see the curves widening, and the benefit from complete clearly holds true. This is again the complete giving you a benefit. As years go, the benefit seems to get better and better. So in conclusion, we could say that performed during hospitalization, like that is on the same day or maybe next day, and compared with done a little later on the third week or fourth week, the benefit looks about similar. The benefit of complete revascularization on the hard outcome, CV death and MI, emerges as mainly over the long term. So this difference between complete and culprit only, the difference is getting stronger beyond 45 days. And there were no statistically significant differences in the safety outcome. That means you can do all these multi-vessel quite similarly. If you see some of the analysis of the earlier study, this is actually 8-year registry, culprit only versus multi-vessel. And you can see the multi-vessel, the all-cause mortality, all-cause survival is better. The MACE-free survival is also better. And repeat revascularization is much less with multi-vessel. That is a complete angioplasty. So overall, the swing is back towards doing multivessel angioplasty. So here the conclusion is multivessel PCI of the non-culprit lesions in patients with diagnosis of STEMI may reduce adverse clinical events. This is another publication in JACC this year, looking at the complete versus culprit lesion only revascularization for ST elevation MI. And you can see that the STEMI complete revascularization, the mortality is less compared to the culprit only. So today, when you have this kind of combination in front of you, culprit is addressed very well. So think of doing the other vessels only if your culprit has gone very well. Like in this case, you can see an excellent main vessel result, and you can see a good distal blush also. So in these kind of cases, you can think of going to the non-culprit vessels. You have an LAD, and you can do an FFR on this LAD. FFR is positive, whether to do the LAD at the same sitting or to call him back after 2 days or 3 days. It's entirely up to you. But generally, we like to call them early. So what looks important on angio sometimes may not be all that important. Like here, the flows are there. It's not a total occlusion, but the right artery, which looks not too bad, actually has a FFR, which is very importantly positive, while circumflex, which looks important, does not have a positive FFR. And LAD, of course, is the culprit. So when you fix this LAD following an anterior MI as a primary angioplasty, do an FFR. I would feel FFR reliability has some issues during acute setting because of microcirculation, but at least do an FFR so that when on day 2 morning or day 3 morning, you know what patient requires. So here, in this case, there was only one vessel to be revascularized, which was done later. So in this 87-year-old doctor, he had anterior wall ST elevation, but he was lysed by his son immediately within about 10 to 15 minutes. And this is the image. You have a critical lesion in the diagonal, which is a big vessel, 2 branches, but again, a disease in the mid-segment, which is a long lesion. So here we do an FFR to the LAD, and this was negative. And we class this patient for medical treatment, considering this is diagonal, considering his age was 87. So FFR is an important help when you are dealing with a primary vessel. You do an FFR. You may or may not act on that FFR immediately. But like in this case, LAD is culprit, an important triple vessel lesion. However, the RCA FFR is negative. So after doing the LAD, we had no difficulty in fixing up the circumflex, and right was classed for medical treatment. So this is again a primary angioplasty to right coronary artery, important lesion in the circumflex, and you can see the LAD at one particular focal spot is critically narrowed. However, this again was a negative FFR, and we ended up stenting only the circumflex. So a lot of changes are taking place in the thinking of these individuals. So this was important lesion in the LAD, and this was a lesion which I didn't want to do myself because when you do ostial circumflex, the possibility of ISR is going to be sizable, and I didn't want to complicate the issue by bringing the stent back. So again, we took help of FFR, which helped us conserving the circumflex lesion. also factors which influence decision not to perform multivessel
Dr.
stent.
Hiramat, sorry to
Yes.
intervene. You are 2 minutes over time. Please conclude
Already?
if possible.
Okay.
Yeah. Thank you.
All right, so we'll come to the end, and thank you indeed for being with us, being with me.
Thank you.
for
Thank
this.
you very much.
Thank you.
Thank you very much, Dr. Hiramat, for outlining the advantages of doing multi-vessel PCI during STEMI over culprit vessel type of strategy. And I'm sure that we are going to be discussing this more in detail at the end of the session. And there were some very interesting points thrown open by you, including the use of FFR in identifying the culprit lesions. But before we discuss all that, we will quickly move on to the next talk, and that is how to choose non-culprit lesions optimally in primary PCI settings. And that is by Dr. Praveen Chandra. He doesn't need any introduction, dear friend of ours. And Dr. Praveen Chandra, the stage is yours.
Thank you. Thank you, all of you, on this Sunday afternoon sitting here and discussing this very, very important topics of initially stable angina and now acute MI. So Dr. Hiramat has already set the stage, and my next presentation is also similar by my colleagues on the issue of treating the other vessels in patients who are undergoing primary PCI. So I'm taking it for a little further. And so the question is how to choose the non-culprit lesions optimally in PCI setting. So there are so many ways we can do it. Of course, one of the ways is that we do a angiographic, visual examination of the patient, of the angiogram, and then make a decision whether you want to do it or not. And if there is a very critical lesion, certainly you would plan to do it either at the same time if the procedure is done well, or subsequently in the index hospitalization, or later on once the patient is a little bit more stable clinically. For example, if the patient is in LVF or is in pulmonary edema, certainly you don't want to do all that at the same time. So now FFR is one of the modalities which has been examined quite intensively now with a couple of trials which have been done. So I will be basically discussing a little bit more in detail of the role of FFR in patients of acute coronary syndrome and acute MI. So the reliability of FFR has now been kind of settled, and the cutoff points are almost similar, which is 0.75 and 0.8 when we are dealing with the non-culprit vessels. Now the question is, if it is safe and if it is accurate, why not do it in all patients and then make a decision? So I'll go through the data as to how it has been studied. So the assessment has been done, and as you can see here, that the values remain unchanged between acute and follow-up. So that study has been done when the FFR was done in the acute phase, and then also done in the follow-up phase in these patients who are having primary PCI to the culprit lesion. So which means that if you want to do FFR at the same time, you can do it. It is safe, it is feasible, and certainly in FAME trial also, a large number of patients, 32% patients actually had had a non-STEMI also. And so that is why we can rely on this data a little bit quite extensively. Now, the question is when to do this, how to do this. So there are three, basically we can divide it into three, ways of strategy. One could be an aggressive strategy, which means you do all the multi-vessel PCI acutely in the same setting. And then if you do it in the same setting, you do it either angio-guided or you can do based on FFR, because we already know that FFR is a reasonable thing to do in these patients. Now, the second option can be that we do it as a staged procedure, which means you do a primary PCI, as Dr. Hiramat already showed us, that you do a primary PCI and then you can send the patient back to the ward, let him recover for a few days, and then do the intervention after that. So that could be a staged PCI, and that also can be based either on angiographic analysis or on FFR. And the third option can be that we do be conservative, as we do in stable angina patients, that you treat the primary PCI for the culprit lesion and then put them on medical therapy, and based on ischemia or symptoms, if they are not getting controlled, we can do a angioplasty in these patients to the non-culprit lesions. So we already have the data on these two aspects. One is the conservative therapy, which is the study which you already know for last many years, the primary study and the CV culprit study, where the treatment of non-culprit lesions was compared between these two strategies. Now, the question is, what about these strategies? Have they been compared? Is there studies available? Yes, the data is now available from the compare acute study, the dynamic pre-multi study. As you can see, FFR guided comparisons, and now also we have studies. So first, let me take you through the dynamic pre-multi study, where we compared this infarct-related artery-only treatment to complete revascularization based on FFR. And here there are 300 patients in each arm, and as you can see here, that there was a difference in the endpoints of these two strategies, and it was found to be significant. And as you can see here, the p-value was 0.004. So basically, it resulted in a lower risk of primary composite endpoints of death, non-fatal MI, and ischemia-driven revascularization as compared to the standard care. Now, this was a reasonably positive study in favoring that, yes, you can try this strategy. So then a couple of studies which were embarked upon after this, and this is the compare acute study, where, again, pressure wire guided revascularization was done in these patients. And here these were, as you can see here, about 885 patients were enrolled in this study, and FFR was measured in rest and after adenosine, or intravenous or intracoronary in these patients. And then they were randomized into two groups. One is acute FFR guided complete revascularization of non-infarct-related artery, and the other group was where the treatment was done in the 45 days window of this FFR being done to these patients. So what did we find in these patients? There was a significant difference in MACE, which is any first event, and this you can see here. So those patients who had infarct artery only treatment had a higher MACE compared to those patients who had FFR guided complete revascularization, and the p-value was significant. And this was primarily driven by the revascularization events happening in these patients in the comparing the two groups. The other trials which have been, and one of them has already been mentioned, the complete trial, which was just presented and published recently. It was published in April this year, and it was presented in October and September and October in ESC, and this was presented by Dr. Shamir Mehta, and this also showed. So I'll just share with you the results. And the last study which is going on at this time is the full revas study from Sweden, where 4,000 patients to be enrolled, but actually the study was stopped at 1,500 enrollment because we got two very important results from compare acute and complete, and then they decided, the steering committee decided that the study should be stopped, and the enrollment has to be stopped, and of course the analysis will continue, and then we'll have the results of this this analysis a little early on. So this is the the complete data which was published in NEJM, and showed that there is a significant difference in the culprit lesion only PCI compared to the complete revascularization PCI, as you can see here, and the p-value is 0.004 in both the primary outcomes and the secondary outcomes. So what was the result of this trial? The important outcome was that in patients with STEMI and multivessel disease, complete revascularization was superior to culprit lesion only PCI in reducing the risk of CV death or MI, and as well as the risk of CV death, MI, and ischemia-driven TLR. So here this is a little bit different from the results which we had earlier on. And here it also shows that even if you take out the revascularization, still it is significantly positive towards complete revascularization guided by the fractional flow reserve. So finally, what the guidelines are saying, because this study came a little later and the guidelines were a little earlier. So we have this 2017 guidelines saying that it is reasonable to do the FFR in these patients, and if it is abnormal, one can do appropriate treatment for these patients. So these are the ACC/AHA guidelines, as you can see here. For non-culprit artery revascularization during the index hospitalization after primary PCI is rated as appropriate and reasonable for patients with one or more severe stenosis or for asymptomatic patients with ischemia findings on non-invasive testing. And in the presence of intermediate severity non-culprit lesions, FFR certainly is a good idea to be done, and the decision can be taken with that. So there is an evolving evidence around non-culprit stenosis revascularization that it may be appropriate after primary PCI in selected patients who are asymptomatic. That if the lesion is more than 70% stenosis, and in patients with intermediate stenosis severity, FFR testing, if it is abnormal, we can do this procedure. So that is the recommendation. And let me take you through some of these interesting examples. This is a patient who comes with unstable angina, and when we do angiogram, we find this kind of thing. So the patient is ACS. So now what should we rely on? Can we rely on FFR only, or we have to do something else? So now there is a concept of combining imaging and physiology together in these patients to make the right decision. So this is a left main. So if you don't, now we have a left main lesion here, and if we don't assess it properly, this patient, as Dr. Kahali was discussing and my other colleagues, that if we leave this patient and they go back their home, they can have a very catastrophic event. So we have to be sure. So we do FFR in this patient, it is 0.76, which means it is positive. And then the issue is how much can we rely on this? So here we see that we do a OCT also in this to combine the benefits of these two technologies to make the right decision for this patient. And if we look at this OCT, everything looks okay. And with the OCT ACR, we can really accurately identify where exactly this is happening. The lesion, we'll see it right bang at the ostium of the LAD with some kind of a tissue eruption over there, and that is probably the point of acute coronary syndrome. And this patient is then treated effectively with stent implantation, going from the LAD into the left main, and of course the patient did well after that. So the decision making can depend upon these. So these are the variations we can bank upon based on the technology which we have. Then another case, here you can see these are routine run-of-the-mill cases where you see these kind of multiple lesions. So what you do? And this is a young patient where he has a LAD lesion, he has a circumflex lesion, and then of course the culprit lesion is the right coronary artery. As you can see here, it's a very huge artery. So we do the RCA, we do the FFR, and find out that the LAD is 0.86, LCX is 0.84, and the RCA is of course treatable. He has to be treated, and he goes home with just one stent. So that is the benefit of making the decision in these patients, because in young patients, you don't even want to put too many stents. So that is something which is very important. And likely here you see that this is a patient with a LAD lesion in the middle, and then what you do with the LAD, but there's the culprit lesion is the RCA. So we do the RCA, and many people will be tempted to do the LAD also at the same time because it looks very simple. But after doing the RCA, which turned out to be quite straightforward, we did the FFR to the LAD, which was 0.83, and we sent the patient home, and he did very well after that. And the LCX also was tested, which is 0.92. So basically, I think these are the case examples which I wanted to share with you, and then of course, I can just finally conclude that FFR-guided complete revascularization in non-culprit arteries leads to improved outcomes in short and long term, and the procedure can be either staged or done at index admission or within the next 45 days. So that is the present situation, and I'm sure with the full REVAS study from Sweden, we'll have much more data to support this approach. Thank you very much.
Thank you, Dr. Praveen Chandra. Indeed, that was a great talk. I think we should really appreciate the way the talks are scheduled. We had Dr. Hiramet talking to us on whether we should be doing multi-vessel or culprit only in STEMI. Then we had Dr. Praveen Chandra talking to us on if we are deciding to do the multi-vessel, how do we choose the non-culprit vessel? Now we have Dr. Subhash Banerjee to tell us if we have decided to do the non-culprit and we have chosen the non-culprit, when do we do it? Do we do it straight away or do we do it as a gap? Dr. Subhash Banerjee, the podium is yours.
Thank you very much. Thank you for inviting me. This is a fantastic lecture series and I'm really enjoying it. I think the topic about how and when to time the non-culprit vessel revascularization in STEMI is an interesting one, and my previous speakers have already alluded to some key facts. Let me start off with my disclosures, and I'm going to start my presentation with demonstration of two cases, one which is very similar to ones enrolled in the complete trial and other that is more from clinical practice. So this is a 77-year-old male with an anterior ST segment elevation myocardial infarction. He also has stage 3 chronic kidney disease and post-traumatic stress disorder. The LAD is clearly the culprit, as you can see here. A picture of the, and you also see the secondary lesion in the left posterior lateral branch of the circumflex, and also disease in the right posterior lateral branch of the RCA, and very distal disease in the posterior descending arteries. The patient undergoes, this is a second view of the left posterior lateral branch of the circumflex. The patient undergoes a successful stenting procedure of the mid-LAD culprit vessel. You have spent 18 minutes of fluoro time and about 80 cc's of contrast via femoral approach, and the baseline syntax score, syntax 1 score of this patient is 18. Now the question I would like the audience to consider as I move through my presentation, which one of these following options would be advisable and you would conduct in your practice? Option A, perform immediate left posterolateral branch PCI, planned left posterolateral branch PCI in 2 weeks, post-discharge test perfusion imaging guided revascularization, optimal medical therapy, and no planned left posterolateral branch PCI, and of course, imaging guided identification of thin cap fibroateroma to guide your PCI approach. So give it a thought as we move through this presentation. I'm sure the talk by the previous speakers would be illuminating in arriving at the right conclusion. This is a second patient which probably would not be enrolled in the complete trial or would be limited by it. This is a 67-year-old diabetic male who already has baseline peripheral artery disease, presents with subtle changes in the anterior leads, and the emergency room activates our STEMI team for an anterior STEMI. The patient has stage B cardiogenic shock. He's on low-dose pressors, and his lactate levels are not available to us. His baseline syntax score is 24. I wouldn't describe you all the lesions for this audience. I think it requires no explanation that there is disease in the distal left main, ostial LAD, circumflex, and also in the mid-RCA. You can also gauge the motion of the cardiac silhouette to imagine that his overall LV systolic function is severely depressed. The question now here is, what are the options for this patient in terms of revascularization? Would you refer this patient directly for coronary artery bypass grafting? Or you would perform a mechanical circulatory supported PCI of the left main and LAD, support, hemodynamic support, and PCI of the left system completely, both the left main LAD bifurcation and of the circumflex, or you would include the RCA into it, and finally, you would just do the left main and LAD PCI with IV pressors. These are a lot of complicating questions. And the reason I highlight these complicating factors is because the decision regarding timing of non-culprit vessel PCI is not such a simple one. And I'm sure my esteemed colleagues before me have used the word in carefully selected patients. So I would like to drive your attention to those words. And what does careful selection actually means? So I've tried to highlight, not all, because this slide would not suffice, but some key factors that play into our decision of choosing the right patient. I think one factor that is critical to consider is the presentation of the patient, and amongst various presenting factors, the presence or absence of cardiogenic shock is very critical. Second is that we do pay attention to the type of lesion, whether the non-culprit vessel is a chronic total occlusion, the complexity of the lesion in terms of severe calcification involving major side branches of bifurcation, and also the amount of myocardium that area supplies. So these are all implicit factors that we assess when we perform the angiogram after the culprit vessel PCI. The timing is also important, and I call these immediate, staged, and deferred. Immediate would be during the same procedure or in the same hospitalization. Stage would be within 3 to 4 weeks, and deferred would be where you would not actually plan that procedure. One factor, which I think Dr. Kahali alluded to in one of the discussions I heard this morning, which was very pertinent, is that the patient level factors cannot be discounted. Do you know all about the patient when you're taking for STEMI? Are you aware of non-cardiac comorbidities before we put in 4 or 5 stents in a patient? Are we aware of other factors that could complicate the compliance of the patients, and notwithstanding the assessments of socioeconomic factors, which could be crucial in in making such decisions? So I think I again applaud my colleagues for bringing up the careful selection of these patients and not completely be guided by angiographic appearances of lesions. Let me repeat some of the key findings, but I will try to drill down a little deeper into the most landmark of trials that has provided us with the key evidence in this area, in addition to many prior smaller studies. One thing that distinguishes the complete trial, that it was very well powered, including nearly over 4,000 patients. Now, you should also see very carefully on this slide that apart from the median 3-year follow-up and the use of a co-primary endpoint of both composite cardiovascular death or new myocardial infarction, and the second composite co-primary endpoint was death, new myocardial infarction, and ischemia-driven revascularization. But another key factor in this study was the stratification based on timing that was performed based on the visualization of the angiogram that was done by the operator. So the stratification of timing was not done based upon some key pre-procedure factors, but it was done completely based upon the intent of the operator. And that is a very important factor to consider while interpreting the results of this trial. Here are the results of the study that have been shown before. On the panel onto your left shows the co-primary endpoint of cardiovascular death and MI. You see the separations of the curves, and the number needed to treat is 37 in terms of preventing cumulative incidence of these hard endpoints. If you include ischemia-driven revascularization, the number needed to treat over 3 years is only 13. So a substantially larger benefit is gained in terms of avoiding future revascularization procedures. Now, if you look at the second paper published from the study, following the New England Journal publication, this one is in from Jack, I really want to highlight what I had mentioned earlier, is the stratification based on the timing of the non-culprit lesion revascularization per patient, per physician intent. And I think that is quite key. And this was done before the procedure, and then the patient was randomized between the culprit or staged PCI after the culprit vessel revascularization was successfully completed. And that is, I think, a very key take-home point of how the decision points of this study was actually executed. I think Dr. Hiramat pointed to a very important factor of the study, which I think is highlighted on this slide, and that is that patients with a baseline syntax score exceeding 22 were not included in the study. And the operators did a very good job in reducing the syntax score to low levels, as you can see. Most of the non-culprit vessel PCI were in the severe in the severe range, although the study, like Dr. Ravin Chandra said, did allow FFR-guided approach in these patients, and most patients had a primary PCI through radial access with a high proportion of thromboaspiration. Here are the co-primary endpoints based on the stratified analysis based on the timing of the procedure. As you can see on these slides, whether the non-culprit vessel PCI was performed during index hospitalization or after discharge, the benefit of complete revascularization was preserved. I should also add here that 2/3 of all operators enrolling in the trial stratified or intended to perform the procedure, the non-culprit vessel intervention, during the index hospitalization, again, which highlights how carefully these patients were selected. In terms of the landmark analysis, in terms of benefit from randomization, as you can see that the benefit of the study of the outcomes was actually seen after 45 days. In the early period, the cardiovascular death and MI rates were superimposed, and the benefit was observed slightly later. Finally, the benefit of complete revascularization was preserved in terms of cardiovascular death, MI, and ischemia-driven revascularization, both if the non-culprit vessel revascularization was performed during index hospitalization or after discharge, of course, by including the revascularization as a co-primary endpoint. You see that the magnitude of benefit is greater and the hazard ratio is even smaller. Now, this is a very interesting slide, and I would like to stop on it for a few more seconds. On the x-axis here is the years of follow-up, and on the y-axis is not events, is actually number of events preserved or prevented with 100 patients treated. And if you see very carefully, the magnitude of the benefit in terms of the number of patients, number of events prevented is far greater if you include the benefit of complete revascularization with respect to cardiovascular death, MI, and ischemia-driven revascularization. So I think we need to interpret this very carefully in the sense that the overarching benefit is, of course, for cardiovascular death and MI, but an incremental benefit is gained in preventing future revascularization procedures. The penalty for this, as we are all concerned about major bleeding and contrast-induced nephropathy, the rates of these events were fairly marginal and low and expected, under 3% for major bleeding with both complete and culprit vessel PCI, and the incidence of contrast-induced nephropathy was also not extremely high. So I would like to, before I proceed, I would like to say that although these results are extremely promising and exciting, one cannot conclude that the timing is immaterial as long as revascularization is complete. And I say this because there is an inherent bias in the study because of stratification that was based on physician intent and not on a key pre-randomization patient characteristics, which we are very used to during stratified randomized studies. So I think this is one factor that we nearly always need to include, which again speaks very loudly and reiterates the point that my illustrious speakers before me, Dr. Hiramath and Dr. Chandra, have quite carefully alluded to, and that is that there is no replacement for a physician's eye in carefully selecting these patients. Now, let me turn my attention to the second type of patient angiogram I showed to you. In the other important trial of complete versus incomplete revascularization in STEMI, although small, the culprit study also showed very important data, and this is a sub-study of the culprit study, which is the culprit shock, which is a randomized trial of multi-vessel PCI in cardiogenic shock with the primary study endpoint of all-cause mortality or renal replacement therapy or need for renal replacement therapy. And you see the endpoints of the primary endpoints are on the y-axis. In this study, mechanical circulatory support was used nearly in a third of patients. About 80% of patients were mechanically ventilated, and non-culprit vessel chronic total occlusion was in a fifth of these patients. And you can see very clearly that in this setting, the benefit of a non-culprit vessel, immediate multi-vessel PCI was not realized. And the overall event rate were actually higher, and the differences were statistically significant. Although I would point out that the number of patients included in the study was fairly small. Now, I have tried to put together the cumulative evidence that was shown by my previous speaker, that is the evidence from compare acute, PRAMI, DINAMI, and complete together. And in terms of this very important meta-analysis, where the median time of non-culprit vessel PCI was between index admission and up to 45 days after the initial PCI, there was a benefit in terms of reduction of cardiovascular mortality with immediate revascularization compared with staged. Second was that the effect of timing of complete revascularization on the rates of future myocardial infarction was realized in both groups, whether it was done immediately or it was done in a staged fashion, again, highlighting the benefit of complete revascularization. And the third is that if, like Dr. Chandra elegantly presented, that if in the setting of an acute myocardial infarction or STEMI, we do not intervene based on a non-critical FFR value, we are not going to subject that patient to a higher risk of future myocardial infarction. And I think that the top panel of this meta-analysis speaks to it loudly. Now, this is a survey that was conducted in 2010, and I intentionally picked this paper of 1,800 interventional cardiologists speaking about multi-vessel PCI in STEMI patients. I show this because each one of these factors remains relevant today. And on the top of those factors was renal function as adjudicated by our colleagues, and the contrast used, the lesion complexity, and of course the patient symptomatology, including with LV function, patient reliability, patient age, penalties for readmission, and insurance status. I think all of these factors have to be taken account before this complex decision is made. And I think these factors remain relevant today. Here is the completion of our cases. As you can see in this particular patient that I showed with a culprit LAD and a non-culprit lesion in the circumflex, this patient actually underwent immediate PCI to the left posterolateral branch after successful PCI of the LAD, and this would be a very typical patient enrolled in the complete trial. And I think the simplicity of the lesion and the fact that these patients are the types of patient with a mean syntax score between 13 and 15, which would be highly likely to undergo a non-culprit vessel immediate or during the same index hospitalization. And here is the overall final results of the angiogram. 96 cc's of contrast, additional 16 cc's, and a 4 minutes of more additional fluid time was used in this case. Now, let me show you about the second case. This is our other patient. I showed you that he has a RCA lesion and a distal circ lesion, and the culprit is in the distal left main in the ostium of the LAD with poor LV function. In this particular case, we opted for mechanical circulatory support, but intervening on the left main LAD and circumflex. And I can tell you that although the data speaks against it, this decision was made based on a series of factors that I think you will all appreciate. Number one, the patient had very poor vascular access. This is the occlusion of the distal aorta and the occlusion at the level of the left common iliac artery with very slow flow and severe diffuse disease down to the common femoral artery on the left side. The right iliac artery is completely occluded. We actually opted in this patient for mechanical circulatory support. A left axillary impeller was placed, and the PCI was performed and proceeded with a 7 French catheter from the right radial with a slender sheath. And because the LAD and the left main would be jailed forever, I think we actually decided for a more complete revascularization of the left side. And the results are shown here. And the residual syntax score was reduced to about 7 or 8 in this particular case. Again, as this is the reason I'm showing this case is to illustrate that the timing of the non-culprit vessel PCI and the complexity of factors that need to be included cannot always be substantiated by one randomized clinical study. And the technical factors along with the patient factors have to play a very, very important role. So in conclusion, I want to say, again, as my previous speakers have said, that complete revascularization is superior, has been shown to be superior to culprit-only strategy in STEMI with multi-vessel coronary artery disease undergoing primary PCI. I would like to highlight that the endorsement of these by the guidelines is slightly higher at the European level than at the ACC-AHA level. Second is that the non-culprit PCI with the aim of complete revascularization can be performed and can be equally successful and beneficial for the patient if in carefully selected patients it is performed early, either during the same hospitalization or within a median period of 23 days after discharge, and it confers similar benefit on major cardiovascular events. Finally, the safety is not compromised in terms of higher risk of major bleeding or contrast-induced nephropathy in carefully selected patients. And finally, the STEMI and cardiogenic shock patient is a different subgroup. And I think in this particular case, contrary to my case that I've shown, the culprit vessel PCI has been shown to reduce composite endpoint of mortality or need for renal replacement therapy at 30 days. And finally, I can tell you that as expert clinicians, all we are, and our responsibility to guide our future generations, I think there is no substitute for careful patient selection and solid clinical judgment and a rational interpretation of the clinical evidence before us. Thank you very much. I'm delighted to be here, and thank you for inviting me at your meeting.
Thank you very much, Dr. Subhash Banerjee. That was a great talk indeed. Now we touch upon an area of cardiogenic shock in STEMI. Now, STEMI is causing the cardiogenic shock. Which one to treat first? Should we touch upon the shock aspect of it, or should we touch upon the thrombotic lesion aspect of it? We have none other than our good friend Ramesh Dagubati to talk to us on what do we treat first. Is the shock or MI, STS score? Dr. Ramesh, the podium is yours.
Oh, thank you very much, Justin. It's a great pleasure being here. Could I share my screen, please? Okay, thank you for letting me do that. So I want to congratulate Dr. M.K. Das, Dr. Kahali, Dr. Roy for having these presentations organized in such a way really relevant to the current literature and the current audience. So STS score, what do we treat first, shock or MI? I think S2S actually means shock to support. I have no disclosures. So here is a 60-year-old man with cardiac arrest, return of spontaneous circulation in cardiogenic shock. I think you have to think about when should we treat this patient and how should we treat. So his EF is low, and now what? A balloon pump, impeller, ECMO, or just a straightaway PCI, or all of the above, or just inotropes and leave the patient alone. So at least in our center, what we do is we enroll them in a door to unload study, which I'll talk to you about. We place the impeller, and we don't even shoot an angiogram actually now, because this was a patient before. Now we place the impeller for half an hour, and then we do the angiogram and then PCI. So it's purely based on EKG, ST elevations, and then unloading the left ventricle. So what do the guidelines say, actually? So let's start off with guidelines. And as you know, all mechanical circulatory support devices, including balloon pump and other devices, are all class 2B recommendations now. And so we have no great evidence to say that balloon pump or impeller should be implanted ahead of time. So the current paradigm focuses on primary reperfusion in acute myocardial infarction with or without cardiogenic shock. That's what we are always used to. And we have this rush of going to door to balloon times. And it did make a huge difference in door to balloon times. The sooner they come into the hospital, within 3 hours of their symptom onset, the better it is. And if you can get the balloon, the vessel opened up with the balloon. And it's always actually, we're trying to say we should supply oxygen to the myocardium as quickly as possible. Against what is the question? To improve myocardial reperfusion, lessen the myocardial reperfusion injury. So if we look at the amount of myocardial salvage that could be achieved, obviously more than 6 hours, there is probably no benefit at all to do PCI. But within 6 hours, we can definitely, by moment of time, the door to balloon time, there's a greater benefit of myocardial salvage that we can achieve by doing early reperfusion. So how early is early, and whether we can really shorten that much time? Patients with shorter door to balloon time results have better outcomes. We know that, as I said, less than 6 hours. And as you can see, the line touches, if it anything from symptom onset to balloon time is less than 3 hours. And there is definitely a great benefit. But between 0 to 2 and 2 to 3, there is no big difference. And the door to balloon time, once you achieve almost less than 90 minutes, and now most of us are going to 60 minutes, 0 to 60 minutes versus 60 to 90 minutes, 61 to 90 minutes, there is hardly any difference here, okay? Not statistically significant. A reduction in door to balloon did not improve survival. We know that since 2005, we were able to come down on the balloon time from 83 minutes to 67 minutes. In people more than 75 years of age, we were reduced door to balloon time from 92 to 73 minutes. And in cardiogenic shock from 88 to 69 minutes as well. So in anterior MI, it is 86 to 69 minutes as well. So if you look at the mortality in the red, it has hardly changed anyway among all these groups of people with anterior MI or even with the more than 75 and in cardiogenic shock patients. So despite getting very excellent door to balloon times, we are not making an impact on their mortality times. So what is the gap? So there has to be something that we are not understanding, because ideally, so door to balloon times are improving and we are not even seeing a major change in their times, okay? So why did a reduction in door to balloon time is not resulting in better mortality? Maybe patients with longer door to balloon times die because they're sick to begin, and takes longer to get the sicker patients to the cath lab. Most patients present to the lab about 3 hours, more than 3 hours after symptom onset. And that's why there's a flat part of the myocardial salvage curve. And most patients who die after MI die from arrhythmias, ventricular fibrillation. And open artery is always the best therapy for preventing ventricular fibrillation. A few minutes delay in PCI does not alter the likelihood of PCI success. And these are all the debating points. A patient who has VF prior to PCI usually gets resuscitated, as my patient had. So how do we improve? That's a big question, right? The physiological rationale for door to unload has been brought up, saying that myocardial oxygen supply versus oxygen demand, we have to balance out. Maybe we are just improving the oxygen supply with opening up the coronary occlusion, and as we discussed, the multivessel disease being treated or not, and maybe avoiding systemic hypotension with inotropes. So, but on the other hand, by doing all that, we are not concentrating on actually maybe controlling the heart rate or reducing the LV stroke work and the wall stress. So maybe that is something that we can do better here and limit myocardial ischemia by first limiting this oxygen demand. So understanding myocardial oxygen demand actually comes from several trials in the animals rather than humans first. So how can we move this pressure volume loop which is there, and that is the stroke work, to the left side, meaning reducing the stroke work index of the left ventricle. And so animal protocols have shown that actually you occlude the artery for 90 minutes, and you go ahead and open up the artery and assess the infarct size, versus actually occlude the artery for 90 minutes and then keep the impeller CP on for another 60 minutes, and then actually open up the artery and see what happens. So this is primary unloading versus primary reperfusion. So, and assess the infarct size. And this is done with by a good friend, Naveen Kapoor at Tufts. And they found that actually that unloading has works, definitely did not cause, number one, harm, and it improved the amount of infarct size that actually is found in these patients. So here is the LV wall stress. In people who had primary unloading, we were able to move the curvature to the pressure volume loop to the left, which actually was beneficial for those patients. And whereas primary reperfusion strategy, they went to the other side. And as you can see that in the white is the unloading, the baseline to occlusion to reperfusion, definitely the wall stress on the left ventricle is much significantly lower in the reperfusion, unloading group strategy than in the reperfusion group, in the primary perfusion group. How about infarct size? As you can see, primary unloading reduced the infarct size. This is about 70% to about 40%. And as you can see, primary unloading does have an improvement in reduction in the infarct size. What type of, this is another group which studied with the control, no devices. This is percutaneous left ventricular assist device, which is the impeller here, versus a total LVAD surgically placed. And they found, Dr. Sakhu found that actually better than control is either of them. The best is actually total left ventricular assist device in terms of reduction in CKMB. Infarct size is much lower in the left ventricular assist devices that are placed. But percutaneous LVAD, such as impeller, did much better than the control. So this has been shown repetitively in animal models by different labs. Sun Lab and Mainz Lab have shown using sheep or pig that better than control is a left ventricular assist devices in the white to reduce infarct size repeatedly. So then, similarly, we thought actually let's try to see what happens in human beings. So we did we understood that time is muscle. Myocardial stunning is probably reversible. We are increasing oxygen supply by opening up the artery, but probably we have to concentrate on increasing, reducing the demand of the heart muscle, and primary unloading we might actually protect the myocardium and helps in recovery. And by actually reducing reperfusion injury, and further on after 30 minutes, we can supply more oxygen by doing opening up the occluded artery. So rapid unloading is very important in these patients. So there has been a lot of registry data that we looked at in the CVAD that we have a ventricular assist device strategy here, and with the percutaneous devices and using impeller, whether they were placed before PCI versus after PCI, you can see that definitely pre-PCI made a difference in those patients. And then actually on support, if you do the PCI, before support, if you do the PCI, the systolic blood pressures were lower. Then actually on the device, the systolic pressures are much higher. So mean arterial pressures were high, diastolic pressures were high, as well in people who had an impeller. And freedom from death in impeller placed before PCI was much higher, about nearly 55%, as compared to post-PCI. After doing the PCI, patient is still in shock. And if you do an impeller, the mortality is still very high. And the freedom from death here is about a 20% survival. So inotropic requirements is much higher in people who have assist devices placed later. So it is better to place the impeller first, and then you do not have to increase the number of inotropic devices, as you can see. And these were presented by Parvez at TCT. So maybe we need a time for paradigm shift in trying to actually acute coronary occlusions with cardiogenic shock, undergo LV unloading first, and then a primary reperfusion strategy. This is being tested even though in anterior wall MIs right now, but we first did a pivotal feasibility study. Our center is one of the large enrolling centers in this trial as well, from West Virginia University. The first FDA IDE trial looks at door to unloading, and it was found to be that unloading is safe in these people. So now we are doing a larger study, which is actually a great study. Patients with the STEMI with the anterior ST elevations, more than 4 millimeters acute ST segment deviation in the anterior leads. First MI, age 21 to 80 years. If they present within 6 hours of symptom onset, we immediately get an informed consent, and they're enrolled and randomized after doing a peripheral angiogram of the femoral artery to make sure that they have good vessel size, and then we do an LV gram and to see if the EF is low, and patients are then randomized either to unloading and then primary PCI versus immediate PCI, and as soon as you put the impeller device. And we have to explant the impeller after 4 to 6 hours, and infarct size by CMR 3 to 5 days and 30 days post-PCI. So the primary endpoint here is infarct size at 30 days by cardiac magnetic resonance imaging. And we just recently enrolled our fourth patient 4 or 5 days ago. She went into the unloading arm, which she tolerated quite well, and we did not have any problems. And her MRI has already shown to have some improvement. So we should not just concentrate on one part, which is the balloon, door to balloon time, but cardiogenic shock is complex. We need to both reduce biventricular congestion as well as cardiogenic shock to improve the end organ perfusion in these people. So as SKY has started actually staging cardiogenic shock now, at least it is very good to see that different types of stages. A is people who are at risk, extreme people who are really have no other option and they're going to probably die. And whereas the people in the middle from B, C, D are the ones that actually probably improve if you treat them early with the mechanical circulatory support devices. As you can see that in extreme, that means refractory cardiogenic shock, how much ever we do, the mortality is high. So there are probably C and D are the people that we can try to bring it to B by acting early and improving their survival. So if you see in a PA catheter, does it make any difference by people with the SKY stage C and SKY stage D kind of shock? Yes, it does make a difference. Here is a no pulmonary artery catheter versus pulmonary artery catheter in the bold. There is a big difference in reduction in mortality in all patients, whether they're in heart failure, especially in cardiogenic shock in SKY stage D. MI patients also, it makes a difference in people who have a PA catheter. So why is cardiac unloading important? I think we are trying to reduce blood returning to the heart, decreases pressure and volume in the chambers of the heart. The heart does not bloat up, and reducing left heart pressures rapidly decreases lung congestion, and reducing right and left heart pressure improves cardiac output and end organ perfusion. And unloading also will improve the urine output, and cardiorenal unloading is, I think, is going to be taken into effect. So in several algorithms have come now in most centers in the United States, and actually there's a national cardiogenic shock initiative, and this is one such algorithm from a different center close to us, but we also have our own algorithms. And looking at cardiac power output and the wedge pressures, one can make a decision. Our protocol algorithm, actually by using immediate devices, has reduced the mortality from 44% to 24%. And most of that usage has been with the impeller device. And so we looked at that. Actually, initially it was only 26 patients, but then we analyzed that per quarter from 2012 all the way to 2016. And now every quarter, there are about 100 patients that are increasing. Our observation to expected mortality is much lower. Okay, so the amount in the dotted line, you can see the mortality is coming down despite the number of patients that are coming to our center is increasing. So in National Cardiogenic Shock Initiative as well, using such a algorithm, the mortality has come down. Is there a score that we can think about in a shock to support? In IABP shock to score, there is a variable that they looked at, and they are the lower points that you get, meaning younger people, no stroke, non-diabetic, and not in cardiogenic shock by lactate or creatinine elevation, they have a better mortality. So we will be working soon to get a score for probably shock to support. So in conclusion, in dealing with the acute MI and cardiogenic shock, in the current era of mechanical circulatory support devices available, I think an appropriate device or patient selection algorithm should be applied to improve clinical outcomes and optimize utilization of resources. In India, probably ECMO should be the first one, along with a balloon pump, because impeller is expensive, but that is something that we're also looking at over here in probably in the future, and trial with the ECPella versus balloon pump and the ECMO. I'll stop here, and I'll be happy to take any questions. Thank you very much for this opportunity.
Thank you so much, Dr. Dagubati. And I think in the interest of time, we'll move to the last talk of the session, and then we'll have some discussion. So we have seen the STEMI intervention, how to stage the non-culprit lesions, when to do it, whether to do it or not, and how to select it. We have also seen that cardiogenic shock with STEMI is a totally different subset. And we are now going to talk about another subset, and that is STEMI with left main. So intervention in STEMI with left main lesion, and we have with us Dr. Fazila Malik. Would not waste much time. The stage is yours, Dr. Fazila. Please start with your talk.
Can you see the slides, please? Hello?
Yes, we can.
Yeah, right.
Very
okay,
well.
Thank you. So, chairpersons, friends, and colleagues, it's indeed a great pleasure and privilege for me to be here today. I'm Fazila Malik, and I work at the National Heart Foundation Hospital and Research Institute, which is a tertiary cardiac care center in Dhaka, Bangladesh. We started with a single cath lab in 1999. At present, we have 5 fully functioning cath labs. And when we see patients who have STEMI, and on top of that, they have left main disease, often when they come to our cath lab, they have a dramatic presentation. And such was the story of this 43-year-old gentleman who was rushed to our cath lab in a collapsed state. The ECG, which was done in the emergency, showed that he had ventricular fibrillation. After defibrillation, he developed complete heart block. Temporary pacemaker was done. And as CPR was going on, angiogram was done. The heart left side was totally occluded from the left main, as you can see. And the heart was barely moving. CPR was going on, and in that state, we managed to give intracoronary adrenaline. We managed to wire the vessel, and we did balloon predilatation. After balloon predilatation and the intracoronary adrenaline, the heart sort of jump-started, and we then proceeded to put 4x12 drug-eluting stent in the left main. And this patient, I'm very happy to say, walked home alive 4 days later. And this is his check angiogram done after 21 months. It's spot on. And this case was done more than 4 years ago, and this patient is asymptomatic. So how common is ST segment elevation MI with left main disease? Well, STEMI with unprotected left main artery culprit lesion accounts for 0.8 to 1.2% of all primary PCI interventions, and retrospective studies have identified cardiogenic shock, TIMI 0-1 flow, or cardiac arrest as the main prognostic factors for an unfavorable outcome. So studies have also reported that when you do a CABG in these patients instead of PCI, you tend to get better outcomes. Why? Because the higher frequency of complete revascularization in CABG as compared to PCI results or translates to better outcomes in this setting. But let's face it, in a patient who's so severely sick or has already had a cardiac arrest, to arrange an emergency CABG right on that spot might be a somewhat daunting as well as challenging. And what happens if a patient who had already had a CABG developed STEMI and comes to the hospital? And such was the story of this gentleman who had CABG done 3 months back. He had been given a Lima to LAD graft and a graft to the PTA. The patient presented with an inferior lateral MI and he was in cardiogenic shock. So we wired the vessel, did thrombus suction, and then we took a single stent from the left main and we deployed it. And this is the final result that you see after stenting, and you can also even appreciate some competitive flow in the LAT. So CABG might be theoretically the best option for patients with unprotected left main and STEMI, but it might be challenging to do that right on. So when a patient suffers from STEMI and has left main disease, the outcome of that patient or the mortality on 30 days follow-up depends on what kind of collaterals did he have, or whether he did or did not have collaterals, and on the TIMI flow. So if the patient has TIMI 0 to 1 flow and is in cardiogenic shock, then the 30-day mortality can be as high as 84%, according to a recent study. When, however, there are collaterals present, then the mortality, 30-day mortality comes down to 60%. Now, this is the story of a young gentleman who came to us with cardiogenic shock, and he had no collaterals. And you can see his Lima is left main coronary artery is totally occluded with thrombus. We wired the vessel, we put in an IABP, and this was done 6-7 years back, and we've done thrombus aspiration repeatedly, temporary pacemaker has been put, and then we stent the vessel as well. And this is the final result that we get. And unfortunately, this patient did not make it. He died 48 hours later. So cardiogenic shock, TIMI 0 to 1 flow, no collaterals, that's very, very serious and very, very carries a very bad prognosis. In STEMI patients, if the TIMI flow is good, the prognosis is a lot better. Like in this extensive anterior ST segment elevation myocardial infarction patient, he presented with cardiogenic shock. He had a 40 to 50% stenosis in distal left main with thrombus. LAD was totally occluded with thrombus from its origin. After wiring, thrombus suction was done with thrombus aspiration catheter. Immediately after thrombus aspiration, this is how the vessel looked. We gave the patient intracoronary adenosine as well as intracoronary adrenaline. We then proceeded to stent from left main to LAD with a 3.5 by 30 drug-eluting stent. We deployed it at 12 atmosphere pressure. We noticed that there was significant plaque shifting to the LCX origin with TIMI 1 distal flow. So here, even though we were looking for a single stent strategy and we wanted to keep the thing simple, we had to go for a double stent strategy, and we did a tap technique here. We did final kissing with the same balloon. This was the final result. And this patient also survived and is now under follow-up and is doing fine. So patients with ST segment elevation MI, thrombus and unprotected left main are a very high-risk subgroup, obviously, particularly when they present with cardiogenic shock. PCI is something that we can do for these patients and is usually associated with a reasonable good outcome. A recent study showed that in their study, the hospital mortality was 32%. And in their study, they showed that the long-term prognosis is excellent in hospital survivors with an 89.5% one-year survival rate, which is pretty encouraging. Now, sometimes left main coronary artery disease can have very, very complex anatomy. However, the initial complexity of the coronary artery disease and the need for revascularization has not been thoroughly investigated as outcome predictors in this group of patients who come with STEMI and left main disease. However, it is generally advocated that provisional stenting should be the preferred strategy due to the presumed risk of embolization when many devices are manipulated or when we opt for a complex strategy. Now here, this patient had STEMI with distal left main quadrification disease. So pretty complex anatomy, you would agree. So after wiring the vessel, we did thrombus aspiration. And after thrombus aspiration, the vessel appears to have cleaned up somewhat. And then we proceed to put a 4x24 drug-eluting stent from the left main to the LAD. So even in this complex anatomy, our aim was to keep the procedure as simple and as short as possible. We do proximal optimization and we start the patient on GP2B3A receptor blockers. He tolerates the procedure well, and he makes it and can be discharged 72 hours later. And this case was also done actually quite a few years back. And this is the final result. Now this patient was very, very sick. His heart was barely moving. He was in complete heart block. We did a temporary pacemaker, got the guide catheter, and we found that the left system was totally occluded with thrombus. The entire left system is occluded, in fact. So we wired the vessel quickly, did thrombus aspiration. Our wire went into the LCX. After aspiration, we gave intracoronary adrenaline, and intracoronary adrenaline in such dire situations really does help in many instances. Our heart started contracting a bit more efficiently. The patient went into cardiac arrest. He went into respiratory arrest, had to be intubated, CPR had to be given. We then managed to deploy a 3x24 millimeter stent from left main to LCX. The flow was established, and again we gave intracoronary adenosine, adrenaline. Blood pressure was not recordable. So we gave the patient, we put in the intra-aortic balloon pump. After some time with the inotropes, intra-aortic balloon pump, the patient did manage to get a blood pressure recording. We shifted the patient like this to the CCU, and 7 days later, actually, we could discharge this patient. Now, 4 months later, he came back. We wanted him to come back earlier, but he came back 4 months later, and we did his angiogram again, and we found that he had a non-dominant RCA. However, this RCA was giving good collaterals to the LAD, and the left main to LCX was well revascularized. The LAD, as we already had understood, was totally occluded from its proximal proximal segment, but it was getting the collaterals. Now, this gentleman opted for CABG. He underwent CABG, and this was also done like 5 or 6 years ago. And at present, he is symptom-free, but he's under our follow-up. So actually, we started doing left main PCI in National Heart Foundation since 2007 on a regular basis. Up till August of this year, we've done more than 2,200 left main PCI cases. And regarding STEMI, the one thing I have to explain to you is that Heart Foundation is a tertiary cardiac center, and we get lots of patients from different parts of Bangladesh. And, yes, please. And so from 2007 to August 2020, we had 5,208 ST segment elevation MI patients coming to our center. Of these patients, we did primary PCI to 1,437 patients. Of these 1,437 patients, we had ST segment elevation MI patient with left main disease in 228 patients. So 228 patients had left main disease with acute ST segment elevation MI, of whom in 30 patients we did primary PCI. So in 30 patients, they came within the time frame for us to do primary PCI. The rest of the patients came from different parts of Bangladesh. Some had undergone pharmacoinvasive therapy. Some had not even received that, had just received anticoagulants and antiplatelets and had subsequently come. And the mean time frame of their arriving to our hospital was 30 hours. So of these patients, 228 patients who came with STEMI and left main disease, as you can see, the vast majority, 75% of these patients were above the age of 50 years. And regarding sex distribution, 87 were male. Risk factors, these patients were really, really sick with multiple comorbidities, and more than half of them were diabetic, and around 64% were hypertensive. Regarding the ejection fraction, more than 80% had some or other form of impaired ejection fraction. We've managed to follow up these 228 patients. 9 patients were lost to follow-up. And we did symptom-driven check angiogram for 22 of these patients. And we found that ISR had developed in 2 patients. Our overall MACE is 12.3%, which is, I suppose, pretty good. And so with these few words and with our experience, I would like to say thank you from the entire team of National Heart Foundation for giving me this opportunity to present ST segment elevation MI in patients with unprotected left main disease. Thank you.
Thank you, Dr. Fazila. It was indeed a great talk. And ladies and gentlemen, you'll all agree that we had a great session, wonderful talks, which really called for a great discussion. However, in the interest of time, we are restricted to 1 or 2 comments from the expert panel only. So I would like to request the expert panel to offer any comments from your side.
Good evening, sir. I think it was wonderful talk by almost all the speakers. I think one major consideration that is there in our Indian setting is most of the patients who are undergoing primary PCI are either funded by some state government insurances or by out-of-pocket expenses. So how to ensure immediate complete revascularization in all of them? If whether the state we should represent do an advocacy with the states to enable that.
I think there's a great thought for CSI to take it forward. I think we should sit and work on this and formulate guidelines as to, or make a request to the government or on this aspect.
These circulated are good. They make logic, but some of the trials are not able to show benefit. Is it because of the trial, or is it because of the way it is used?
I think it's both. The way it is used. We have to make sure that we don't get the peripheral complications. We should look at the size of the femoral artery before implanting, and also patient selection. The moment that they're in refractory shock after more than 6 hours being in shock and multiple pressors, I don't think we can make any difference in them. So I think this is what our most important point is, that symptom onset to cardiogenic shock time, and as well as making sure that we can do it safely, safety and efficacy.
I'll just make one point about the timing of the interventions. We all agree that the stage PCI and all lesions at the same time and only culprit. We look at the three groups only, but the stage PCI, I think it was one large registry, about 6,000 patients. The British Columbia registry, which looked upon all lesions at the same time, then lesions and the lesions. And what they really found that was doing all the lesions at the same time was much inferior to doing the rest of the non-culprit lesions as a staged procedure during hospitalization. Would you like to make any comments on this, Dr. Subhash?
Absolutely. I think that's a great point. And I think that the British Columbia registry also was able to clinically classify those patients. They did the Euroscore and the Syntax 2 scoring that takes into account clinical factors that always could not be accounted for during the immediate PCI of the patient. So I do definitely agree that an immediate, we have to use the terms very carefully. In literature, the word immediate is applied to both ad hoc PCI at the same instance and during index hospitalization. The median time in the complete trial was about 1 day. So I think we have to be careful. So this word staged, I think, should be applied to when the patient leaves the hospital within 23 median days, and the immediate should be applied to either ad hoc or in hospital. But I agree with you that a lot of the patient careful selection can be made better if the patient comes off the table and comes back this next day. So if there are no other comments, thank you very much, ladies and gentlemen, and my co-chairpersons and expert panel members. Over to the team. Thank you.
Okay, thank you very much for very successful session, and all the speakers did so well, and it was a very lively discussion, and the points are very well taken, and the chairpersons and moderators were also excellent in their comments. So our next session is a very important one, that is PCI in COVID era. Yesterday in USA, the total number of patients affected is more than 99,000. And in our country, there is no testing, so the numbers have decreased dramatically from 97,000 to 48,000. And just to tell of an epidemiologist concerned, day before yesterday in a very national busy channel, India Today, Dr. Joy Prakash Moli told that the actual numbers probably are 28 to 30 times. That means approximately if we have now 10 million people suffering, the total number is 280 or 290 million people affected. And he also commented in the national channel along with Dr. Guleria, he of course didn't tell it, he is the director of AIMS, that, Dr. Moli commented that probably we are going towards herd immunity. We don't know what is going to happen to all of us, because every alternate people we are seeing that they are being affected, or every alternate families are being affected. So it's a very, very important, very, very important disease now, and this pandemic is taking its toll. And I would invite the chairpersons, none other than Professor Manutosh Maja, Dr. B.P. Singh, Professor Praful Kerkar, Dr. Alok Mojumdar, Professor Bijoy Bang, and Dr. Soumitra Ray, and Dr. Amol Khan to chair the sessions. Our expert panel constitutes Dr. Devanu Ghoshrai, Dr. T.K. Prohoraj, Dr. Aftab Khan, Dr. Devobroto Roy, Vishwajit Bojumdar, Dipankar Ghosh Dostidar, and Dr. Ashit Das. So you please take over, Professor Paja, and conduct the session. Thank you very, very much. টোটাল স্টেশনে এসে গন্ডগোলে ফেললে কখন থেকে বলছি
Dr. Panja, you need to unmute yourself and get started.
In respect to time, may I just start the session? We have got eminent speakers over here, including our CSI president, NIC chairman, past NIC chairman, who not. So it is a star-studded session. And let's have the stargazing now. We start the session with our president, Dr. Mrinal Kanti Das. Mrinalda, you please start.
Yeah.
Dr. Panja will join in time.
Yeah, am I audible?
Yes, sir. You are audible.
Good evening, everyone. It's a great opportunity that CSI could start this initiative, educational initiative for these coronary interventions. And in the last session, we had fantastic lectures on basically the various aspects of PPCI. And that was mostly in the peace time. Now, what happens in a war? Actually, we are fighting a war against COVID-19, and PPCI in COVID-19 is a different animal altogether. And my topic is actually PPCI in COVID, the thrombus burden, and other issues.
Kindly click on your slide and kindly click on your slide and move, sir.
Which one?
Just click on your slide, sir.
Yeah.
Just move your mouse on the slide, it will start moving. Yeah, now you move, sir. Yeah, yeah.
Okay. So okay. You can imagine that the definition of the COVID is also a bit different: acute, manageable, immunogenic, thrombogenic, inflammatory, viral, notifiable disease. So this thrombogenicity is a very, very important factor in this COVID scenario. Now, while we are discussing the various aspects of the MI and their management, we must remember this universal definition of MI, especially the various classification in terms of type 1, type 2, type 3, type 4, and type 5. And one must also remember the implication of the biomarker, especially the TROP-I and TROP-T, in the diagnosis of acute myocardial infarction and differentiating it between myocardial infarction and the type 2 that is due to the myocarditis. This is one of the cases that was done by me during the initial period after COVID, that is in the month of June. And actually, it is showing the total occlusion in the left system, that is the LAD. And this was a plain case because after the wire was put, actually there was somewhat a restoration of the circulation, and ultimately the balloon dilatations at different levels were done, and the stent was put, and there was good circulation, TIMI3 flow. So this was in the COVID time, but the result was very encouraging in that scenario. But what is coming out from the London registry study, as I am presenting this particular case from the London registry, actually, when the patient presented, that time on admission, there was no much significant change in the ECG. But after the admission, the patient again started the chest pain, and that time these were the changes in the ECG in the form of bundle branch block and acute ST elevation. And you can see that the LAD system was totally cut off, and the patient was gradually becoming unstable, and the patient had to actually undergo the intercoronary TNK, infusion, and also the patient was given intercoronary adrenaline, nitroprusside, and all other measures that are done for no reflow phenomenon. And after that, there was actually this picture which came out, lot of thrombi in the whole artery. And the patient was stented. But what happened after stenting, after some time, there was again this ISR, and there was also occlusion in the left coronary LCX system. And that resulted in a very, very critically ill situation in the form of hemodynamic deterioration, and patient had to ultimately undergo IBP insertion and also intubation, and the intercoronary thrombolytics was again given in the artery, and all other measures were also taken, and patient was somewhat stabilized. Now, in that period, actually, in the early period of the COVID situation, CSI came out with the position statement where we categorically defined into 3 groups, A, B, and C, with confirmed, suspected, and low probability of COVID cases. And in our scenario, where there was heterogeneity in the overall logistics, we recommended, if of the thrombolysis, if the patient comes in an unstable state also within 12 hours. Of course, the PCI was recommended all the time if the facility and feasibility were there. But what came out surprisingly after the London study was that they found more incidence of hospital mortality and more incidence of large thrombus in their studies. And as compared to the Hong Kong study, actually, which we in India followed because of the early period. And that's how the characteristics of the ST segment elevation MI in COVID-19 infection had various facets in the form of stent thrombosis, multivessel thrombosis, then thrombus burden, modified thrombus grade 4-5, and myocardial blast was also much reduced or altered, and significantly D-dimer was very much attributable and was very much significant in those conditions. So just to summarize those kind of things, that is the large coronary thrombus burden with hypercoagulability were the most important signatures, but there were other risk factors which are also associated with these, where the deep venous thrombosis, pulmonary embolism, disseminated intravascular coagulation, and stroke among patients with COVID-19. However, as I highlighted that the COVID-19, the D-dimer was very much diagnostic. That's why it was attributed as a rainbow phenomenon, where various kind of informations were gathered, or various kind of manifestations were there in the form of non-obstructive coronary artery disease, large thrombus, multivessel involvement, stent thrombosis, and myocardial blast. And of course, there was the various insights that came out in the form of opportunities, challenges for PPCI during the pandemic, and various recommendations that were supposed to come. And this was also supported by the North American COVID-19 STEMI registry, where also they found more hospitalization, more thrombotic lesions, presence of microthrombi, frequent non-culprit lesions, and more likely to have medical therapy. Rate of PCI was comparable, however, but the high mortality was very much obvious. And in that background, actually, CSI started collecting the data, and this is the results are still unpublished. They are going to be published very soon, and the results are quite surprising as compared to the Western, the Western literature. And I'm not going further about the CSI data, but definitely the mortality that was highlighted in Western literature was not available in our setup or in India. Now, why is that so much complicating? Because of these various factors, especially the immunological reactions and the hypercoagulability, which ultimately actually makes an unstable plaque further amenable to the rupture, and ultimately the huge thrombus burden is affecting the whole system in a very, very deleterious manner. With that background, actually, the various guidelines, apart from the CSI guideline also, the ESC guideline also put forward where primary PCI was and fibrinolysis both were recommended as per the feasibility and as per the considerations in a particular patient. Same way in the ACS also, the fibrinolytic arm was definitely given more chance, but whenever there was a possibility of the unstable status with the right kind of coronary anatomy and the right kind of time duration the patient is presenting, the immediate invasive strategy was recommended. And cardiogenic shock was definitely a negative factor, and more pulmonary infiltrates were requiring mechanical ventilation in COVID scenario. And in the confines of pandemic, actually, there are other issues which were very, very important. And that we might actually highlight this in this form, that hospitals were overwhelmed after the COVID scenes and failure to prioritize the patients in terms of care. Logistics were compromised. PPCI, though known to be very helpful in fixing the coronary artery disease, but the pneumonia, thus, not the pneumonia, and thus delaying the potential intubation, prone ventilation, which actually cause increased mortality in many a patient. And of course, last but not the least, is the lack of understanding on thrombus and vigorous care in peri-procedural period. And that's why this is to summarize that the various mechanisms of coagulopathy and pathogenesis of thrombus, which I have already highlighted, are giving rise to the disseminated intravascular coagulation, of course, the myocardial infarction, venous thromboembolism, and cardiogenic shock, and very critically ill patient. And they can be manifested in different ways in the form of arrhythmias, coronary events, thromboembolic events, and of course, the heart failure. So what is the take-home message? The take-home message from the whole episode is that there are two schools of thoughts. One on one side, actually, we the CSI proposed something, and on the other side, the Western literatures, they propose something more in favor of PPCI, but we focus more on the fibrinolytic plus pharmacoinvasive therapy. Of course, letting the PPCI to be adopted whenever it was feasible. Now, patients with COVID-19 infection are at a specially enhanced risk of inflammation-triggered thrombus burden. The management of AMI complicated by extensive thrombus burden in patients with COVID-19, though favors PPCI as the choice of therapy, but at the present time, it is still not clear because of the number of patients studied were low, both in the London registry as well as the American registry. For the FMC to door to balloon time pathway, depending on the logistics of a country, is a very, very important factor which we must take into consideration. Best procedural techniques are to be adopted. Cost effect consideration must be made before deciding on which kind of therapy, whether PPCI or pharmacoinvasive therapy or only fibrinolytic therapy, are to be taken into account. And choice of adjunct pharmacotherapy is also very, very important, because the following the PPCI or following the fibrinolytic therapy or the pharmacoinvasive therapy, you'll have to follow the optimal medical therapy along with the anticoagulation for the betterment of the patient's survival as well as the morbidity. Thank you very much for patient hearing. I am really thankful that our team, especially Dr. Dhiman Kahali as the chairman and Dr. Debabrata Rai, the interim treasurer, have done really stupendous job in formulating the whole this program, in making this program a successful one. Namaskar.
Well, thank you. Thank you, President, sir. That was an excellent talk on what havoc thrombus can play in this COVID pandemic whilst dealing with acute myocardial infarction. Next, we have a very practical session We are now fairly adjusted to doing primary PCI, and we have none other than from Delhi, my good friend Dr. Anil Dhal, who's going to tell us the practical tips about how to handle, how to ensure a good personal protection whilst you are in the cath lab trying to deal with this thrombotic state and the acute MI. Over to you, Anil.
Thank you so much, Praful, and I think we must thank Dhiman, Mrinal, and Debu for really getting us all together. It's good to see each other and see that everybody is safe. So really, most of what I had to say has already been covered by Mrinal in his usual gustful fashion with a lot of energy. So we all understand that this damn virus, the collective weight of which must be less than 2 grams, has brought the entire human race to its knees. And really, we are dealing with an unprecedented syndemic. And what is really crazy to understand is 102 years and nothing has changed from the last influenza pandemic till 2020. We still have nothing better than stay at home, wash your hands, wear masks, and that's about what we've been doing. And today's census in the John Hopkins register is something which is, and this is again, like Minal pointed out, an understatement. I mean, people are obsessed with figures, but these figures actually probably talk about the decimation of the human race. And we all understand the illness. The best part is that a large amount of your infective population may have mild to moderate symptoms, would not desist from meeting people, and also the other bad point, unfortunately or fortunately, is that less than 5% of the illness is going to be critical, with a mortality of 1 to 3%. Unlike the SARS or the MERS pandemic or the epidemic, where the mortality was much higher. So we have a large amount of asymptomatic infectious pool with a vulnerable population, which are all our patients. And these damn tests are not really conclusive, and we haven't really moved much in 102 years, and atypical presentations don't spare anybody. World leaders, politicians, physicians, bureaucrats, sportsmen, professionals. Mortality is definitely higher in healthcare workers. And really, other than realizing the high-risk factors, we still are very confused about the immunology. We understand that there would be a lot of B-cell response, but we also realize that there is some adaptive immunity and natural killer cell, and also T-cell immunity, which would be probably important. And now when we are talking about reinfections, we also realize that maybe all this halalabu that we went through about plasma therapy just about a couple of months ago was possibly misplaced. But truly, we need to have a diagnosis, and the diagnosis, very clearly, the best diagnosis still is an RT-PCR. But let's not forget that 1/3 of patients are not going to have an RT-PCR positivity. So early in the pandemic, we learned from our Chinese colleagues, and we would do quick HRCTs to find people in that range. But that was the time we did not have PPE. That was the time we did not have tests. That was the time we did not have masking. Today we have moved further, and we realize that we have to have safe physical distancing. We need to understand that the viral particle distribution is affected by the flow and also by more activities like coughing and shouting. And we should have clear understanding of what we are going to do to be able to decrease the viral load. There was a lot of talk between droplet and airborne transmission, understanding that droplets are more than 5 microns, airborne transmission less than 5 microns. And really, people calculated a variety of indices, but truly a closed, confined area, more time being spent, more loud conversations, people eating food together, people conversing are something which could transmit. The WHO confused everybody by saying that there's no such thing as asymptomatic transmission. Well, they renamed it to pre-symptomatic. There's been a great race for a vaccine, which is still far from reaching any definite thing. We don't know whether it'll work, whether it'll be safe. Can we get it to all? And we must not forget that there was a lot of time spent in reaching other vaccines, reaching their destination. So whether we have a safe and a viable vaccine with this, we don't know. As a nation, what did we do? We had a nationwide lockdown. We had guidelines. The CSI also had guidelines which we had for emergencies. But really, as Minal said, the healthcare system was overwhelmed. We were stuck with a syndemic, a double whammy. A lot of people spoke about high-cost solutions, wanted to re-engineer hospitals or create new hospitals. People looked at wonder drugs. People tried to see how the governance should have dealt with. But the truth was that we are all indisciplined and we did not practice social distancing or masking. We are now in unlock, and really everybody thinks of it as one holiday which we have had in the last few months to obtain PhDs in Netflix. Because it's really one thing to understand that you have a low-cost solution, which is in form of sanitizer, hand soap, wearing gloves, wearing masks, and to really prevent transmission of disease. There was a lot of initial talk about the ACE receptor as being the receptor for the coronavirus, and there was a lot of talk about varieties of cardiovascular manifestations, and 78% of myocardiums on contrast-enhanced MR, which could be affected in the coronavirus disease. But really, we ought to move ahead from this, because we have to understand that it is an endothelial disease. There is going to be more propensity to thrombus formation, but we have to take simple measures. We tried to go away from our standard drugs to go back to them. But what happened was the fear of contagion pushed a lot of procedures away, delayed presentations of STEMIs, like Minal pointed out, and there was also a lot of paycheck pain. And this was, Makarofi did this study, which is published in Eurointervention. We did a similar study, and we found that during the first 3 months of the pandemic, in North India, there was an 87% decrease in PCI volumes in the cath labs. Of course, this was different whether it was government or private. Government hospitals, the cath lab volume decline was even more. In the private labs, it was a little less, which can be understandable because a large amount, about 80% of cath labs in our country are single cath lab centers. So the procedural volume has been studied, and really this has fallen across the kind of work that we do. There are a lot of challenges of return to work in an ongoing pandemic, which is discussed. We have to really think whether we have thought through the hospital for the next pandemic, and we have manpower attrition, emotional trauma, unclear data, and so many things which we have to actually consider. So if we have to have a Swiss cheese approach, physical distancing, ventilation, masking, hand hygiene, surface cleaning, sensitive testing, tracing, quarantining, isolation, government messaging, financial support are all important. Telehealth should have become even more important, but more than even telehealth, which has not become important, people still want an in-store experience in India, is the fact that we have not really worked on the value of care. While we are talking about value of care, we should also talk about care for caregivers, because the physician mortality has been humongous, and we have had all these are physicians who succumb to this illness. And we learned some lessons. And the lessons were that whenever we let our guard down, we are at risk, not only patients, but also colleagues. Pre-symptomatic will spread infection. Even having a cup of tea together can be a problem. Having these discussions are a problem. Interacting with mask down is an issue. It can happen in non-patient care areas like break rooms, nursing stations, cafeterias, lunch together. So all this, we put it down that frequent, prolonged, unmasked contact during social interactions at work, unreliable mask use, working together in office, including unmasked contact, and prolonged contact at nursing stations is very important. So the day-to-day challenges, Minal has already covered the emergency, but we need to get to the value of procedure. How should we test? We went from a phase where governments were criticizing physicians from testing. Now, and we were trying to use CT. Now they're saying test everybody who enters the hospital. PPE for all, it's not possible to do prolonged procedures with PPE and masking. It becomes, or PAPR, it becomes very difficult. What is the legal position? What about alternate transmission routes? We must be clear, ignorance is not bliss, it is the kiss of death. And if we put this all together, we can't eliminate, we have to substitute the hazard, we have to have some engineering controls, we have to have some administrative controls, but the least effective may be something which is actually something which we should recommend, and that is PPE. We talked about re-engineering the hospital from positive pressure rooms to negative pressure rooms, but we realized that this is going to be a challenge because it takes more manpower to nurse a patient in a prone position. The probability of contagion goes as you increase distance, and it can be avoided by very simple things. So using an N95 mask or using a PAPR will be great, but we cannot wear your face mask inefficiently because it is like wearing your underwear, and we always tell patients that wearing your mask and your colleagues that is like wearing an underwear. You cannot touch or adjust it, borrow or lend it, and you should make sure that if it is not damp. We can work further by we initially had a lot of challenge about temperature testing at entry and testing, but we never looked at the quality of PPE and the donning, doffing, and disposal practices. We need to understand this is not only in the cath lab, but also in the non-invasive lab and also in the emergency room. So we know this, that a lot of these patients are going to be a challenging population. And just a small case, here is somebody with tombstone STs, and with the patient procedure was done in PPE, elective intubation, balloon pump, placed outside, cath lab, put in a quick stent, come out, TB3 flow, but this patient, despite isolation in CCU, turned out to be RTCR positive. Now PCR positive. He was extubated in 24 hours on inotropes, but he continued to have fever. His HB dropped. He had some seizures, brief bradycardia. There was a small infarct, but the chest X-ray was ground glass opacities, and this patient was finally he made it. So where possible, bedside procedures are preferred. We should not do intratracheal intubation in the cath lab. Where possible, it should be done outside, avoiding non-invasive ventilation to avoid aerosolization, and all personnel not essential should exit the room. And we don't have too many Lucas devices or automated CPR devices for chest compression, but we should think about it. More important than getting enhanced negative pressure is to lay out the transfer route clearly. This is a photograph from Queen Elizabeth Hospital in Hong Kong, where you have these huge HEPA filters with these chimneys going outside. I don't know whether it is important. When we looked at all of this, we tried to get the airborne infection isolation space. We looked at the HVAC, the HEPA filters, their efficacy. We found that the weakest link was the biomedical waste disposal, because the Safai Wali would just come and pick up all this without realizing what has been done. We should use protection, and we actually, with the help of one of our device companies, we formulated what was called an Operation Rebuild. This was the help of Terumo. We held some training exercises. We guided people on infrastructural changes, administrative changes, and behavioral changes. There is no one universal solution. The solution has to be customized depending on the hospital, and we brought out a lot of SOPs on smart cath lab, how to enter, how to use the proper gear, or what is the checklist, and all these checklists were displayed in all our cath labs. We had to keep the patient contact communication intact with early discharge, clean every medical tool, trace the contact, performing CPR adequately, pre-donning checklist, slipping into PPE appropriately, having these donning and doffing with a buddy system with somebody with an alcohol swab available so that this could be done correctly. Correctly using face mask is all we ask. Ensuring hand washing, a lot of effort on training, on respiratory and cough hygiene, biomedical waste disposal, and also clean surfaces and disposal of dead bodies was something which we have been trying to educate people for a long time. So the solutions have to be low tech, which are facial coverings, adherence to science, adaptability, common sense, societal participation, teamwork, because no one is safe till everybody is safe. We have now reached a stage of prevention fatigue. but it ain't all over yet. To quote unquote Navjot Singh Sidhu, it ain't all over till the fat lady sings. And living with this is going to be the new normal. While fear was the key, complacence, fatigue, and arrogance can undo all the good which has been achieved without a vaccine. Hospitals face new challenges. Initially, we did not have PPE. Today, we are addressing patient fears and hospital finances. It is a very delicate balancing act. And the HPI has actually said that this infection is going to stay. There's no harm in hoping for the best. So staff, space, supplies, and systems have all got to be used, and all steps should have the safety of a healthcare worker as a priority, and nothing should be taken for granted. I'll just quote Field Marshal Manekshaw, who said that courage is not a matter of not being frightened. It is a matter of being afraid and yet doing what you have to do anyway. Everybody asks us, when will life return to normal? Unfortunately, the pandemic from the virus's point of view is that the virus will set the timeline, not us. So let's, friends, just stay safe. Thank you very much. I hope this is enough room for discussion.
Well, let us call upon, I don't know, Dr. Manatosh Panja is not able to speak, but let us call upon next the man himself, the man who has organized this conference along with for the CSI, the convener of the CSI NIC, Dr. Dhiman Kali, who will tell us what impact this pandemic is having on ACS management. Dr. Dhiman Kali, please.
Thank you, Dr. Praful, a good friend of mine. After two brilliant lectures by Dr. Anil Dhal and our president, Dr. M.K. Dash, practically I haven't nothing much to talk about, but just let me try to tell some of the things. According to Dr. Antonio Fauci, that it's a disease about which we know very little. So just to talk about a person who has written the book of Harrison's Internal Medicines for editions after editions, he has told we don't know much about the disease. That explains how much we know about the disease. Some people tell that it is a vascular disease. Just now, Anil, my good friend, has shown it's an endothelial disease. And Mrinal told that there is more of, thrombosis. And in our day-to-day practice, we have seen that while we are using PPE, we are doing primary PCI in all our patients, if possible, of course, if it is indicated. And we have seen that the thrombus burden is unusually high. So we are also thinking that it's a vascular disease. And we got the indication in mid-April when our friends from Royal Brampton Hospital has been SMSing that, it seems that in the lungs, from the pathology, from the autopsy studies, that there is some thrombus inside the arterioles, inside the capillaries. So that being the situation, it is more of a vascular disease than that of a viral infection. And people are telling that the spikes protein, S protein, they are incremental in causing the vascular manifestation. So we'll discuss under these headings because these are very important challenges to us. And sometimes it's very difficult to diagnose whether it is STEMI or not, because myocarditis, which happens in all the viral infection, but little more in this infection, as sometimes causes a different difficulty in diagnosing the STEMI, and that has been highlighted in all the guidelines, the one by SCI, ACCHA, by the ESC, by our own guidelines. And we are having a registry, and we have included almost more than 40,000 patients, and we are going to come out with the results very soon. So just now our friend Dr. Anil Dhal told about the personal protective equipment. It was a wonderful deliberation, and he left nothing regarding this one. So what is the objective is to provide recommendation and systematic approach for the care of the patients with acute myocardial infarction during the COVID-19 pandemic. Because already there is a problem. What is the problem? The patients are coming much late, which has been told by my previous speakers. Really, they are coming very late. So what are the emergency and strategy to categorize the interventional procedures following this pandemic outbreak? So this is STEMI. STEMI ACS who are very high risk patient, and really the patient is having, lot of chest pain, because there is not a lot of pathophysiological differences between the two entities, and actually the mortality is more in this NST ACS group. And also the third category is the patients with cardiogenic shock, which patients we should deliver the health care very urgently. These are NST ACS with intermediate risk features, unstable angina patients, left main PCI, as our previous speaker, Dr. Fazila Malik, has shown. The PCI in left main is already a problem to us. Last remaining vessel PCI, decompensated ischemic heart failure patient. And Dr. Ramesh Dagubati told about the recent procedures, and he has recruited already 4 patients, not of course COVID patient, but with cardiogenic shock patient, because there is paucity of data regarding the shock patients. Angina pectoris, especially class 4 patients. And we should consider CABG in patients with NST ACS who are unsuitable for PCI, and whom we should give lower priority. So advanced CAD with angina class 2 or 3 symptoms, stage PCI of non-culprit lesion STEMI, and proximal LAD PCI. Sorry. Now this is the strategic categorization of invasive cardiac procedures during the outbreak. And emergency mechanical circulatory support for cardiogenic shock below 65 years, because we know in Italy also the mortality was more in the elderly people, because they didn't provide at one point of time patients aged more than 70 years the active therapy, like intubation or mechanical circulatory devices. So these are the different guideline recommendation. Now coming to our subject, we talked about STEMI. What we should do about these non-STEMI patients with COVID-19 outbreak. Again, we risk stratify this patient, whether they're very high risk group of patient. Yes, if they are like hemodynamically unstable patient or having cardiogenic shock, recurrent ongoing chest pain, refractory to medical therapy. A lot of therapy has been given, but it's not working. And we know that these COVID patients are a peculiar group of patients. We tell about that they prevent the thrombus by giving the anticoagulants, but they should not be, they are sometimes failures even after adequate medical therapy. And I want to mention this point of time that there are some recent literature that NOAC should not be used in this group of patients, because we use a lot of NOACs in such situation because there is a drug-drug interaction, and we don't severe and apixaban interferes. So they have recommended, this is a JSCC blog, that don't use the NOACs in such situations. Life-threatening arrhythmias or cardiac arrest, mechanical complications of MI. So we have to act in such situation. Acute heart failure, and if there is recurrent intermittent ST elevation, because we know some STEMI patients also show that in between they have ST elevation with exacerbation of the symptoms. So intervention should be done at a very urgent speed, that is as per the recommendation. But the recent guidelines give us little, benefit to us, the physicians, that you can get 1 hour of grace, as my previous speaker Ramesh was telling, that they're taking the patient, high-risk patient, within 67 minutes, anterior MI, proximal LAD occlusion, the patients aged more than 70 or 75 years old, the time bound has come from 92 minutes to 67 minutes. So we should also try to take the patients very early in this very high-risk group of patients with STEMI. Now, established diagnosis of STEMI based on cardiac troponins, because TROPI is also high in COVID patients. We frequently find that the TROPI or the NT-proBNP all are high in this group of patients, like D-dimer is high, and there is a neutrophil to lymphocyte ratio, which also pinches the diagnosis early, because it takes a few hours time, even in the best of hospitals, to get the data for the RT-PCR. We know there are 2 types of tests. One is the molecular test with the RNA technology, where the RT-PCR is done by gene expert, or there are COVAS technique or TrueNAC technique. These are the 3, but I think gene expert and COVAS are very good in detecting the person, and the results are coming within 1.5 hours in our lab. But we can't wait up to that. We take the patient in the lab, cath lab, we do the job, and after that we get the results. And we have got a lab which is not, of course, dedicated, but we do these procedures in that particular lab, a very good Philips lab, and we are happy with the things. And always it's not possible to do with negative pressure, to speak you frankly, because they are not inbuilt like that. Intermediate risk patients establish diagnosis of STEMI based on cardiac troponins and at least one of the following: diabetes, if the ejection fraction is low, below 40%, and early post-infarction angina or prior PCI or CABG. And low risk, any addition not listed to other risk factors. Those are the low risk group of patients. And so if the patient tests positive for the COVID, early invasive after test result less than 24 hours. We take these patients very early. And if the patient is a intermediate risk group, we go for more of non-invasive testing, and then we decide about the, intervention. But the policy, as Mrinal told, we would like to take this group of patients as early as possible if there is any high risk probability. And the low risk group, we don't bother, we go conservatively, as we learned from Dr. Bahl's speech, that medical treatment is also versatile. Of course, he talked on stable patients, but in unstable patients also with low risk category, the patients with low risk group, they do extremely well. And this is the ESC guideline. We know that patients with STEMI during COVID-19, we haven't got any such network, but he should be taken by ambulance or of his own, and where the center where primary PCI can be done, we should go for primary PCI without getting the result of this, COVID test, that is the RT-PCR. But if it is not available in a primary center, as Mrinal has told our Honorable President very nicely, that we should go for fibrinolysis and then a pharmaco-invasive approach, which have been tolling for long. So in COVID scenario also, because if we can't do anything, we should go for any sort of reperfusion. It may be pharmaco-invasive one, and it has been shown in many trials that the results are non-inferior. At hospitals with 24/7-hour cath lab service, of course, there is no problem in going for primary PCI, but without this, we should go for fibrinolysis and send the patient for early angiogram. And if required, we should go for, pharmaco-invasive approach. All STEMI patients should initially undergo evaluation in the emergency department, and this for COVID treatment patients, we should go some sort of focus, point of ultrasound, point of care ultrasound if possible, or if possible, bedside echo, whatever, both are good. Patients should be evaluated in the ED prior to cath lab activation. All patients require the placement of a face mask. As Anil was telling, it's very important. It's a form of vaccination. It prevents both droplet and aerosol contamination of the CCL. A recent literature showed that with a cough or sneezing, the particles can go up to half a kilometer, from 3 feet, 6 feet, now to half a kilometer. Very recent in ViewMedi. And STEMI patients, primary PCI should remain the default strategy. And in patients with evidence of STEMI, if a primary PCI approach is not feasible, pharmacoinvasive approach may be considered. During the COVID-19 period, there may be delays in door-to-balloon time, and they have given us an additional 1 hour for this. But if it is more than that, we should consider fibrinolysis instead of, going for PCI and unnecessary delay. We can give tenecteplase in a shot, and then we can take the patient up to 2-3 hours. Now ESC tells that we can take the patient up to 2 hours. Possible STEMI for patients who have an unclear or equivocal diagnosis, as I was discussing, because many of the patients have signs and symptoms of MI, but they are actually myocardial myocarditis. And the most disturbing fact is that after the patient has got certificate that the patient is okay, after that also we are finding, because it's a cardiac complication, in CMR evaluation in one of the latest studies in Germany, where 100 patients were included and all had CMR evaluation. And in 78% patients, it was found that they have dilated heart with LV systolic dysfunction. A similar result came from another multinational European study, where of course the numbers were little less. 52% of the patient had some sort of heart failure. So it's a dangerous disease with follow-up complications much more than the pandemic, which we saw in 1920. The focus of this evaluation is twofold: further risk stratification for COVID-19 status and further evaluation of the diagnosis, specifically assessing the potential for coronavirus occlusion versus other pathologies. And as I mentioned, focus is very useful. It's being increasingly used, or echo can be done bedside. Echo consistent with the ECG provide valuable information. Available clinical ECG, lab, and imaging data give us immense, help for the interventional cardiologist, whether we should activate the CCL, because we have in our setup a 24-hour activated system, and we can take the patient within an hour. So if we think from all the data, it's a case of, primary, it is a case of STEMI or a very high risk group of STEMI, we should take the patient to the cath lab, have PP, and not only us, all the persons inside the cath lab should have a full PP, and it's a very cumbersome, of course, to operate with a PP, but what we can do to save ourselves. Coronary CT may be considered in cases where the findings of ST elevation, transthoracic echo are divergent. As I told you, sometimes the diagnosis is difficult. Now,
Chairman, sir.
Yeah, time is over.
2 minutes, sir.
Okay, thank you very much.
Almost.
So a joint decision of the emergency department and the intervention cardiologist should be incremental in activating the cardiac cath lab, and we should go for all these steps, and care for ST elevation should properly be taken, and we should not deviate from our policy that we should go for primary PCI if needed in our STEMI patients. And, COVID-19 screening is very important. We should put a pulse oximeter. We have heard about happy hypoxia. The oxygen saturation is good, 98%. Suddenly it drops to, 82%. And it's not because of, MI or the heart failure, but because of the COVID pneumonia. And chest X-ray helps, and, CT of the thorax, it helps us immensely. And if we think that intubation has to be done, better to do in the CCU or in the emergency room, rather than doing in the cath lab and pollute it. So consider COVID-19 myocarditis, that whether we are missing the diagnosis, and if it is COVID is positive, we should look into all these diagnoses, because abroad the US government has bought 15 crores of Binax, test kits from Abbott, and, they are doing this test very rapidly. The results comes very rapidly. So the protocol is same for this. It doesn't differ much between the recommendations, and patients with cardiogenic shock, the out of hospital cardiac arrest patient, if the diagnosis of STEMI is not there, of course we should not take them to the cath lab. But if the cardiogenic shock is because of AMI STEMI, and then we should take the patient quickly to the cath lab and do the needful. Now, patients with out of hospital, and we use more of ECMO in these patients. In our city also, a lot of venous extracorporeal membrane oxygenation is done, and these patients are often intubated. Just to brief you about the results of intubated patients with COVID, of course, not the ordinary STEMI patients. In Wuhan experience, it was 97% mortality. In New York, according to different authorities, it was, 80% mortality with ventilated patients, total patients. And, some of our friends like Dr. Sipal, Bangalore, published one literature in New England Journal of Medicine last month, and it showed that in about 46% of the patient, though it was not a big study, that's not possible in the current time, and it was a single center study, it showed that 46% of the patient had non-occlusive lesions. So I had some more things to show, but this is the value of cardiac CT, and at this time to rule out the left atrial appendage thrombus and intercardiac thrombus, where the patients with STEMI needs to be shocked for cardioversion, and in patients with respiratory distress, we should go for chest CT as early as possible. There is a mention about no use of NOAC in patients with acute, this is regarding personal protective equipment, but already Anil has left nothing to discuss about this, and these are the triage we should be activated. And so to conclude, the management of ACS remains a key priority, and services configured in an adaptable manner to respond to the changes demands in pandemic. And we should not forget the fact that COVID itself is a dangerous disease at high mortality and morbidity, and we don't know much about the disease, and we should try to give, after the procedure at least, a very good DAPT, Like I should prefer to go for prasugrel or ticagrelor if they are not contraindicated, and 150 milligrams of aspirin because it's a vascular disease with high thrombogenicity. And I won't hesitate to give a few doses of enoxaparin even after the procedure, just to avoid the thrombus load, as our president has shown in that case. So I'm not going into the case. And thank you very much for your kind attention.
Dr. Paja, please unmute yourself, sir. Please unmute, sir. Dr. Paja, please unmute yourself. Dr. Paja.
Yes, audible now?
Now you are, sir. Now you are okay.
Yes, that's right. Several times do it. We have helped to do it. Anyhow, that is the Dr. Kahali has done a wonderful job, and everybody agreed the primary PCI treatment of choice in spite of the PCI, particularly in spite of the COVID positive. So my thing is that there should be balance between the patient's care as well as the protection of the cath lab staff. This is very important. We'll discuss later on. The next speaker, I think the last speaker, Dr. Srinivas, will talk on the subject of the different guidelines of the PCI in cases of COVID situation. Dr. Srinivas, please.
Thank you. Good evening, Dr. Panja, Dr. Praful Kerkar sir, and Dhiman Kahali and MK Das. Thanks for the opportunity. My job is made very easy by my earlier speaker, Dr. Kahali, who has covered most of the recommendations and the guidelines. Thank you for doing it, sir. And I'd like to review some of these various guidelines which have come in this PCI in COVID era. Best wishes from Apollo Group of Hospitals. Proud to present my colleagues of Fax Professional Services, which run services in hub and spoke model, very useful in these tough times of COVID. So obviously, whenever we see any guidelines, basically any aim of any recommendations is basically to treat the patients well. So what are the aims if you see, be it be ACC, be it be Sky or Indian, for that matter, anything, we want the patients of STEMI should get a timely reperfusion. At the same time, as mentioned by Dr. Panja, we should also take care of our staff, protection and safety of all healthcare personnel in these tough COVID times, and also efficient use of resources, including PPEs and things like that, and minimize adverse outcomes. So somebody gets infected, the entire staff could be in jeopardy. So these are some of the broader guidelines where, in spite of giving good care to patients, we should also not jeopardize our staff. That is the basic aim of taking any guidelines. This is the pathogenesis of CVD is very different. I won't go into details because I'm not supposed to cover it. Suffice to say that endothelial disease leads to various types of presentations, not only acute MI directly by major vessel occlusion, so minor vessel occlusions, STEMI mimics, asymptomatic troponin elevations, the direct myocardial involvement into shock, and massive multi-organ failure, pericardial involvement, arrhythmias, and the thrombotic complications are already very well highlighted. It basically suggests it is a diffuse systemic illness. This point-of-care ultrasound helps very much in confirming the diagnosis of acute MI before we take up these patients, but we need to protect our staff, and those are the methods described to assess. Initially, in the COVID pandemic, very early in March, as a reactionary response to one of these Chinese articles, the European Society recommended that in almost all the patients, you just give pharmacolysis, pharmacoinvasive strategy, or give thrombolysis because it could infect most of the patients' staff. This was the situation in March 2020. Then later we became wiser that it is not advisable to prevent the benefit of a primary PCI to all those patients. So actually, what type of patients we are dealing with, we need to further identify. So group A is a confirmed COVID patient. For this sake of this patient, you should not get into trouble to other group C patients where there's low possibility of COVID. Somewhere in between is a COVID suspect is group B. So in order to take care of a group A patient who is infected with COVID, we should not jeopardize the patients who do not have such infection. Those are the concepts which are gradually coming up. So in other words to say, if your patient have a suspected COVID or a diagnosed COVID, you follow the COVID protocols. But if he doesn't have a disease, which is not, you follow the same protocols which exist in your hospital before the COVID era. That is quite simple, understandable so. So if you see which are the patients who, in spite of having COVID, you do primary PCI is obviously when it is not possible, there is no choice. It is like doing it in periphery. Fibrinolysis, when the PCI is not possible, you almost do fibrinolysis. And which lytic agent to be given, all those, I'm not going it. This pharmacoinvasive strategy was also proposed in JAPI consensus statement, which was written by along with Dr. Hiramat and Chopra, which is mentioned here. Same thing, I'm happy to share Dr. Praful Kerkar sir is here. The Indian Cardiological Society position statement has come in Indian Heart Journal, suggesting the protocols which are need to be followed. So basically, whether it is Indian, American, European, what is already said is when there is not possibility of primary PCI, obviously we send these patients for lysis. But whenever the patient has these high-risk features, like patient has a large anterior MI, patient has hypotension, Killip class, cardiogenic shock, life-threatening arrhythmias, and one other thing is delayed presentations, which often happens in COVID times because patients are worried to come to hospital late. These are the subsets of patients who should try to do primary PCI in spite of all odds. Whereas if a patient has a low-risk features like a small MI, inferior MI, or lateral MI, then patient is already stabilized without much of hemodynamic compromise. Here, such sort of scenarios, you can just give lysis. We need not risk the cath lab staff for a COVID positive patient if it is a low-risk MI. And probably you should identify some special spaces in the hospital ICUs itself where you could thrombolyze these patients. Just to take you through, I will take you some case examples. Case scenario 1 is a 50-year-old female, hypertensive, has chest pain, and elevated troponin. That's how the cardiologists were getting affected before. Without knowing the COVID positivity, we were going and seeing such patients, such diffuse STT changes. Obviously, we'll take up these patients for angio. And sometimes, as we noticed, this patient almost had a normal coronaries, near normal, which you call as Minoka. Then conservatively managed. This sort of approach and everybody being covering is all a big pain to do this doffing and donning of this PPE kits. But unfortunately, we need to follow all this to keep safety of our staff. So it is very important to preserve the morale of the cath lab and also have a second cath lab if possible. In our hospital, Apollo, one we have identified for borderline cases or doubtful cases, and one is done for pure negative cases. We need to train our cath lab staff and probably have clear-cut guidelines how to follow it and how to clean it in between cases. And we need to maintain the morale boosting of the psychology of the team. And then probably in that sort of attitude, we still continue to do a good job. This is another patient here. You can't just get away by using lysis, because elsewhere the lysis was done and patient continued to have pain, then he's referred to us for further evaluation. We have already scan was done showing negative, then obviously we had no choice but for doing a primary PCI. Luckily, pre and post immediately was done. During that time, late April or early May, this CAI guidelines came out, got it from Ajay Kirtan, and later it was published in JAC. They came out with some other specific purposes where you should avoid, where you should prioritize. So what this mentioned is definite STEMI. Like when there is no doubt of acute MI and the window period is more than 2 hours or less than 2 hours, the same standard guidelines apply. But they said it could be delayed by another hour or so. So what we need to follow is level 2 PPE kits, what I have shown in the previous picture. Some are doubtful MIs, so probable MIs are STEMI mimics, which could happen with my small vessel involvement. So here again, the small MIs could be managed conservatively without exposing the cath lab staff, could give lytic therapy here. Then another entity called futile prognosis. Sometimes patient is COVID infected, gone into cardiogenic shock, or out of hospital cardiac arrest patients they brought into the hospital. These are futile, whatever you do, in spite of doing, we were doing primary PCIs in these shock patients before. But what is recommended is once the patient becomes so sick with again COVID, the mortality is as high as 95%. That's how they said it is not recommended to take up these patients to cath lab for procedures. This is a futile prognosis group. Other thing is probably a milder low-risk group, which was covered before by NST elevation, unstable angina, probably without hemodynamic compromise. If you can avoid and postpone doing angiograms itself, and probably at a later stage, that when that later stage will come, we are in the process of still waiting to see cases coming down. I think this slide was shown by Dr. Kahali before. Basically, STEMI patient coming into a networked ambulance type of care system. You take them of primary PCI with a with again additional 1 hour of extra delay which is happening. If patient is coming to a place where cath lab is available, if it's high risk for MI, you take them for primary PCI with protection. Whereas if a patient cannot reach hospital in time, probably you could still continue fibrinolysis like in before. This is also shown before by previous very high risk individuals. You directed to take them to cath lab, intermediate and low risk where it is possible. You tend to avoid getting the exposure to our cath lab staff and others. American College of Cardiology, good friend Dharam J. Kumbani has written this, basically guidelines of ACC, and it again matches the same. So in spite of COVID, if a patient has high risk features and a large MI, cardiogenic shock, lip class, what we mentioned like before, they still recommend the STEMI and proceed with primary PCI. Again, when there is contraindication to fibrinolysis, like patient has active bleeding prior, this is a regular contraindication lysis, obviously we have no choice but to take these patients for primary PCI. Wherever possible, probably if a small MI, there is no contraindication lytic therapy, you could get away by giving lytic therapy. But in the patients, again, we have a rescue or failed lysis, as case what I have shown, we have no choice but to do PCI with all care. So some of the patients in which this is again important for us to understand and know these patient subgroups, where to avoid. Sometimes you get only troponin positive myocarditis type of picture. Then sometimes you get patients already having pneumonia or ARDS. Then you need not be aggressive on these patients. And the patient who are again having an STEMI, a low risk type of patients, you could stabilize these patients and get to these patients to lab at a later date. So these are some of the very sick patients or very low risk patients you avoid. Other important thing is about regarding the cardiologists also. We respect all the senior colleagues who are there, again, Dr. Panja and many others. But basically, it's also important to protect ourselves and the cardiologist. Whenever this is about a personnel management, like a cardiologist or a paramedical staff, if you are aged more than 65 years, or if you yourself have diabetes and hypertension or COPD or any previous cardiac disease, better this sort of a group practice, what we follow, helps a lot. We cover up the patients of all our senior colleagues, and that's how you should avoid exposure of the senior colleagues in these tough times of COVID while doing your PPIs, primary PCI. This is a patient who is a 50-year-old, another case, who is referred from Indore Apollo hospitals for a PCI. He came with this sort of angiogram picture with a tight lesion there, unstable angina. We were waiting to get the COVID testing done. In that process, he started developing ST elevations, and the R waves here started becoming more. That suggests that he's about to infarct, developing 10. We have to rein him inside. And when we found it, the L6 was totally occluded. The pictures are small. For sake of time, I freezed it. And then we had to do a OCT-guided PCI, and that artery got opened totally, and the patient became all right. So this sort of PPE, I wouldn't say it is level 2, but probably you can say level 1. We protect ourselves. The masking patient as well as ourselves, along with the face shield, is the most important, I feel, to protect. And then if you have 2 labs designated, one for COVID suspects or COVID, other for non-COVID, it's good. This patient, that's how we referred from Indore, we could save that patient and save the myocardial damage. But what we need to follow is, again, still follow all the precautions you mentioned. And one sort of guideline cannot fit all. One size does not fit all, because each institutions, each hospitals are different. And as a COVID-19 is evolving, the guidelines, recommendations also could change. But in this particular scenario where you still find some cases, fortunately not very sick cases, but cases are still there. So probably prevention by social distancing, hygiene, and N95 mask with face shield. This is the most important for all the cardiologists, even interventions, during interventions, to protect ourselves. I feel this is the best. And then if you realize the continued presence, you need not become negligent and work without masks and all that. We should be careful. But sick patients are coming down. Other suspected cases, again, should be managed as per guidelines. Any positive case with acute MI with high-risk features, still we should try to do good with patients with PCI, with PPEs, and avoid cath lab exposure unnecessarily if possible with some of the smaller MIs and things like that, which I've shown where you can avoid it. But if required, we should always be ready to act. Ours is God's own country. We see people going around without masks and all that. Still, they are saved. There are mask slums. We do not get into it. But we should at the same time be careful, take care of ourselves and staff, and try to do good to these patients. Thank you very much for patient hearing. I think I've tried to finish in the time allotted to me. Thank you very much.
Well, thank you, Dr. Srinivas. That was an excellent talk. You gave us a gist of the entire session, actually, in your talk, when you gave us what to get out of every guideline. Unfortunately, though we had a 15-minute slot for discussions, we are running out of time, and I've been just called up by the organizers telling that we need to wind up, especially because there are more exciting sessions ahead, and there are international speakers who are waiting in the guest room to come over. The guest room, as we talk in this modern era, is a separate room to go live. So I'm sure everybody would agree that all the speakers have done an excellent job.
Yes.
My apologies to the expert panel that we cannot really have them coming into the discussion. There are so many practical tips and traps, and a lot of questions have come in the chat box. But due to lack of time, we'll have to wind up this session, and a hearty congratulations and an applause that we can probably give this way. Okay, you can see that. So every one of you can give that kind of an applause to the organizers of this show, Dhiman Kali, Debabrata Roy, and led by our president. Okay, bye-bye, everybody.
Is also
Let's
good way.
move on to the next session.
Thank you. And thank you, all the speakers. Thank you, Dr. Praful Kerkar. Thank you, my very good friend, for your excellent moderation and chairing. Thanks, sir, Professor Manutosh Paja, who is our teacher. And thank you, Dr. Amol Khan, Dr. Srinivas, my previous NIC chair, Soumitra Ray, and Dr. Debabrata Rai. He has done an excellent job. I must give a very heartfelt thanks to him. And also Dr. M.K. Das, our president, and Dr. P.K. Dev, who is our mentor. So this was a very successful session, but unfortunately, we cannot go for discussion, which would have been very exciting. At present, I thank all the 1,106 delegates who are seeing this proceedings. Thank you very much, sir. And 36, panelists and, chairpersons and faculty. So altogether, it is 1150, little less than yesterday. It was almost 1,500. 1457 yesterday, but today it is little less because being Sunday and IPL matches, etc. Anyhow, thank you very much and accept our gratitude. So I announce the next session, coronary complications and difficult situation. This is the hall where maximum crowd is there, and we have got an excellent international faculty, Dr. E.S. Brilakis, Dr. Subhash Banerjee, Dr. George Dangas, Dr. Ramesh Dagubati, and we have got an excellent chairpersons in Rishi Shetty, Professor Pranab Kumar Vishwas, Professor Rishi Shetty, Professor Kashinath Ghosh Hajra, and our expert panel consists of Professor S.C. Mondal, Professor Shukumar Ghosh, Devashish Mitra, Vinayak Dev, V.T. Shah, Sharad Chandra, Professor Sharad Chandra, Vijay Kumar, and Dr. Keshav Murthy. So I would invite all of them to come on the dais and take the mic from me. And I would request Dr. Subhash Banerjee, who is a very good friend of mine, to kindly introduce Dr. Dangas and Dr. E.S. Brilakis, who are first time in our conference of, done by us. So kindly introduce them first and then start the conference. Thank you very, very much, all the chairpersons of the previous session. So please, Dr. Subhash Banerjee, take the mic from me.
Thank you very much, Dr. Kahali. And thank you I want to thank the organizers for this very, very engaging session. I've been part of it since the morning, like early hours in Dallas, like about 4:30. But I've enjoyed every bit of this session so far. So thank you very much for inviting us, and thank you for inviting the faculty from the United States. Dr. George Dangas is is a well-known name, and he does not need much introduction. He is the professor and a leading cardiologist who is known worldwide from Mount Sinai Hospital in New York City. And he is going to talk about the high-risk PCI in patients at a high risk of bleeding. And my dear friend, Dr. Emmanuel Brilakis, who is at Minneapolis Heart Institute, also a very well-known expert in the field of complex coronary intervention and CTO intervention. And he's going to talk about coronary perforation. And I think it's a great pleasure to introduce them. I would invite Dr. Dangas to take on the stage or the arena and present his talk first.
I think you're muted.
George,
Yes,
please
sir.
unmute
You are
yourself.
probably muted.
I'm unmuted.
Yeah, that's
Very
it.
good.
Yeah.
But you see my screen very well?
Yes, sir. You can see it, sir. Yeah.
Okay, excellent. Well, sorry for the AV mishap for a moment. Congratulations for a great conference you're having and a great exchange of talks and discussions. I'm very happy to contribute in the topic of PCI and high bleeding risk patients. At the same time, take the moment to introduce the new initiative of the Society of Cardiac Angiography and Intervention, SCAI, the SCAI Bifurcation Club, with associations with all the different bifurcation clubs around the world. And hopefully many of you will also join SCAI as well as our bifurcation initiative if you'd like. Let me proceed by indicating, first of all, a high bleeding risk case. This is a patient as high as it comes in high bleeding risk for various reasons. Is a status post bypass surgery. We went into shock and persistent shock for the second day. And as a background, was an 80-year-old, that's also a risk factor, came in with dismal exertion, is hypertensive, diabetic, PAD, Parkinson's disease, also the risk factors here because of patients' somewhat frailty also, prior MI, many medications that you see here, and in fact, patient been a little hesitant from ICU point of view to refer for surgery, for PCI, I'm sorry, because after surgery still had the chest tubes and they have the usual bloody drainage for the first day or so. In the end of the day, the patient was brought in the cath lab, was found to have a subtotal occlusion of the ostial circumflex. The grafts to the circumflex as well as to the PDA were occluded. The lima to LAD was the only patent graft. We proceeded with the Impella, IV heparin, IV Angiomax we gave, IV Cangrelor, and maintained the patient on that for a few weeks because the patient could not really thrive or go or eat anything by mouth. It was intubated. The impella was removed at the end of the procedure. Patient remained on a balloon pump support and ultimately went to a rehab center about a month later. And 2 months since then, he came to an office visit walking. I think that's a good outcome and how careful we have to be in high bleeding risk patients. Let's talk a little bit about who are these patients. And you can see that everybody talks about bleeding risk as something like scary. And we can see that what are the major and minor risk factors? They include age, renal disease, liver disease, active cancer, anemia, low platelet count. These are really big ones. And again, they are aging related, comorbidities, laboratory related, brain related, such as stroke, bleeding history, that's kind of obvious, as well as iatrogenic related, including anticoagulants, surgeries, as the last patient, for example, and obviously many combinations of the above. One can say that, oh, that's really weird. It's not really my patients. Well, actually, that's not the case. These are very common conditions if someone watches around, particularly, for example, the anemia and the age. Extremely simple. Then you talk about CKD, and then you start going up again. And you can see that a combination of major and minor criteria is quite a few of the patients, maybe even about the half of the patients may have some of these high bleeding risk criteria that are published by the European Society first, then by the American Society, as well as we published this study from our database just to show you the real world, how frequent those things are in our center. And obviously, once you see that in real practice things are very frequent, you start to care even more. And then you start asking questions, how do I get through the procedure? And most importantly, for example, how I got out of that procedure was that I used the IV reversible agent that kind of calmed down the ICU. Ultimately, the patient did not have bleeding, but who knows, maybe we had used an oral agent. One might say, okay, the patient didn't bleed anyhow. What do you really gain by that? Well, we gained that the ICU minds were settled, and we also gained that the drug didn't have any problem with the absorption, etc. Anyhow, DAPT comes always in the I would say the security that DAPT can be taken for some time acts as always a frightening or a concerning question. And if we have find ways to abbreviate it, that would be better. So, optimizing the stent implantation, the stent choice, and the post-stent antiplatelet therapy become really very important and interrelated in these patients. To begin with, let me remind you that a good job by implanting the stent is extremely important. And we tend to forget about that just because the stents have become so good, so deliverable, thin strut, this, that, the other, nothing to do with the original stent. However, the original lessons of a 1995 by Dr. Colombo and co-workers indicated that if you can fail to deploy a good, well stent, although angiography may be misleading, so you really have to do your post-dilation, and here they showed it and proved it by the IVUS that the angiographic picture between B and D, for example, didn't change a lot. However, the IVUS picture changed tremendously by using appropriate expansion of the stent. That is step number one. All right, so if you're concerned about any DAPT or any other thing with your stent, just make sure it's implanted excellent to begin with. Then we obviously have IVUS and other types of imaging may optimize. Do we have studies that clearly show that? Not really, but in my mind makes all the sense. If you're really very, very concerned, you have to go the extra mile to make sure the job is really done well. And then we can see how we can potentially interrelate the stent choice with the duration of DAPT. In high bleeding risk, studies have started to emerge in a way trying to see that whether some stents can afford abbreviated DAPT or whether some stents can work better in patients with high bleeding risk. And having high bleeding risk trials or studies has become a little bit of a fashion over the last few years, indicating, for example, that the surprising findings of the Leaders Free trial that with a drug-eluting stent, they had a better outcomes long-term than with a bare metal stent, even in high bleeding risk patients. And I think that was the beginning of saying, you know what, maybe we got it all wrong, and maybe the bare metal stent with abbreviated DAPT is not all we need. Perhaps we can go down the drug-eluting stent. Seems to be so much better these days with the second-generation stents, etc. And perhaps we can work off that and try to curtail the DAPT treatment duration with a drug-eluting stent. Then we had another study that wasn't exactly high bleeding risk, but again, all older patients are high bleeding risk. So the senior trial with the Synergy stent indicated very clearly that it can be better than a bare metal stent and can afford 1 month of DAPT in stable angina or silent ischemia and 6 months for ACS patients once they are elderly, over 75 years of age. This is the first trial, or I would say that one of the very first trials that focused exclusively in a high bleeding risk population. The definition wasn't even available back then. All of them were elderly, and that qualifies as a bleeding risk, but the flavor was the same. A drug-eluting stent, again, with abbreviated DAPT, seemed to be much better and very, very safe. And you can see on the bottom right, all the way to the right, the stent thrombosis 0.5% with this stent, despite the nervousness one can say that 5 years ago, every one of these investigators had that. Could it be possible that we give a drug-eluting stent here with a bioabsorbable polymer and not give a full year of DAPT, and oh my God, what's going to happen? Actually, nothing happened. Patients did great. Then we have a series of other trials coming up and say, you know what? Can we systematically abbreviate the DAPT in some ways? And the pathway we approach in Twilight was that we abbreviate DAPT, but again, hold on for 1 second. What is DAPT? DAPT is dual antiplatelet therapy. Until the Twilight trial, when talking about abbreviating DAPT, everybody thought about stopping the P2Y12 inhibitor. In Twilight, we said, okay, hold on. How about if we stop aspirin? And could it be that most of the bleeding aspects come from the aspirin point of view? And it could be better for ischemic protection, perhaps, to keep going with the P2Y12 inhibitor. And therefore, in this study, we employed DAPT for, everybody got DAPT for 3 months. And then after 3 months, we got the aspirin dropped and in a randomized fashion into aspirin versus placebo, and we actually showed that the bleeding would cut tremendously, and everybody can see on the right side that the death, MI, or stroke wasn't affected at all. And I don't want to show the slides here. We have separate publications. Earlier this year, my own publication in JACC with in the complex population sub-studies, essentially, of Twilight. Dr. Baber published in the acute coronary syndrome sub-study, and all of them have the same flavor. So whatever you see for the overall study, pretty similar results in the ACS population, pretty similar results with a complex lesion sub-study. And we also showed in a pharmacodynamic study that nothing much really was affected pharmacodynamically if you drop the aspirin. And we also, Dr. Angelo Lilla's publication showed pretty similar cardboard copy, one could say, similar with a diabetic population. So we have very, very good confidence that it's just not an overall result that kind of fades away in the high-risk populations, but actually has a very, very good durability when you see that. The onyx population and that you can see in this slide indicates that everyone, what I said before became of a fashion to have high bleeding risk studies, and now this popping up left and right. And you have here this randomized study, all high bleeding risk patients, Resolute Onyx versus the Biofreedom drug or the Stent, 1 month of DAPT, both ways. You can see a few years ago, we're very nervous. Could we even do 3 months? Now you can see everyone is going up into shorter and shorter DAPTs. And you can see that actually both stents performed very, very close to each other, a 17% of a 70% of events in this high-risk population. Then we have one can say the continuation of the Synergy Senior into this Evolve Short DAPT with the Synergy Stent. That was again the one that was used in the over 75 years of age patients. This was about 2,000 patients, and they got a they're essentially not randomized, but they classify the patients to eligible to discontinue or not eligible to discontinue at 3 months, and they kept following that up. Most people were eligible to discontinue, 77% of the patients. The minority were not able to discontinue because usually they were not event-free. And then we have the results that you can see here, whether they did discontinue or not discontinue, kind of all the same with the population. That was a little bit of a different kind of study where everybody got the same stent. It wasn't exactly randomized. They were followed in a very clinically meaningful way. Finally, we presented at ECT the ZANS 28 and 90. There were two, I would say, twin trials. One of them had an index PCI, gave DAPT for 3 months, and another one gave for only 28 days, and they continued all the way to a year. And you can see that the results were extremely similar, 5% compared to the historical control, met the non-inferiority, and again the same flavor with a 28, 3.5 versus 4%. Again, by the pre-specified definitions of non-inferiority, and most important to me, the stent thrombosis was at 0.2%, because as interventionalists, we know that this is really the hallmark of quality of what we try to do. Without the bleeding, I think everybody understands that if you abbreviate DAPT, you save a lot of bleeding, save a lot of events. We did something really good. Finally, the master drug trial with yet another drug-eluting stent, the ultimaster bioabsorbable stent, bioabsorbable polymer stent, 1 month of DAPT, and randomized into abbreviated DAPT or a control population. And we can see that in the end of the day, we really have to understand high bleeding risk patients get a great result. Take account the stent choice, and if you do a good job with those two, you can definitely abbreviate the DAPT. Keep in mind that this type of patients represent a vulnerable subgroup, underrepresented in the classic trials. That's why we study them separate now. IVUS and other imaging, OCT and other imaging, optimizes stent implantation. You're very concerned, you have to use it. Next generation DS has superior safety efficacy, and several of them sequentially test very favorably with abbreviated DAPT even to a year, and recent studies have shown safety and efficacy of shortened DAPT in HBR patients following PCI with drug-eluting stents. So we do have the answer. We just have to be very careful, very organized, and do primarily a good job in our cath lab with great implantation and the follow-up as suggested. I'd like to thank you for your attention.
Thank you, George. That was wonderful, and a comprehensive review of patients and how to manage them with high bleeding. I have one very brief question, because we won't let you go out without a question. Do you think, first of all, congratulations on the Twilight trial and the data. Do you think the data from Twilight, in your opinion, could be extrapolated to other antiplatelet P2Y12 agents?
Yeah, well, first of all, the classic answer is that definitely not for clopidogrel, because we know that there is a lot of clopidogrel-resistant patients, particularly when you talk about high-risk patients treated with rotablator. For example, we have studied before and published it in JACC Imaging that patients with long calcific lesions, for example, those we need rotablator or cutting balloons or orbital atherectomy and all that, all of them, many of them, tremendous number have clopidogrel resistance, just like a lesion-based characteristic we have to think about. Now, when you go to prasugrel, then of course you can say it seems very reasonable, because this might be you know, very high efficacy oral agent as well. That hasn't been studied yet, so anticipate that it has very high likelihood for this to happen once the study continues. And of course, we're targeting now to abbreviate it even further and see if we can go in a follow-up study, and even hopefully with STEMI, including STEMI, because that's a population that was not included in original Twilight. We can go down to 1 month and then drop the aspirin after 1 month. We'll see about that. And if this happens, we'd like to have many sites from India as well.
Thank you, George. Handing it over to Dr. Kahali to moderate the session.
Yeah. No, you please, Subhash, you please continue, because, you know, the session is on you now. I am just an anchor, you know. And just on behalf of the CSI NIC, we let Dr. Dangas our profound gratitude, and, you know, for coming and for giving his valuable time, even on a Sunday evening. And it was a terrific lecture, brilliant lecture, and it was real pleasure. And at present, 1350 delegates are watching the proceedings, along with approximately 30 to 40 faculties. And I thanks also Subhash, and I would request Dr. Ramesh also to assist with other moderators, because I am off now. I am only an anchor, just to thank Dr. Dangas, because he has come for the first time. Thank you, Dr. Dangas, again. You are welcome. Thank you very much.
Thank you. Thank you.
And Dr. Dangas, we would also like to collaborate from CSI NIC. It is the All India Cardiological Society of India and National Intervention Council. So we would like to collaborate with you in our future endeavors. Thank you very, very much, sir. Thank you. Brilliant speech. Thank you.
Thank you. Congratulations for your conference once again. And I like how modestly you say you're just presiding. I'm sure you've arranged many, many things, so just this word. And I like to thank also the over 1,000 participants right this moment, and we expect to see many of them in the in Sky Bifurcation and other initiatives with your society. Good day from New York.
Thank you very much, sir. Thank you very much, sir. Thank you. Thank you,
Thank
sir.
you, George. And so let's now proceed with our next lecture, which is going to be given by no other than Manos Brilakis. He's going to be talking on managing coronary perforations, and Manos and Subhash have worked together for several years, and now Manos has moved to Minneapolis, and so as you know, he's a good friend of Sky, and he's visited NIC Sky sessions in India several times. Manos. Probably a muted, Manos.
Oh, sorry, I did the same mistake as Dr. Dengue. So I'm sorry for that. So again, I'd like to say thank you very much, Ramesh, Subhas, and Dr. Kahali. Again, it's a great opportunity to be with you this morning or this evening.
Welcome, sir. Welcome to CSI NIC. Yeah.
Thank you. And this is a topic that I'm very passionate about. I've had a lot of perforations for good or for bad reasons. And I think I'd like to share some of the lessons I learned doing those procedures and how to manage perforations, which remains a severe complication in the cardiac cath lab. These are my disclosures. And these are a brief overview of the acute complications of PCI. And when it comes to coronary complications, there are three main types. You either close the vessel, or you perforate the vessel, which we'll discuss today, or you lose equipment in the vessel. And when it comes to perforation, traditionally, the classification has been about severity. So the Ellis classification, Ellis 1 is a small perforation, 2 has more than 1 millimeter, Ellis 3 is a large perforation, and Ellis 3 cavity spilling if it goes into a cavity. But this classification does not really help us as much regarding treatment. And I think classification based on mechanism and location of the perforation is what matters more, because the treatment is directly related to that. And we like to break them down into three main categories. One is the large vessel perforation, for example, a mid-RCA perforation. The second one is a distal perforation, for example, a distal branch, typically with a wire. And the other type is collateral perforation, either through a septal or an epicardial collateral. These are mainly CTO PCI related complications. But this classification is important because treatment depends on that. In a recent analysis from our institution, about 3/4 of all perforations were main vessel perforations, and 1/4 were distal vessel perforations. And this is our algorithm for treating those perforations, which we break down into two parts. One is the universal, so to speak, algorithm, which are measures you can do regardless of the type of perforation. And the second one is the type-specific treatment. How can you do to seal off the perforation? So we'll start with the general measures. The first thing you should do when a perforation happens is to inflate a balloon proximal or at the perforation, because the faster you do that, the less blood into the pericardium, the less chance of getting tamponade. Now, how far can you go? Again, you shouldn't go too far into the vessel, so you can sometimes have the vessel stretched too distally. Low pressures, 6 to 8 atmospheres, 1-to-1 sizing of the balloon. The second thing is give intravenous fluids, and you might need vasopressors. And typically for this, we use norepinephrine. Again, there's no specific one, but if you start getting hypotension, vasopressors might help you temporize until you get the pericardiocentesis to relieve the tamponade. The third one is to do pericardiocentesis if the patient develops hypotension, and we typically will aspirate the blood and give it back through a peripheral vein to minimize the amount of blood loss. This is an example of a patient. This is the baseline. This is after the patient developed a tamponade. We can see two things. One is that the heart rate is increased. So tachycardia commonly happens in case of tamponade, but not always. For example, if the patient is on beta blockers. And also we see a pulsus paradoxus, which is a decrease in the systolic pressure with inspiration. Echo is very useful for guiding pericardiocentesis, but if the patient is developing tamponade that is unstable, we should not wait for the echo machine to arrive, but perform pericardiocentesis directly. And one actually nice thing about pericardiocentesis in the setting of perforation is that there is often contrast into the pericardium that can be used as the target for a pericardiocentesis needle. This is an example where we see the outline of the heart, and then we see contrast into the pericardium, so we know exactly where to advance our needle. And this is the example of the needle going up into the pericardial space. I am a strong advocate for not showing fluoroscoping our fingers. However, in life-threatening situations, that may have to be. And then we move on to notifying the surgeons. And although we almost never need surgical treatment, I think it's a good idea to give them the heads up. So in case there are issues with operating room organization, they can be sorted out if the patient needs to go to the operating room. So these were the general measures, regardless of type of complication. And now we move on to the specific causes and type-specific treatments. So for large vessel perforation, the treatment is mainly a covered stent. Although sometimes prolonged balloon inflations will do. For example, you may be unable to deliver a covered stent due to calcium or tortuosity. Sometimes prolonged balloon inflations, even for hours sometimes, can help seal the perforation. And rarely you can actually do CTO techniques. For example, we had some RCA CTO perforations that going subintimal and creating a flap help to seal off the area of perforation. How to prevent it? Well, you want to avoid oversizing the stents or the balloons or going very high pressure. You should be extremely careful when there's severe calcification because those vessels are more prone to perforation. Balloon rupture is one of those mechanisms that can really be a problem. If balloon ruptures, it can be a pinhole rupture causing a focal area of injury on the wall of the artery. So if you have rupture, the first thing is take everything out, aspirate the guide, and take an injection to make sure you do have a perforation or not. Also, a atherectomy can do it, and of course, exit of equipment and CTO PCI will do it as well. How do we treat it? As we discussed before, the mainstay is the delivery of covered stents with other techniques that can be used as well. Surgery is very rarely needed. At least in the US, we have currently two types of covered stents, the PK Papyrus and the Graft Master. Maybe there are more available in India. The PK Papyrus is more deliverable and has lower profile, so it's used more often these days. How to do it? There are two ways to do it. One is to use a single guide catheter. The other one is using two guide catheters. That's called the ping-pong guide catheter technique. For a single guide catheter, this has to be usually at least 8 French or 7 French, depending on the cover stent you have. And this allows you simultaneous delivery of a balloon to prevent bleeding in the pericardium and the cover stent. So these are the steps with the single guide. Perforation has happened. Balloon goes in to seal the perforation temporarily. Then a second guide wire is advanced. We deflate the balloon for a few seconds to advance the second guide wire through that area of perforation. And then we reinflate the balloon until we get the cover stent right to the proximal edge of that lesion. Then we deflate the balloon that is causing the hemostasis. We remove it. We advance the cover stent across the perforation site, deploy the cover stent, and that should achieve hemostasis. Now, if you have a smaller guide, then you may have to use a second guide catheter. This is how this is done. The first guide has the balloon in, achieving hemostasis. At the same time, you bring in a second guide catheter, temporarily deflate the balloon, advance the guide wire, advance the cover stent, remove the original balloon causing hemostasis, deploy the cover stent, and you've got sealing of the perforation. This is an example. LAD perforation in the setting of LAD CTO. It happened because of balloon rupture. So what to do next? The first step is to put a balloon. This was proximal to the area of perforation. Then here it was a smaller guide. We placed a second guide catheter inside the left main. We had difficulty delivering the cover stent that was in the area of graft masters. But then through a guide extension, we were able to successfully deliver the cover stent to the area of perforation, and that successfully sealed the perforation. Very important for any cover stent to post-dilate it to make sure it's well expanded and causes adequate hemostasis. Moving now to the distal vessel perforation. This difference because the main treatment there is embolization, usually with fat or coils, although sometimes a cover stent can be placed over the perforated vessel origin. Now, how to choose between the two? Obviously, fat is universally available. It is free, but the challenge is you cannot visualize it as well. So we dip the fat into contrast for a few seconds, usually about 30 to 60 seconds to get some contrast in it and visualize it. The advantage of the coils is they can be visualized very well. You know exactly where you put them before you release them if they're detachable. So they give you more control over how you occlude the vessel. Very important to prevent this. And I'm a big advocate that you should never stand over polymer jacketed wires. You should try to remove those wires and put a workhorse wire in before placing balloons and stents. Also, be careful when you use collimation. You should always check the distal position of the wire so that it doesn't go to places you wouldn't like it to go. So how to treat it? As we mentioned, usually embolization is the key. Cover stent is another option. Surgery is rarely required. These are some of the coils you can use. I strongly encourage you, if you can, to have 0.014 inch coils, because those coils are actually delivered through any microcatheter we use for PCI. So you don't have to change the microcatheter. So that makes this easier and faster. Also strongly encourage you to have the detachable coils, which means that once you deliver them, then you can pull a lever and then deploy them. If you don't like where they are, you pull it out and reposition it. This is how this is done. Very similar with before. The first step is to get a balloon to achieve hemostasis. The second step is to transiently deflate the balloon, advance a second guide wire close to that area of perforation. And then the third step is to get a microcatheter. Now, once you cut the microcatheter there, you inflate the balloon proximally, and you have the luxury of time because you don't have active bleeding through that area of perforation. And also you can inject to the microcatheter to see if you've achieved sealing or not. The next step is to deliver the fat or coil through the microcatheter and then inject to the microcatheter to confirm whether you have achieved hemostasis or not. This is an example of a perforation of an acute marginal branch. You can see it's a very, very small branch, but we were able to advance a microcatheter and then place a small 0.014 inch coil. And this is the perfect embolization because we closed that small vessel, but we did not affect the other vessel. Even though it's small, still it's best to minimize the amount of injury to the myocardium. Another way to get this done, if you cannot deliver a coil, is to cover the ostium of the perforated vessel. And that's similar to the large vessel. You get a balloon, you get a covered stent, and then you deploy the covered stent across the origin of the perforated branch, achieving hemostasis. So this is an example. This is a patient who had multiple restenotic events in the right coronary artery. It was extremely challenging delivering equipment. Look at the position of this wire. This is a workhorse wire. So you would think no big deal, but it's clearly going into a small side branch. And with all the movements back and forth delivering the stent, this can be a bad thing. And sure it was, because we can see now that we do have a small distal vessel perforation, even with a workhorse wire in the setting of aggressive movement. What do we do? Once again, get a balloon in to make sure we achieve hemostasis, give fluids. And then here it was such a small branch, we could not really deliver any microcatheter into that area. So we decided to use a covered stent instead. This is injection through a microcatheter. But eventually what we did is we deployed a covered stent across the origin of the branch, and that achieved hemostasis, and the patient did well. We did not have to do pericardiocentesis in any of those cases, and the reason was because the blocking balloon was inflated quickly. So to summarize, perforation can be a catastrophic complication. When it happens, the first step is inflate the balloon, give fluids, do pericardiocentesis if needed, call the surgeons, and then treat the cause, cover stents usually with large vessel, and embolization for distal vessel perforation. Importantly, for anticoagulation, you don't want to reverse it until after you have removed your wires and balloons from the vessel, because otherwise you may get vessel thrombosis, which can be a catastrophic complication. If you have to reverse it, however, you can do so after you've removed the wires, and typically this is with proton. And then be careful, don't reverse it too quickly. Here's an example of stent thrombosis in this first case after the ACT went down while working on another lesion. So don't reverse the heparin until all the equipment has been removed from the coronary artery. Rarely, if everything else fails, then surgery may be required. Thank you very much.
Thank you, Manos. It's a fantastic talk. You always impress me with the nice algorithmic approach for these type of perforations. I just want to ask you one quick question, and then we move on to Dr. Sahu. Graftmaster versus papyrus, do you have any preference?
Yeah, thanks, Ramesh. I think PK papyrus is much more deliverable, and quite often the vessels that are perforated are hard to deliver. They have calcium, they have bends. So, we mostly use the PK papyrus these days, but sometimes, you may have, you may not have a papyrus size on the shelf. So we actually keep both graft masters and papyrus, but we do prefer papyrus for most perforation.
Okay. Thank you very much, Manas. I appreciate it. And so let's move on to the next speaker in view of time. Manos will be introducing Dr. Subhash Banerjee later, but it's my great pleasure to introduce Dr. P.K. Sahu. He is a senior interventional cardiologist and director of interventional cardiology at Apollo and Bhubaneswar, and he's a good friend. He's involved in several trials and of the devices that come into India as well. Thank you, Dr. Sahu. Can you unmute yourself, Dr. Sahu? He'll be giving a talk on how to tackle slow flow and no flow.
Am I audible?
Yes, now you are. Thank you.
Are my slides visible?
Visible. Can you go to PowerPoint as the slideshow?
Yes, just a minute.
Okay, very good. Thank you.
So I basically have to speak on how to tackle slow flow and no flow. I thank Dr. Kahali for giving me this opportunity to share my experience on how to tackle slow flow and no flow. This is something which every interventional cardiologist must have come across. If you haven't come across, then I'll believe that you're not doing enough interventions. Now, to know what is slow flow or no flow, it is the inability to perfuse the myocardium despite the removal of a large epicardial coronary artery occlusum, manifested by reduced myocardial flow after opening an occluded artery with the presence of a patent epicardial coronary artery. So this is what you see over here. You see the flow has suddenly stopped over here, or in the RCA, the flow has stopped. So this is where the flow stops. Now, let me start with the case. Here there's a subtotal RCA occlusion, and when the guiding catheter is put, suddenly all becomes a no flow. So these are certain situations, but one has to be sure that this is not a classical definition of no flow or slow flow, although there was a guide catheter dissection which caused the no flow. Now we have to find a cause, so that we pass a wire, and in fact the wire was in the false passage, and when we did an IVUS to it, we could see the true lumen and the false lumen. So we knew that our wire had gone from the true lumen to the false lumen, then again to the true lumen, and then the case was, in fact, STAR technique. With the STAR technique, the catheter, the stent was taken, and we got a final good results. So these are certain things which one can get while doing guide catheter-induced dissections. Or sometimes it is not always pathological. You see, this is a very short segment lesion, very easy. Just go ahead, dilate it, and stent it. But after the stent, you see what has happened. It's a slow flow again. So now this slow flow, after doing a little bit of autoperfusion, giving these medications, in fact, the flow came down. But what we discovered later on was, what you can see very closely is that there is an air embolism. The air embolism is something which is very notorious, and when you see some of your juniors working on it, you can see the air slowly traveling across this thing, and these are situations which you get on the cath table where you have to ask the patient to cough very violently, maybe try to do autoperfusion, and then suddenly things come normal, because you can see a pacing wire is inside. In fact, the patient went into complete heart block immediately after air embolization occurred. Now, we are all aware of this, of the TB1, 0, 1, 2, 3 flows, in which the TB0, there is no perfusion, TB1, there is minimal perfusion, TB2, there is a partial perfusion, and TB3, there is almost an entire artery gets perfused. Now, if you come to the definition of coronary slow flow, it has been shown that there is an angiographic definition, and there is no evidence of obstructive epicardial coronary artery disease. That is, no angiographic lesions more than 40%, or there is a delayed distal vessel contrast opacification, as evidenced by any of this, either a TB2 flow or a corrected TB frame count more than 27 frames, that is, images acquired at the rate of 30 frames per second, or the delayed distal vessel opacification is at least in one epicardial artery. Moreover, we have to exclude the no reflow phenomena, the coronary emboli, the coronary ectasia, and the exogenous vasoconstrictor administration like cocaine, which have been known to cause coronary slow flow. Now, in sum, one can say no flow is TB0 or 1 when you do not have any dissection, spasm, stenosis, or thrombus. Now, if there is a TME2 flow, it is considered as slow flow. And whatever be the condition, whether it's a no flow or a slow flow, the prognosis and complications are the same. Now, what is a pathophysiology? We all know that atheroemboli and thromboemboli, ultimately they lead to either plugging or platelet aggregation. But it is a spectrum of ischemia reperfusion that works, thrombosis, atherothrombosis, and vasospasm. All these work together and ultimately lead to the phenomena of slow flow or no flow. Now, overall, in all PCIs, it's approximately 2%, primary PCI 12%, SVG PCI 15%, and rotational atherectomy having the maximum of almost up to 15 to 16%. So this is the order of incidence of no flow as has been seen in various studies. Now, let us take acute MI situations in which there are various causes. I would like to elucidate all of this because there is microvascular plugging, distal coronary embolization, intravascular thrombus, mitral edema, ischemic perforation injury, spasm, hemorrhage, inflammation, and endothelial swelling. Any of these or a combination of these can all work in no flow in acute MI. Let us see this case, ectactic arteries. You can see the LAD flowing ectactically. See the RCA. Very slow flow because there's a big chunk of thrombus sitting on this thing, RCA. Now, when in these such cases of slow flow, it is foolishness to go ahead and chase such thrombus. Better would be to just give an intracoronary thrombolysis. And you see after the intracoronary thrombolysis, the results have been good. So such ectactic arteries which can present with slow flow or no flow, it is better to thrombolize them rather than to chase them because they're ectactic and you won't get the right size of stent, and these are big chunks of thrombus. Now, if you go into elective setting, there are even the same phenomenon of microvascular obstruction, distal coronary embolization, secondary ischemia and cell death, microspasm, and secondary inflammation all takes place to cause this no reflow phenomena. Now, let us take this case. There is a lot of thrombus again sitting in the RCA. The wire is passed and you can see there is still slow flow. And after that, what you can see over here is that a thrombosuction has been done because there are just to clean up the artery. The first thing that would be done for a slow flow situation would be in such thrombus setting lesions in ACS. One would like to do a thrombosuction, but there are a lot of debates about it. But definitely slow flow is slow. Naturally, thrombosuction does help. Now, after that, when the stenting has been gone, we got a good flow post-thrombosuction, took a stent, but finally you see what has happened. There is again a slow flow again. So this is very common sometimes in acute setting. When they put a stent, you'll see that slow flow does take place. So the next thing that was you start giving intracoronary pharmacotherapy, you start giving all these verapamil or adenosine. When sodium nitroprusside in these doses are very good, and nitroglycerin or epinephrine can be given, and you can see such a good flow. All these doses are almost 100 microgram, given up to 3 to 4 doses, excepting for adenosine, which is 1/4 the dose of the other agents. Now, if you come to slow flow in the planned case of PCI, you can see this is a very straightforward mid-LAD lesion, which looks like a case where a direct stenting can be done. But then you see after dilatation has been done, we get and a stent has been put, you can see there is a slow flow. Even slow flow can occur post-stenting, and if you try to see, if you give autoperfusion in such cases after doing it and give a post-dilatation and give intracoronary nicorandal, the results are good. So ultimately, it is not only in the acute coronary settings, but also in chronic coronary settings, where you can get such flow situations. Now, it is very important that you have to know when, in what percentage. Almost 20% of the cases of primary PCI and less than 2% elective PCI can have this thing slow or a no flow, and all depends on how much of ischemia, the duration of preceding ischemia that has taken place. The mechanisms have already been discussed by me. Now let us see what happens if you get a slow flow or a no flow. First, you try to rule out there's no thrombus, no spasm, no dissection, give good amount of NTG, and see for 3 points. Check your ACT. Keep the target of approximately 300. If you're going to put an OCT or a Rivas catheter, for hemodynamically stabilize it, you might have to give inotropes and an IBP if required, and then start taking a delivery system either through the guiding catheter or over the wire catheter or the microcatheter or aspiration catheter, and start giving any of your pharmacotherapy drugs as I have discussed. Now, this is a case of rota which was being done. The SERP was a tight calcific lesion, a rota ablation has been done. And we know that post-rota, there are cases of slow flow is very common. And in fact, you see just after the rota, you can see the circ is not flowing well, and then it is after giving this thing nitroglycerin and nicorandil, the flow is better, and after stenting it, we can get a good flow. So one has to be prepared in such cases where you expect that these patients might have slow flow or no flow, so you have to prepare the patient properly. So now what happens in cases of rota? Try to have shorter runs, slower speeds, smaller initial burst size, gradually increase the burst size, and you can give a cocktail of this thing that is diltiazem, heparin, nitroglycerin, nicorandil. Now, if it is a elective SVG PCI, distal protection device is a must, and you have to give a newer antiplatelets. And if it is STEMI or a non-STEMI, if a thrombus aspiration and a GP2B3, it does help given in cases of slow or no flow. Now, there are certain troubles which come uninvited. You see, for example, in this case, you see this is an RCA. The wire has been crossed, and after crossing, you can see a slow flow. And then after that, the balloon dilatation was done, and just to see an OCT catheter was put, and just see what is there in the OCT. Very interestingly, you'll see a honeycomb appearance. But if you see this honeycomb appearance has got a very peculiarity that none of the cells that you see are any ragged size. They're all uniformly round shaped cells that you see in a honeycomb. This is not a picture of a recanalized thrombus. In fact, what had happened was that there was air embolism during OCT catheter flushing. So this is very notorious that you have to be very careful once again. If you ask your assistant or technician to be flushing the catheter, they may flush it and finally you may land up with a slow flow because your OCT catheter, air has entered the OCT catheter. Then this was the final result. So you see that you can clearly see that the stent has been deployed, and after the stent has been deployed, the results are quite fine, nice, and this shows the good apposition of the stent. So one has to be careful, especially for air, because these are one of the most commonest problems which new beginners and even operators, senior operators can accidentally push an air into the coronaries and can cause problems. Now, sometimes it does happen that nothing works at times. This was a case of infeval LMI, where you can see there's a total cutoff of the circumflex and there is a tight lesion in the OM. And also there is a lesion in the LAD. The lesion, spot lesion in the LAD. This patient comes with infeval LMI, and then because there was a lesion in the OM and the circumflex, a bifurcation stenting was done, and what you see after the bifurcation stenting, the circ is not flowing well, and that is the time when the patient starts developing bradycardia, and there is slow flow, the hypotension starts coming down. We give inotropes, and as I told, first try to maintain the blood pressure. And this is where when the hypotension occurs, you might have to put an intra-aortic balloon and try to see also, in fact, we tackle the other artery, hoping that the patient would do well. But believe me, the patient never did well, although the patient was intubated, the patient was this thing that is put on a pacing wire, but somehow the patient didn't do well. So there are implications of the slow or no flow, that is, they have higher post-infarction complications like arrhythmias, pericardial effusion, cardiac tamponades, early congestive heart failure. They have an adverse ventricular remodeling, and late repeat hospital stays, and patient can go into heart failure and ultimately land up with higher mortality. And this is very common that you can get episodes of ventricular tachycardia where sudden death can occur due to slow flow or no flow. So if you have to summarize or to cut the long story short, it is pre-procedure, you optimize the glycemia, optimize the blood pressure, give good amount of statins and effective DAPT. Per procedure, give nitrates, optimize the anticoagulation, give GP2B3 inhibitors, follow the stringent rota protocol, and a venous graft, you use a protection device. This is how you can do prevention. But if you have already developed a no flow, definitely first stabilize the patient hemodynamically, give selective drugs with adenosine or without adenosine, and also give GP2B3 inhibitors, and they do work. So sometimes you do succeed, but please remember that slow flow or no flow is there. Definitely sometimes the end-term results are hazardous. So as was said in a Chinese proverb, that be not afraid of going slowly, but be afraid only of standing still. So it is not that if there is a no reflow that you should be afraid. You should also be afraid of even of going slowly, because both slow flow and no flow have all bad outcomes. And so one has to be prepared and has to finally give good results so that there is a good TB3 flow. Thank you very much for your patient hearing.
So I would invite the next speaker, our good friend, Dr. Subhash Banerjee, to come and take the podium. Dr. Subhash, please. Dr. Banerjee, you are the next speaker. Okay, okay, Subhash, yeah.
Thank you very much for inviting me. And I really loved Dr. Sahu's expression of a trouble uninvited. My message today would be, it could be uninvited. Is it really unanticipated? And my talk is going to be about retrieving stuck hardware and devices. Here are my disclosures. Let me start my talk about potential causes of stent loss. Now, talk to Baba because he's already in that room for. So I think stent loss, as I said, could be uninvited, but I think there are various factors and causes that can highlight the potential of this occurring, and therefore it need not be unanticipated. And some of these key criteria are tortuosity and calcification. Poor vessel prep and the intention of stenting directly, even in the presence of tortuosity or calcification. Stent delivery through another stent always increases that probability, especially if the proximal stent is not fully dilated. Use of small French guide catheters, forceful stent withdrawals, and pushing of stents through guide extension catheters and not realizing the resistance that one could encounter. And of course, the very rare occurrence of retrograde delivery through a collateral. All of these could be potential causes of a stent loss. Now, I think one of the most common things that I have encountered in my own career that could have led to an avoidable stent loss is not probably feeling the surface of the stent after a difficult delivery attempt before it was reinserted into the guide catheter. I think a close inspection of a stent in that situation can avoid a lot of troubling situations. Here is an example of published literature where a stent loss occurred during delivery through a septal perforator. I think this is fairly uncommon and not commonly used, even in the most experienced hands and experienced CTO operators. So it's a rare occurrence. However, it does occur and raises the possibility as shown in this publication in JIC. Now, the most common cause, in my opinion, these days is pushing stents or trying to retrieve stents through or into a guide liner or in a support catheter or a guide extension catheter. I think this is fairly common, and sometimes when we are pushing multiple devices and have more than one guide wire, I think the risk of that could be accentuated as shown in this figure. How to prevent and avoid stent loss? I think one is meticulous vessel prep, and especially if there is calcification, and avoid direct stenting. Stent from distal to proximal, fairly basic principle, but often that is violated where delivery is difficult. You can't retrieve the stent, the proximal stent, and it is delivered underdilated and underexpanded, and you want to deliver a stent distal to it. I think those are situations where one can anticipate a stent loss and try to avoid it. Guide extension delivery and should be very carefully performed, even though it is quite frequent, especially with radial access. And to avoid forceful pushing and pulling of stents and withdrawal of stents into such catheters, especially into guide catheters. And if you feel a resistance, stopping and inspecting and reanalyzing the situation is quite important. And of course, 5 French guide catheters, at least in my practice, is quite rare, but I think avoidance of small guide catheters is quite important. And finally, the point of inspecting stents that did not deliver before reinserting them. This is an algorithm drawn by Manas and published. I think this algorithm is very, very useful. Actually, it hangs on a piece of paper in my office. And despite many years of interventional work, I think it is worthy of recalling. And I think it clearly outlines the potential location of stent loss and the retrieval or deployment mechanisms that could be used or employed. And I think I'm not going to take you through each aspect of this scheme, but I think that familiarity with these techniques and strategies, and also familiarity with specialized devices that could help you retrieve lost hardware and stents inside the coronary is especially useful. It shouldn't be the case that one is going to use a specialized snare for the very first time after the stent loss has actually happened. And therefore, some sort of protocol of trying to get some experience with handling of these devices on table has been is quite useful. And when I and Manas used to work together, we used to very frequently try out new devices and take some pictures of it and get some handle on how to use them in a real life situation. Here is a old case where you can see the very eccentric lesion in the left main, the very calcified lesion with multiple bends in the circumflex. And as expected, however, that the delivery of this would be extremely difficult. And after intravascular ultrasound, multiple stents were lost in the proximal segment of the vessel, that is the proximal circumflex, and into the left main coronary artery. And I'm not going to take you through each step, but it was very difficult to cross with the stent into the mid-circ. And here is one stent deployment and the second stent deployment that was attempted that led to TIMI zero flow, and as we said, loss of flow and slow flow and ST segment elevations, and multiple options and highlighted on the screen need to be considered at that time. If the stent could not be retrieved back into the guide, and deploying the stent and expanding it as best as possible is one of the best techniques in this situation. And once multiple stents couldn't be deployed into that mid-circ lesion, this is a picture of one of the real-life stents that came out. As you can see, the stent integrity has been destroyed and disrupted, and trying to reinsert it would lead to a catastrophic outcome. Here is the summary of the two stents that were deployed in the left main after being shearing off. And after that, the guide wire was exchanged to a more stiffer guide wire. And in the absence of guide liner, the Proxys catheter, which is no longer in use at that time, was delivered through the proximal stents as a guide extension catheter. And the distal circ and the mid-circ lesion was pre-dilated and treated successfully, salvaging the day and for the patient. So the message is that this is one technique of addressing unexpanded or stents that shear off the balloon, that is deploying them on position and post-dilating them and using guide extension catheters through them after adequate inflation so that you can avoid stents catching through the previously deployed stent. Another technique that we have commonly employed is retrieval of the stent using a small balloon, as shown in this cartoon and published by Manas in his book, and that is passing of a 1.5 or a smaller balloon through the underexpanded stent over the guide wire. But as you can imagine, this assumes that the guide wire is still in place and the underexpanded stent has not floated distally into the vessel, and which can actually occur in many rare situations. The balloon is inflated distal to the guide, to the under-deployed stent, and then it is very carefully withdrawn into the guide catheter and then moved and removed from the coronary artery. This is an example of an attempted CTO crossing in the mid-LAD with antegrade wire escalation strategy. After crossing, attempted stent delivery, and you can see on the panel to the right that there is the shearing of the stent off the balloon during retrieval and during manipulation of the stent, as it couldn't be advanced easily into the distal part of the lesion. During this, a balloon catheter is advanced, 1.5 millimeter balloon distal to the stent. You can see the central marker of the balloon. And after inflation, the stent is, along with the balloon, is withdrawn back into the guide catheter very, very slowly. This is very clearly demonstrated here. And then it is removed from the body through the TUI bores and copilot catheters, as you can see here. This is the contraption. As you can see, the distal balloon extends beyond the stent, and this is exactly in this position that the under-deployed stent is actually withdrawn from the coronary arteries. The use of snare, I think, is one of the very most important aspects that an operator should be proficient with. There are various types of snares. It could be either used through the main guide catheter, or in some positions even through a second guide catheter that is brought to bear to deliver while the wire position is maintained in some situations. There are multiple kinds of snares. The end snare, which comes in 18 to 30 millimeter and multiple diameters. The Ampla's gooseneck snare, and also handmade snares where a guide wire is passed through a support catheter and then reinserted back at the tip to create a loop, which could be then used to grab onto stents and other devices or other hardware in the coronary arteries. You can even use a guideline catheter for it, as it provides more control over the distal tip. This is an example on a tabletop version of using the snare, as you can see, deploying it and grabbing and then withdrawing the device into the catheter is something that one should be quite aware with and have a minimum set of these snares in your cath lab. This is the gooseneck snare and the end snares, as I showed you, and this can be also used to retrieve. This comes in large and also in small micro sizes. And then the whole category of the micro snares, which is the micro elite snare, which comes in 2 millimeter, 4 millimeter, and 7 millimeter diameter, that has become quite popular in the US and is stocked in most cath labs along with the micro end snare. Here is a case example of the use of the micro end snare. I didn't want to take you through the entire case, but this is a stent that was left underexpanded in the left main coronary artery. The wire position is maintained, and then a second guide catheter, a second catheter is used to deploy the micro end snare and grabbing the floating stent and then removing it from the body. As you can see on the right-hand side, the end snare has grabbed onto the stent. And here is the more magnified picture of the retrieved stent. Twirling of the guide wire technique, I've actually, to be honest, never done this personally, but I think it is a careful technique where a guide wire could be twisted, and the guide wires with the pre-existing guide wire can wind together and create a knot and distal to the entrapped stent, and both those guide wires could be gently removed. With good luck, you'd be able to get this out. Here is an example of a trapped guide wire, and this is not a polymer jacketed wire. And after stenting of the LAD across the circumflex ostium into the left main, as you can see, the guide wire in the circumflex could not be removed. Multiple attempts by passing a support catheter and pulling with a support catheter closer to the insertion site were unsuccessful. And more we pulled on the guide wire in the obtuse marginal branch, more unraveling of the guide wire actually happened. And you can see the OM guide wire is completely stuck in this situation. And multiple attempts of using the guide wire with a snare and grabbing it and pulling at it, all of these strategies were completely unsuccessful. This is the use of a end snare, micro snare elite, and a gooseneck snare in sequential fashion, trying to grab into and remove the hardware. And each time we attempted this, the situation got from bad to worse. There was a point where we realized that this would not be successful percutaneously. And as Manas highlighted in his pericardiocentesis talk, that alerting the cardiothoracic surgeons is actually an important step, and to think of bailout measures as the safety of the patient is paramount. And this had to be removed in the OR after final injection was taken, and the guide wire that is looping in the coronary and stuck behind the stent and in the aortic cusp was left in place. Here is the image in the OR of the completely unraveled guide wire. It's like a mesh of guide wires, as you can see, and that was removed successfully. And this kind of a situation can only be handled in an operating room, and therefore one should be very careful in terms of to notifying the OR and recognizing once it's a point of no return. This is another case of a LAD CTO, where the mid-LAD CTO is crossed And the attempt is made with a knuckle wire. This I can see is quite common. As you can see, there is a microcatheter, and the guide wire is completely looped on itself and twirled so that it couldn't be removed, and the knuckle is completely entrapped. This is another view of it. The wire broke trying to push it, and then at that point, to relieve the entrapped wire, a second guide wire had to be placed, and it had to be ballooned so that the entrapped guide wire is freed from the vessel wall, and at that point, the microcatheter was able to pull and remove the fragment of the guide wire here. This is no conversation about trapped device can be without a trap burr. This is one of our cases where you can see on the left panel, the very tortuous, heavily calcified segment of the right coronary artery. And if you notice very carefully, there is a movement of the guide wire from the middle panel to the extreme right panel with the movement of the burr. And that already tells you that there is some sort of interaction which shouldn't happen, and that happens mainly in very tortuous small caliber vessels. And at that time, we realized that the guide wire actually was moving and the burr was stuck. At that time, a second guide catheter was brought in, a parallel wiring of the RCA was performed, and after multiple gentle inflations, the burr could be retracted and removed successfully. So my conclusions for you is that although a device entrapment can be uninvited, it need not be unanticipated, and therefore anticipation and recognition of complication is important. I also favor the concept of responding, not reacting, and this can only be done by familiarity, by a step-by-step approach and consideration of bailout options, as I've shown to you. I also want to strongly mention that our egos should not prevail, and we should very promptly and early on call for help. And if there is a colleague, especially a senior colleague, can be of great help and be a calming influence. And finally, there is no substitute for familiarity with devices and techniques. And I think hands-on experience with filters and coils before you first time deploy in the coronary on tabletop is actually mandatory and should be done routinely for cath lab staff and for the operating and the performing physicians. Thank you very much, and thank you for the kind invitation.
Thank you, Dr. Banerjee, Subhash Banerjee, for your excellent talk. And if you kindly ask Professor Brilakish, and if Dr. George Dangas is also there, to just precisely summarize the session. And thank you also for giving your valuable time since very early morning, both to you and to Dr. Ramesh Dagubati. Ramesh, you are there? So if you kindly invite your friend, Dr. Mahmood Brilakish, we are very proud of you, and we see the chapters in, Brownwell's textbook of intervention. You have written on SVG intervention brilliantly, both of you friends. So please call Dr. Brilakish and ask him to precisely summarize the session.
Thank you so much again. It's been a pleasure. And I think we learned a lot of things in the session. I mean, starting earlier on, we learned about the importance of careful achieving an excellent result in patients at high bleeding risk so that the risk of stent thrombosis and other complications can be minimized. Then we did learn about the importance of having preparation for perforation and knowing the techniques, get a balloon up, and then use cover stents or embolization for treating perforations. Then we went over the slow flow and the importance of vasodilators as well as intravenous antiplatelet agents if slow flow happens. But first of all, you want to exclude other complications like dissection or perforation. And finally, with Dr. Banerjee, we had an overview of what can happen if there is entrapment or loss of devices and the importance of having equipment for retrieval, such as snares, to facilitate getting the things out. But don't forget that sometimes maybe deploying the device, if it's a low stent, might be a safer and faster way than actually retrieving it. So again, an excellent session. I would like to thank the organizers, Dr. Hali and the whole panel for a lot of learning for some very complex clinical situations.
Thank you, Dr. Brilakish, for your excellent lecture, then your beautiful summarization of the session. But due to paucity of time, because legions are waiting, Professor Greg Stone, Professor Jeffrey Popma, all are waiting. So we can't make them wait. So because of paucity of time, and if you kindly don't mind, I would request you to be with us to chair the session along with us. So the next session is by Legion Speak, and our first speaker will be Professor Jeffrey Popma, and this will be chaired by Dr. P.K. Dev, Dr. Satyavan Sharma, our past president, Professor K.K. Shetty, he is also our past president, Dr. N.N. Khanna, who is a very famous interventionist, Dr. Devobrata Rai, and so I would invite all of them. Dr. Devobrata Rai, Dr. Minal Das is there. Can you call Dr. M.K. Das also? He is our president at present of Cardiological Society of India. So I would give it to our chairperson, Professor P.K. Dev, to kindly proceed. So Subhash, please stay with us. Dr. Ramesh and Dr. Subhash. Yeah.
Niman, will you please request the next speaker to come to that and to deliver his lecture?
Okay.
Yes.
So I would request Professor Jeffrey Popma. It's our great pleasure to give you, and we are immensely grateful to you for giving your valuable time in the morning hours, especially over there on a Sunday. And we are very, very thankful, and we welcome you on behalf of Cardiological Society of India and National Intervention Council, and I invite you to deliver your lecture on tips and tricks for high risk and complex PCI. And also I want to let you know that almost 1,500 delegates and faculties together are waiting for you eagerly to listen to your Legion Speak. Thank you very much, Professor Popma, and we again tell we are very, very grateful to get you. And he is the Vice President, Chief Medical Officer, Coronary Renal Denervation, Structural Heart Disease of Medtronic, and everybody knows him, and nothing is sufficient to introduce him. He is a great teacher, he is a master of masters, he is professor, and he has written so many papers and always see. Thank you, Professor Popma, for your kind consideration. Please deliver your lecture, sir.
Thank you so much. Can you hear me okay? I think you
yes,
probably
yes, sir. Absolutely,
excellent.
absolutely.
Thank you so
much.
Welcome,
sir. Welcome.
Well, it's a wonderful pleasure to be here with you. Your evening, my morning. 3 months ago, I left my professorship at Harvard and my faculty position at the Beth Israel Deaconess and became a full-time employee at Medtronic as the chief medical officer, or as the vice president, chief medical officer, and it's been great. It's been a wonderful 3 months. I missed the cath lab. It was great seeing the cases earlier today with Subhash, and I think that what we really need to do is to kind of focus on how we can incorporate some technology into this. Now, the only disclaimer I have is that I'm actually now limited to need to stay on label for a lot of my discussions and talks, and I hope to do that. I am going to give some thoughts about high-risk PCI with left ventricular support, which was the original topics. Unfortunately, Greg's following me, so if I go quickly enough, maybe we can have Greg make a couple comments about what's next. I'll give you some historic work that we did when I was with the Core Laboratory at the Beth Israel Deaconess in Boston. I know that you've talked about this topic a little bit earlier, and I apologize, but I want to incorporate some of the changing paradigms that we have right now. And, Greg was part of these days earlier in 2006 when we identified very late stent thrombosis, and we did that with our first generation stents, and we were completely uncertain how long to continue the dual antiplatelet therapy. But in retrospect of all of that, as we talk about these evolving paradigms of antiplatelet therapy and anticoagulants, I think we can agree, it was the first generation stent design that were actually some of the problems for us. Greg led all of the Taxus trials through the years, Marty with the Cypher stent trials, but it's really the polymers that were in the vessels that were causing this late inflammation. But nevertheless, in 2010, we needed to sort it out. And probably one of the most rigorous trials that's been performed in collaboration with industry partners, with the FDA and with academicians was the DAPT trial. And of course, in that trial, everyone went through a 12-month period of open label thiopyridine and aspirin, and then were randomized to 18 months of an additional thiodine, Plavix most commonly, and aspirin versus aspirin alone, and then a washout period that was observed as well. And this was presented by Laura Mori in the New England Journal of Medicine. And we're all familiar with these slides, and I think I just want to point out that we really get an understanding of the balance of the risks and benefits when we look at these slides with their inserts. Now, standard for the New England Journal of Medicine, there are two graphic displays that go into data such as this. There's the differences, the absolute differences on a scale of 1 to 100, and you'll see that on the left side of the screen for major adverse cardiac and cerebral vascular events. And you'll see they're almost indistinguishable when you're looking from 0 to 100. And then there's an insert that gives you more of an idea about what these differences are. And you say the same thing with stent thrombosis on the right side. And what I always take away from these is that these are very, very infrequent events that need large numbers of patients in the groups, almost 10,000 patients, in order to identify these differences. But nevertheless, thiodopyridine plus aspirin had lower events, both for MACE and for stent thrombosis. And that was also reflected in the individual components, particularly myocardial infarction. So that's always the balance. And it's a balance when you give dual antiplatelet therapy, there's a higher bleeding risk, and it's familiar to everybody. And then we really have to come up with patients every day that we sort out who are those patients at higher bleeding risk. And you've discussed this earlier, and I'll go through this quickly. It's related to age, comorbidities, anemias and low platelet counts, bleeding diatheses, and other things that we cause, such as the need for oral anticoagulation, nonsteroidals, and planned surgery as well. And so there's a variety of different ways that one can define a higher bleeding risk as we think about which criteria that we're going to use. And that's important, primarily related to the risk for BARC bleeding over time. And then there's a very, very important risk score that Bobby Ye and others have developed, balancing the bleeding risk with the ischemic risk, and it's very, very useful. Because it's an easy thing for us in our practices that we can actually identify patients who are at low bleeding risk and low ischemic risk, and it's really uncertain that prolonged therapy really makes much of a difference. But when one gets to higher ischemic risks, then longer antiplatelet therapy seems to make a difference. I sometimes keep patients on indefinite dual antiplatelet therapy with very diffuse disease, but we have to balance that with the bleeding risk itself. Fortunately, that we've learned that it's mostly driven by the ischemic risk. Complex versus non-complex lesions are not as important as having the high DAPT scores in terms of their ischemic benefit, which of course we have to balance with this. So I do think this is extremely useful. I actually had to plug in the numbers for this particular patient. 76-year-old, has diabetes, has a small stent, and at discharge, not really much other disease. What's the recommendation for DAPT? And although we can think subjectively about whether that's a useful thing or not, the DAPT score guideline does give us some insight into this particular patient, and that the risk of stent thrombosis, if the DAPT is continuous, 1.6%, but without continued DAPT, 3.1%, MACE barely different, and of course bleeding barely different. At the lower left, you'll see that balance is such that there's really, it's kind of a dealer's choice about one valve is myocardial infarction or bleeding risk more. So it's all about understanding what our duration should be. And in the guidelines by Capodanno, a very nice summary. In patients with high bleeding risk, with an ACS, it's 3 months, and with the stable disease, it's 3 months, and with ACS, it's 6 months, and that's certainly where the recommendations are. And that really set the stage for our Onyx 1 global study design, which was 2,000 patients who were treated either with Resolute Onyx or BioFreedom, 84 sites, 1-to-1 randomization, looking at cardiac death, myocardial infarction, or stent thrombosis at 1 year as the primary endpoints. And it's very important secondary endpoints of target lesion failure and other endpoints such as lesion device and procedure success rates. And patients got in for the sorts of things we think about in our regular clinical practice: older age, anticoagulation, renal failure, planned surgery, anemia, hospitalization last year, thrombocytopenia, cancer, stroke, liver disease, long-term nonsteroidal use, and expected DAPT non-compliant. So in this study of Onyx 1 Global, we found that patients were relatively balanced in terms of their demographics. No real significant differences here. But importantly, in the Onyx 1 Global study, there was an average of 1.6 bleeding risk criteria per patient, and almost 50% of patients had 2 bleeding risk criteria. So I think we can all assume that this truly was a higher bleeding risk population. The patients came off anticoagulation, actually off of their antiplatelet therapy and on monotherapy the vast majority of the time, and that were maintained on single antiplatelet therapy 88% of the time at 1 year. So this is really, for a high bleeding risk patient population, this is really a short duration, and we really have to examine then the safety. And compared to BioFreedom, the Onyx 1 month, the endpoint of cardiac death, MI, or stent thrombosis was the same. The cumulative analysis also showed really no significant differences. And importantly in this study, a landmark analysis starting at 1 month did show significantly less myocardial infarction with the Resolute Onyx than with BioFreedom, but it's just one of many endpoints that was examined. Most all the endpoints are really non-inferior. So I think this really set the stage for 1 month DAPT for Onyx compared to what the 1 month DAPT with BioFreedom stent. And that's true for TLF and cardiac death and target vessel MI and target lesion revascularization. So we needed in the United States to prove that there was also a benefit in the US for our labeled approval. And we, Ajay Kurtane presented the Onyx 1 Clear study at the ACC. That manuscript is now in press. 1 month clear was defined as patients who were adherent to the DAPT within the first month and did not have events that would preclude the cessation of dual antiplatelet therapy at 1 month. It included, as a single arm study, included 1,000 patients from the 1 month DAPT from the Onyx 1 randomized clinical trial, and added to it 700 patients in the US and 100 patients from Japan, again, with same primary endpoints that you've seen before. This is the trial design. It was kind of interesting that 263 patients actually had an event within the first month that required that they continue their dual antiplatelet therapy. But the performance goal primary endpoint of 9.7% was achieved. In the study, 7.7% was the primary endpoint event rate in this combined analysis with the events that you see here. So, these always have limitations of very different factors that affect the generalizability of these trials. Mostly that there was a difference in the periprocedure myocardial infarction rate due to DAPT interruption in the first 30 days. We didn't know about 3 months and didn't know about 6 months, just studied 1 month itself. And of course, there's always challenges of pooling across the different demographies. But at the end of the day, the Onyx Global 1 study was the first DES versus DS trial with the Onyx zotorolobosome stent, non-inferior to the BioFreedom stent. And then the Onyx 1 Clear, first in the United States, the 1 month DAPT in high bleeding risk patients with the current generation device. And that resulted then in a labeled approval for 1 month DAPT in high bleeding risk patients. So I do think that, for the Onyx 1 right now in the United States, it just really happened in the last month. We'll see how that affects physician choices in high bleeding risk patients themselves. We certainly have data that it's supportive, and we've come a long way from 2006, when we were really trying to sort out how long to give the dual antiplatelet therapy. And now we realize, because of advancements in the stent design, antiplatelet therapy, that there's some advantages there. I want to touch on just 2 final topics over the last couple of minutes or so. The first is drug-coated balloons for PCI. And I'd be interested to hear our U.S. physicians understand who are on the line about the need for this. I think that there's a real potential need for this. And I'll share with you Azine Latib's Euro PCR presentation from this year, looking at our Medtronic paclitaxel drug-coated balloon, not approved in the United States, of course, but a smaller pilot study to understand whether the paclitaxel drug-coated balloon was useful in patients with complex coronary disease. And the drug that we used in the PREVAIL study was building on the Euphoria platform. The paclitaxel had a dose density of 3.5 micrograms per millimeter squared, allowed with the excipient to have a rapid absorption. It's a biocompatible urea excipient, and uniform jug coating for delivery. It's on a rapid exchange catheter from femoral and from radial access. We studied, Azim studied on 50 patients who had some native coronary disease, some small vessel disease, and in-stent restenosis. Patients were followed out to 12 months with a primary endpoint of in-stent late lumen loss at 6 months. The demographics were just as we normally see from a study such as this. About half the patients had stable angina, and the target lesions were primarily small vessel de novo, with another group of patients who had in-stent restenosis was treated effectively with that was previous due to a drug-eluting stent. And what I think was amazing, these are the primary endpoints of the trial, what was amazing with this was that the late lumen loss was 0.05. That's phenomenal late lumen loss. Of course, the acute gain is less with the balloon than it is with the stent, but nevertheless, these are very, very favorable late lumen loss rates for both de novo lesions and for in-stent restenosis patients with very, very excellent final results in target lesion revascularization, which really occurred at 12 months in 4.5% of patients in the de novo and 7% of patients with ISR. So, the real advantage of this, you don't put another stent in, another layer of stent for the ISR patients in particular. And I think we're really encouraged about that number for these somewhat refractory lesions. So I think the take-home messages that we have from our DCB program, and I think we're all trying to sort out whether or not there's the appropriate trial in the United States to run to get this to patients with in-stent restenosis and in small vessels, is very favorable late lumen loss rates, very favorable target lesion revascularization rates with no safety issues. And of course, this is with 1 month dual antiplatelet therapy after the procedure. But we really need to study randomized trials, see the value of randomized trials with these drug-coated balloons in complex lesion subsets. The final thing I want to talk about was some work that I actually had done at the Beth Israel Deaconess before I came over to industry. So that's disclaimer. We at Medtronic currently do not have any percutaneous left ventricular support devices. But with Greg on the line coming next, maybe he can make a comment or two about this, because I want to talk about an angiographic analysis that we did as part of the PROTECT 2 trial. As you remember, the PROTECT 2 trial took patients with low ejection fractions. If they had an unprotected left main or last remaining conduit, less than 35%, or 3-vessel disease with an EF of less than 30%, 1-to-1 randomization to a balloon pump or to Impella with the PCI, with primary endpoints at 30 and 90 days. At least to me, one of the most important findings in the study was the fact that the extent of revascularization really determined what benefit one would obtain from the left ventricular support device itself. And we published this in Cardiovascular Interventions last year, looked at 413 angiograms, scored all of the angiograms using myocardial jeopardy scores of 11 points. And then the extent of revascularization was characterized by the change in the myocardial jeopardy score afterwards. And then we looked at the clinical events in a variety of different fashions. Let me give you an example. This is a patient who has single vessel disease, was enrolled in PROTECT 2. And what you'll see is in the upper left panel is that there was a somewhat diffuse disease distal right coronary artery that was treated effectively with stenting. But because there was so little disease, the change in the myocardial jeopardy score was only 2. And that was in comparison to this case where there's multiple disease and multiple vessels. And in this particular case, because the right was treated, the LAD was treated, and the circ was treated, the change in myocardial jeopardy score was 10. So what did that mean? Well, in our subset analysis that we looked, it made a big difference, because in those patients who had limited revascularization, there was really not much value in using a left ventricular support device. 35% and 32% MACE rate at 90 days. However, when extensive revascularization was performed and the change in ischemia scores between 3 and 11, there was nearly a halving of the event rate in those patients who had the Impella device. So I think that really makes a big difference about how much revascularization one's going to do as to whether or not there will be a benefit achieved with left ventricular support in these very complex patients. And we do believe that the extent of revascularization that was performed does relate to the clinical event rates over time. So I think that really where we learned from PROTECT 2 is I think a lot, right? The procedural benefits, we clearly saw those with Impella device, fewer hypotensive events, higher cardiac output preservation, and it allowed more extensive atherectomy in the study. But the clinical event was the clinical benefit of the Impella supported PCI was in a reduction in major events and an improvement in heart failure symptoms that were more pronounced when we went to complete revascularization. And I know Greg has some plans about where we're going to take this information next over time. But I think it's very, very important to understand that left ventricular support probably will be an important part of what we do, particularly in patients who need extensive revascularization. And I think that with the studies that Greg will be leading in the future will allow us to get a good idea about how best to apply this therapy. So that was relatively quick. I got through in 20 minutes. I think I was allotted 25 minutes. So I wonder if we could have a little time for discussion back and forth. We covered the importance of high bleeding risk patients that we've now got good randomized clinical trials that demonstrate 1 month DAPT does work with the latest generation stents. We've got this whole concept of drug-coated balloons. We need to know how to move forward with that. And certainly I think for complex PCI, left ventricular support is going to be very important. So I think I'll stop there, Dr. Deeb, and turn this back over to you. Thank you so much.
Thank you, sir, for your excellent lecture. We really enjoyed it. And, thanks again for giving a Sunday morning to us. And Professor Greg Stone, welcome to CSI NIC. He's also there. So, Dr. Ramesh Dagubati, have you any comments about it? He's in the chair. Ramesh?
Yes, so nice to see both Jeff and Greg on the podium, and really excited to have you as legends for the CSI NIC.
Really,
thanks to Dr. Kahali and Dr. M.K. Das and Dr. Debabrata Roy and Dr. P.K. Deb and all the other exemplary chair people who are there, and Dr. Shetty as well. So, Jeff, I wanted to ask you, do you think that, the stent, and nowadays we are all having short DAPT and everything and high bleeding risk, but what is in it in Onyx that actually you think is specific to make this a little less shorter DAPT time, that you achieved excellent result with Onyx 1?
Yeah, to be honest, I think that all these newer generation stents are going to have much lower stent thrombosis rates than they ever had before. And we were certainly the first to complete the randomized trials and have the sufficient data to be able to do that. There are other trials, Greg may want to comment, but Xience and with Promus Premier, those trials are ongoing as well for short DAPT. It's just not the same stent as we started out with a decade plus ago. It's just not. And so I think that we are getting, less thinner filaments, very biocompatible polymers, drugs that don't hurt the vessel wall. And I think that it's the generation of stents that have really made the big difference for allowing us to shorten the dual antiplatelet therapy. Greg, what do you think?
I think, Jeff, you said it beautifully. I think, the difference in Onyx is that we were able to demonstrate it in a large-scale randomized trial compared to the BioFreedom stent, which, was the first one that really introduced this concept, and I give them a lot of credit in Leaders Free. They were able to demonstrate that you could maintain with a drug-coated stent in this regard, the anti-proliferative properties of a DES while still maintaining safety with only 1 month DAPT. But that was not what I would consider a current generation device. It was a thicker stainless steel strut design. So we've been able to demonstrate in Onyx 1 in the randomized trial that it's got as low or lower an ischemic event rate with only 1 month DAPT. And in fact, beyond 1 month, the myocardial infarction rate was somewhat lower. And again, I think that what we don't know, the Science 28 and 90 data just came out, and that looked very good. That was a single-arm study. There's single-arm synergy data. So we don't know of the current generation premier DES, if you will, whether one is better than the other in this regard. I suspect they're more alike than different because they all have very low stent thrombosis rates. They all have biocompatible polymers, very thin struts, et cetera.
Yeah.
Thank you, Dr. Greg, for your great comments. And I really, appreciate on a Sunday morning, you have given your very, very valuable time. And we missed you in Chennai. You agreed to come, and we had all sorts of, we sent them tickets. Ramesh also couldn't come. So we really missed you, Dr. Greg, on that occasion. But anyhow, in the next meeting, we'll be expecting that you will be joining with Professor Popma, Ramesh, and Dr. William Wins is also there. I would invite Dr. William Wins to come in the podium, and just if you tell your short comments on whether we can take that Giants and Promos Elite is available here, because Synergy has been withdrawn from much of the Indian market because of the recent price tag about 2 years back. So can we take that? All these stents are similar. What is your take on that? Professor William Wins.
Unmute yourself.
Unmute.
Yeah, thank you.
Yeah.
Thank you.
Welcome to CSI NIC, sir. On behalf of CSI National Intervention Council, we congratulate you and we'll welcome you to the City of Joy, sir.
Thank you very much. I don't have much to add to what was discussed just right now. It's clear that, with the larger trials, it becomes possible to detect subtle differences in design that will impact on duration of, for instance, DAPT treatment, and also impact on patients' outcomes. So it's amazing to see after so many years that we still try to improve incrementally. Increments are smaller and smaller, but still keeps us busy in the interest of the patients. And thank you. Thank you for having me at this meeting.
So,
thank you very much, sir.
One quick question. I'll introduce Dr. Greg Stone. I think Greg has given several presentations for Indian audience, and he will be giving a great talk, I'm sure, to talk about Excel. And one quick question, Greg, do you think now, is there any role to pay more money for Synergy with the Onyx 1 DAPT study, as well as now Science, even though it is single arm? So do we need to spend that much money for Synergy?
I personally think the outcomes with all the premier stents are very similar to each other. I personally, I'll just be very honest, and I have no relationships with any of the stent manufacturer companies. I would not pay a premium for one stent above the other stent. I think they're all very good.
Yeah.
It's a great pleasure to have Greg Stone with us. Greg, really appreciate your time and effort to join us on the Sunday morning here from East Coast. And so great pleasure to have you. And without further ado, I'll ask you to speak on Excel results that you have already spoken to on many occasions. Thank you.
Thank you. It's a pleasure to be here, and I do wish I was there in person, but I suppose this is the next best thing. And what I'm going to do is I'm going to tackle some of the controversies that have arisen with Excel head on, and hopefully this will be of interest and a little bit different, but also a little bit educational. So you should be seeing my slides now, and these are my disclosures. I do work with a lot of companies, but as I said, I have no financial interests with any stent manufacturers. So again, to remind everybody what was Excel, this was the largest to date randomized trial of left main PCI DES. We took a total of 2,905 patients with unprotected left main disease. Those that had a visually assessed syntax score of a lower intermediate range, that is up to 32, in which there was agreement that the interventionalist and the surgeon could both do their jobs and safely get the patient through the procedure with a high rate of revascularization. That is, there was equipoise. We took 1,905 such patients and randomized them 1-to-1 to a contemporary Xience everolimus-eluting stent versus contemporary bypass surgical procedures. And we followed up the patients through 5 years, and the primary endpoint was the composite rate of death, MI, or stroke measured at a median 3-year follow-up with a minimum of 2-year follow-up at all patients. And I will say, given that this was a large trial, this is the first trial that's been adequately powered to have a primary endpoint of death, MI, or stroke without revascularization. Everyone that planned Excel, and I'm going to get into this, agreed that repeat revascularization is much lesser importance than death, large myocardial infarction, and stroke. So let me tell you some principles that went into the Excel study design. First of all, it was an academically designed and run trial. Abbott was the sponsor, but allowed the both interventional cardiology and cardiac surgical leadership to design this trial and run it as we saw fit. I would really describe it as the most collaborative study ever between interventionalists and surgeons. There were 4 principal investigators, 2 interventional cardiologists from the US, that was me, and Europe, that was Patrick Sorois, and 2 surgeons, one from the US and one from Europe, that was Joe Sabic and Ari Peter Capitan. It was designed and overseen by interventional cardiologists, surgical, general cardiology, and statistical committees and country leaders with an exact equal number of surgeons and interventional cardiologists. Altogether, about 100 people designed the Excel trial, 100 physicians designed the Excel trial. There was unanimous agreement on all primary and secondary endpoints and definitions. It was designed for non-inferiority of PCI versus CABG for the primary endpoint of all-cause death, MI, or stroke in a median of 3 years. We had extensive discussions about what the definition for procedural myocardial infarction should be. And there was, again, unanimous agreement that it should be a definition that represented extensive myonecrosis with minimal ascertainment bias between PCI and CABG to make it a fair definition. And I'll be coming back to this extensively later. We agreed that revascularization is of secondary importance, and it could be in secondary outcome measures, but not in the primary outcome measure. We all said it was not any more important than new onset atrial fibrillation or the need for oral anticoagulation or bleeding or repeat operations or many other secondary endpoints. We did have about 35 pre-specified endpoints and about 15 pre-specified subgroups, and these were all hypothesis generating and were not corrected for multiplicity. And we even pre-specified the language that we were going to use depending on how the trial came out. We agreed in particular, and this was very important to the surgeons, that we would state that if non-inferiority was met for the primary endpoint, was that PCI was non-inferior in selected patients with left main coronary disease, reflecting that we weren't enrolling patients with high syntax scores. And finally, the Excel database is open to all the surgical and interventional and statistical investigators in the trial. And so far, there have been more than 100 sub-studies that have been led and published, and I think we'll continue to publish in Excel for several more years at least. So the primary endpoint of Excel was all-cause death, stroke, or MI at a median of 3.3 years. And as you recall, there was no significant difference between PCI in orange and CABG in blue, with about a 15% rate in both groups. You'll note there were fewer events early in the PCI arm, but then there was a catch-up in the PCI arm, so they were almost identical at 3 years. When we followed these patients out to 5 years, which is the end of the follow-up of the study, there were still no statistically significant differences between the two groups, 22% and 19%. You can see the odds ratios and confidence intervals. You notice there's no p-value because there was no hypothesis at 5 years. And so these just are the data, and you can look at the precision in the data according to the confidence interval. But you do note that these curves cross, and I'm going to come back to that. So this is non-proportional hazards. You could see that early on, there clearly was a benefit to PCI with having fewer events. But then over time, there's clearly a benefit to CABG. So these crossing curves, which we also saw in the ischemia trial, and we're seeing more and more these days, again, represent non-proportional hazards, which means the hazard ratio changes over time. So how do you best analyze this? Well, the first thing to do is to look within the data to see if there are different periods where the hazards are proportional. And we did find 3 such periods in our data. There's the first 30 days, the periprocedural period, where you could see there was a 60% reduction in major periprocedural complications after PCI compared to CABG. Then between 1 month and 1 year, which is traditionally thought of as the restenosis period, the curves were superimposable. There was absolutely no difference between PCI and CABG. But then from 1 year to 5 years, you could see the curves are diverging and there's fewer events after CABG compared to PCI. So what you can look at then when you look at these curves is, if you're going to have an adverse event, you'd of course rather have it late than early. If you have it early, then if you die, then you've obviously died earlier. Or if you're exposed to that adverse event earlier, it impacts the rest of your life more. So you can look at basically the difference between these two curves as the difference in exposure of adverse events. This is favoring PCI, this is favoring CABG. And you can calculate what's called the restricted mean survival time, which is basically the average time of being event-free in the study. And this is what it looks like. You can see here that after a patient undergoing PCI versus CABG, they start having more and more average event-free survival time, which peaks at about 30 months at around 20 days. But then the greater events long-term after PCI compared to CABG start eating into that. So by the end of the 5-year period, the average PCI patient was 5 days more likely to be free of an event than the average CABG patient. But you can see by these dotted lines that the confidence interval is very, very wide. So obviously there's no difference between event-free survival after PCI versus CABG. Now, we looked at multiple different subgroups. Very hard to see this slide, but that's okay. These were the pre-specified subgroups. And the only thing I'll say about them is that there were no significant subgroups that we've identified, including low versus intermediate versus even high syntax score by core lab assessment, whether the distal bifurcation was involved or not, diabetes, ejection fraction. No significant subgroups were identified that had a significant interaction between the primary endpoint and outcomes. So that's the basic Excel result. I mean, that's what it was powered to show. And we showed really similar results at 3 years. That was the primary powered endpoint. And yes, I think you can continue that out to 5 years. But Excel has raised a lot of controversies, as you know. And I'd say there were 3 main controversies. One, is mortality greater after PCI compared to CABG in left main disease? And if so, doesn't this trump all? 2, why was the specific protocol definition of MI selected rather than the so-called universal definition? And 3, why was repeat revascularization not included in the primary endpoint like in every other study? So, first controversy, is mortality greater with PCI than CABG in left main disease? So the first question is, let's look at what endpoints are important, okay, in patients undergoing coronary vascularization. And there have been a lot of surveys that have been taken on this. This is one, for example, published in Circulation, and they asked 164 clinical trialists and 785 patients with cardiovascular disease to weight the relative importance of death, stroke, MI, and coronary revascularization and hospitalization for angina. And you can see the physicians thought that death was the most important endpoint, that stroke and myocardial infarction were the second and third most important, and that revascularization and hospitalization for unstable angina were much less important. Interestingly, when you looked at the patients thought that, if anything, stroke and myocardial infarction, and this was described as large MI, by the way, that stroke and myocardial infarction was, if anything, more important than death. And they agreed that repeat revascularization and hospitalization for unstable angina were much less important. So obviously, there's no doubt death's an important endpoint, but just remember, patients value MI and stroke at least as importantly. So when we look at all the long-term outcomes in Excel, you can see here that we've got PCI, CABG. Here's the difference and the odds ratio. So this is looking at the absolute difference, and this is looking at the odds ratio. And, you know, people argue what's more important, the relative difference, for example, the odds ratio. Remember, we shouldn't look at a hazard ratio because we have non-proportional hazards. So it could be a relative risk or an odds ratio or an absolute difference. And I would certainly argue that an absolute difference is more important. And that's what we should really be focusing on in 2020. I guarantee you that if we were to randomize an infinite number of patients between PCI and CABG, there are differences between these two techniques in death individually, death, MI, and stroke individually. They're very different techniques. Of course, there are differences. The questions are they clinically important differences, and what are the differences in absolute rates? So here is death, stroke, and MI, and I described to you the difference here of an absolute difference of 2.8% with 95 confidence ranging from minus 0.9% favoring PCI to 6.5% favoring CABG. And you'll note there's no p-values because these are underpowered endpoints, or in the case of death, MI, or stroke, there was no formal hypothesis, and they're not adjusted for multiplicity. So the first thing I want to point out is these are 5-year rates. So if you look at the difference of every single one of these are relatively small differences. So let's talk about mortality, okay? Here you see 3.1%, ranging from 0.2% to 6.1%. So here you could see there was a suggestion of concern of greater mortality after PCI versus CABG. The first thing to note, though, is that this is 3% over 5 years. So it's 0.6% per year, which is quite a small difference in patients with left main coronary disease. But again, as I mentioned, we had more than 35 secondary endpoints. If we corrected this for Bonferroni to done multiplicity, we would have needed a p-value of about 0.001. So we're not even close to being significant with this endpoint. But nonetheless, mortality is the most important endpoint. We pretty much all agree on that. So is this real? So and similarly, you have a small difference in cerebrovascular events that's favoring PCI. But again, I would point out this is a small difference. It's 2%. So I'm not going to get on my high horse as an interventionalist and say, oh, this is a huge difference in stroke or other events, because it's a small difference over a 5-year time frame. So let's get to mortality. Let's say that it is a real difference. Well, how do you even communicate to a patient so they can understand what this means? Well, this is one kind of tool that's often used, and this is a therapy that reduces the 5-year death rate from 13% to 10%. And you can tell the patient, will you be alive at 5 years? The answer is, for these green faces, yes, you're going to be alive at 5 years, and it doesn't matter whether you get PCI or CABG. In these orange faces, you're not going to be alive at 5 years, and it doesn't matter whether you chose PCI or CABG. But if this is a real difference, here are the 3 differences. So now you've got to decide how important that kind of lets you understand the absolute rate differences and how important that is. But is this a real difference? Okay, so when we look at the cause of mortality, if there was a difference in mortality between a left main coronary revascularization, you would expect it to be a cardiovascular cause. But we actually saw no difference in cardiovascular mortality, or very similar, very, very low difference. And that's consistent with the overall similar rate of myocardial infarction between PCI and CABG at 5 years. Instead, the difference in mortality was mostly driven by non-cardiovascular mortality. And these were very clearly adjudicated non-cardiovascular causes. When we look at the specific non-cardiovascular cause, these were due to late sepsis, usually between 2 and 5 years, and late malignancies occurring between 2 and 5 years. That's the biggest difference in non-cardiovascular causes. And so you have to ask yourself, is this biologically plausible, or is this possibly due to the play of chance? So when you have an underpowered secondary event and you find a positive finding, for example, if you take a coin and if you flip a coin 5 times and if you get 5 heads, that's a p-value of 0.03. Okay, that can happen. So when something like this happens, this is when it's useful to go and find all the other trials that have been done, because we didn't have the power to hypothesize a difference in mortality, to explore whether or not there really is a difference in mortality. So this is the updated meta-analysis of all the left main DES versus CABG trials as published in the European Heart Journal. 5 trials, 4,612 patients, including Excel and Noble and Syntax at the latest time point. So you can see Syntax 10 years and Excel and Noble at 5 years. And you can see there's absolutely no difference in all-cause mortality. Hazard ratio of 1.03, p-value of 0.78. And you can see the confidence interval is fairly tight. Now, when you look at these different rates, it is interesting to note that there is moderate heterogeneity. So then the best thing to do is start extracting one study at a time to find out which is the outlier, what caused the heterogeneity. And the answer is Excel. If you remove the Excel trial, now there is no heterogeneity left whatsoever, and the relative risk is 0.93, again with a p-value of 0.47. So Excel was the outlier here, and most likely because of this chance finding of non-cardiovascular mortality. And if you don't believe statistics, then I would just suggest that you just look at the 4 main trials. Here's the 5-year outcomes, all-cause mortality from the 4 main trials. And again, you've got the PCI in red, you've got CABG in blue. In a few of these trials, the blue line's a little above the red line. In the other trials, the red line's a little bit above the blue line. But it really takes, I would say, a very strong bias to look at these curves and think that there's a difference in mortality between these 2 procedures in this population that was studied. Now, then you ask the question, well, what about 10 years, okay? It's always been said that's when bypass surgery is really going to shine, the longer-term follow-up. And 2 of the trials now have gone out to 10 years. We have the Syntax trial, and here you can see, note from 5 years to 10 years in all-cause mortality, the curves are absolutely parallel. And at 10 years, there's no difference. If anything, the point estimate slightly favors PCI at 10 years, but no difference between the 2 procedures. And here is the pre-combat trial out at 10 years. And these were both first-generation drug-eluting stents, by the way. And you can see there's absolutely nothing going on between 5 and 10 years. So there's really no difference between PCI and CABG for left main disease in terms of mortality in at least appropriately selected patients. Now, the second controversy has been about the definition of procedural myocardial infarction. Why did we use the one we used instead of the universal definition? Well, here is the myocardial infarction endpoint, okay? And there was no overall difference in MI at 5 years, but you'll note that there was fewer procedural myocardial infarctions after PCI, but more non-procedural myocardial infarctions after PCI. So the surgeon's criticism of procedural MI in Excel is that the investigators changed the primary definition of procedural MI midway through the trial. Well, that was absolutely a bizarre claim, and the first and the last protocols are published in the New England Journal website, and they've since, David Taggart, who made this claim, has since retracted it. I don't know even what he was thinking. Second, the claim is that equal biomarker thresholds of the protocol definition, which were used, bias the trial against bypass surgery, okay? So the universal definition arbitrarily allows twice as high a biomarker threshold before they call an MI after CABG compared to PCI. And because they say that's fair because you're cutting into the myocardium. And we had looked into the data and saw that the data supported a similar threshold being prognostically significant. But again, they were saying that biased against CABG, and I'll come back to that. They're saying a pre-specified secondary MI definition of procedural MI, according to the universal definition, was never shown, and I'll address that. And finally, that peri-procedural MI is not important anyway and should not have even been included in the primary endpoint. So there are generally accepted principles if you're going to put a component into a composite endpoint. First, that each component of a composite primary endpoint should be of prognostic importance. It should be at least linked to a major adverse outcome such as death. And in fact, myocardial infarction, the way it's measured, both in the procedural period and the follow-up period, is usually based on biomarker elevations and EKG changes. So it's actually a surrogate outcome. So if we're going to include it in a composite outcome that includes death and stroke, at least we have to have confidence that those biomarkers are linking to a clinically important outcome. 2, assessment of the outcome should be equally robust with both therapies. It shouldn't be easier to detect it with one therapy or versus the other. And 3, the prognostic relevance of the outcome should be similar with both treatments to afford a fair comparison. Again, if a biomarker elevation means that the patient's 3 times as likely to die after PCI and only 1.5 times as likely to die after CABG, that's not a fair comparison to count them both the same. So I won't, because of time, get into this in great detail, but this was the procedural MI definition for the 3rd universal definition of MI that was in place at the time of Excel. And they define a type 4 and a type 5 MI as needing a certain biomarker elevation with associated evidence of myocardial ischemia. The problems here are that they define these both as arbitrary, okay, because they didn't have enough data to say what the biomarker threshold should be. They require a normal biomarker level for post-CABG MI, a normal baseline biomarker level for post-CABG MI, but not for post-PCI MI. They use symptoms, that is chest pain, severe chest pain, as being consistent with an MI after PCI, but not after CABG. They require ischemic EKG changes after PCI, but only Q waves after CABG. The biomarker thresholds are twice as high as I've mentioned before. And of course, one of the complications is angiographic complications. And of course, PCI patients, 100% of them have angiography. So you can look for angiographic complications. But almost no CABG patients have angiography unless they're having a major, major issue. So that's the definition of ascertainment bias. So these are problems with the universal definition of MI. Now, in the Excel trial, we did a detailed literature search before Excel, and we found that the literature supported a similar threshold of biomarker elevations, and we wanted to do something that would somewhat minimize ascertainment bias. So we found that the literature supported only that large myonecrosis was clinically correlated with subsequent death. And so we required, and this is before the SKY definition, a 10 times URL peak CKMB elevation within 72 hours, or 5 times with at least one of the following. We didn't allow chest pain. We allowed new Q waves. We did allow angiographically documented graft or native coronary artery occlusion, or imaging evidence of new loss of myocardial, viable myocardium. And this is an evidence-based, it wasn't arbitrary. Every surgeon, including David Taggart, agreed on this based on the evidence, and these are the ones that were associated with death. So these were the procedural myocardial infarction rates, and it took us a long time to report the universal definition rates, because CKMB was required in all the patients, but troponins were not. And troponin is the preferred biomarker after the universal definition. And the universal definition doesn't say what to do if all patients don't have troponins. There can be tremendous biases as to who gets troponins, who gets CKs. It could even vary between the same sites, because surgeons may draw one and interventionalists may draw the other. So finally, we just decided to report the universal definition in multiple ways. And we reported it using CKMB in all patients, using troponin in the 49% of patients who had troponin levels, and then using a mixed definition of troponins if available and CKMB if not. And this is an analysis that was led by Stuart Pocock and his colleagues independently at the London School of Tropical Health and Hygiene. So here are the protocol definitions of MI using CKMB elevations. And if we just look at the troponin cohort of patients, and you can see with this definition, these are large MIs. Again, most of them CKMB is greater than 10 times, and there's clearly fewer of them after PCI than CABG. If, on the other hand, you look at the universal definition of MI in these other 3 different categories, you could see using the CKMB or the mixed definition, it flips. There's actually more MIs after PCI than CABG. Using the troponin-only definition, actually, they weren't statistically significantly different. And you'll note that the orange curves, which are the PCI procedural MIs, are relatively similar. The rates are relatively similar with both definitions. But the CABG MI rates are much higher using the PCI definition, the protocol definition, even though a very large biomarker threshold is required, and much lower using the universal definition. And in fact, here it is, and again, it'd take me too long to go through all this, but the bottom line is the protocol definition and the third universal definition correlated in about 3/4 of the patients for PCI, but there were many, many fewer found after CABG. And the reason is because of this requirement for angiographic complications or new Q waves. You just don't find those very often after CABG. Despite the CABG patients having very large biomarker elevations, you're not going to call that a myocardial infarction if you use the universal definition. So the question is, what are the implications of these definitions? And if you use the protocol-defined myocardial infarction, there was about a 2-fold increase in mortality after both PCI and CABG if you had a protocol-defined MI. If, on the other hand, you had a MI by the third universal definition, if you had it after CABG, there was a marked increase in mortality. But after PCI, there was no increase in mortality. So it wasn't even important after PCI using that definition. So here's the basic data. The protocol definition gives you about, this is multivariable adjusted now, gives you a 2-fold increase in, this is cardiovascular mortality. It's very similar for all-cause mortality. A 2-fold increase in all-cause mortality, similar after PCI and CABG. Whereas the third universal definition, depending on which one you use in the CKMB only definition, the mixed definition, the troponin only definition, you can see that the hazard ratios after PCI are not significant where they're markedly significant after CABG, and you have very strong interaction p-values. So we then look to see, well, why is this going on? And the only biomarker elevations that were prognostically correlated with death were those with a CKMB greater than 10 times the upper reference limit or a troponin greater than 70 times the upper reference limit. And this held after both PCI and CABG. So this basically shows you that data. Again, only the very large biomarker elevations are associated with all-cause death. And finally, there was this old thing about how do you convert troponins to CKMB? The SKY definition uses 7-to-1 ratio, and actually we had 1,600 patients that had both simultaneous draws of troponins and CKMBs. First of all, you can see there's a fair amount of variability, but nonetheless, if you draw a geometrically weighted regression line, you see a geometric mean of 7.01. So actually that 7-to-1 is the perfect ratio for troponins to CKMB. And large biomarker elevations by those CKMB, this should be greater than 10 times, and troponin greater than 70 times, you could see is much more common after CABG compared to PCI. So then finally, I'll go to the third one. Why was revascularization not a primary endpoint? I already mentioned to you that revascularization is much less important to patients and physicians, and again, arguably not more important than AFib or bleeding, et cetera, et cetera. That being said, unplanned revascularization is certainly more common after CABG compared to PCI. In fact, there's no heterogeneity in the trials here. Every trial finds it. It's about a 6% difference at 5 years. So again, it's not a big difference. It's about 1 out of 100 patients per year requiring a difference in repeat revascularization. And again, not that important to patients or physicians. But importantly, it's also not the same endpoint. It's very unusual to get a repeat revascularization after CABG. Patients are told that you're not going to have a repeat revascularization. And it's not until they're really deteriorating that you're going to do it. So if you look at the Syntax trial, patients who have a repeat revascularization after CABG compared to PCI are having much more angina, much worse quality of life, and much more physical limitations. So frankly, that's another reason you shouldn't be putting it in the same endpoint, because they don't mean the same. And one of the reasons is that there's less revascularization is that, as you know, bypass surgery causes progression of proximal disease in the coronary artery. And if you look at patients who come to the cath lab after bypass surgery who clearly have angina and ischemia, that only 16% of those patients have targets to revascularize, because they've often occluded their coronary vessels and or grafts, and there's just nothing to go after. So again, that's another one of the reasons why the quality of life is so much worse. Revascularization is just not a fair endpoint. Finally, in Excel, we did find that revascularization was associated with subsequent mortality. But I'll point out that it was only associated with subsequent mortality if the repeat revascularization procedure was a CABG. Okay, so if you just have to do a repeat PCI, that's a relatively benign procedure. So I'm going to conclude with this slide by saying that left main PCI and CABG are two very different procedures. And you really have to understand all this data and get beyond all the politics and all the nonsense, because Excel has provided a huge amount of data that should inform the heart team how to translate these differences so they can explain them to the patient. It's very clear that PCI has early advantages. It's less invasive. There's fewer procedural complications, including stroke, MI, AFib, bleeding, acute kidney injury, etc. It's got lower 30-day MACE rates and more rapid recovery with better early quality of life and early angina relief. However, bypass surgery has late advantages. It's more durable. There are fewer adverse events beyond 1 year, in particular myocardial infarction and repeat revascularization procedures. At the end of the day, there are no major differences in long-term survival, overall major MACE events, that is composite death, MI, or stroke, or quality of life between PCI and CABG when there is equipoise for low and intermediate syntax score patients. There are going to be some patients that clearly should have CABG, those with multiple chronic occlusions and severe diffuse coronary disease. There are going to be some patients that should clearly have PCI, a simple osteo left main lesion, or prior mediastinal radiation, or marked frailty, or severe COPD. But for the other patients that could have both procedures, you've got to consider the expertise of the interventionalist and the surgeon at your hospital, and you have to take the patient's preferences very strongly into account. Some patients will prefer the early advantages, some patients will prefer the late advantages, and if you explain this to the patient and listen to what they care about, you're going to be doing your job as a physician and giving the patient the best care possible. Thank you very much.
Thanks, Dr. Greg Stone, for your excellent lecture. It is superb and terrific lecture, and there is no language is sufficient to tell the greatness of your lecture. It's really, I have heard on Excel previously also, but it is the best lecture I have heard from you as well. So we missed you in Chennai, Greg, yes, but that is compensated today by your great lecture. So Ramesh, are you there? And Dr. Shottoban Sharma, he is, yeah, Ramesh, yeah.
I'm here. So I think the most important point Greg has actually brought up very clearly is that, for example, I'll talk about individual cardiologists, how we should receive this great results of the study is that if I do 100 left main PCIs rather than sending them to bypass surgery, there will be probably 3 people at the end of 5 years who might die or who will die, right? So am I doing that even per year, if you think about number needed to harm and all that, am I doing 33 left mains that either could go to surgery or actually PCI at the same time? We already have a huge selection bias in the United States. All the left mains that we get to do are surgical turndowns. And all the ones that simple, straightforward left mains are going to go for surgery. And here, Greg, I think the main reason is hospital lobbying more for the reimbursement for surgery is 80,000 or 70,000, depending on where you are, versus maybe 18,000 or 20,000 for PCI. If we both actually bring that up, the reimbursement to the same, I'm sure the hospital lobbying also will stop saying that push for more CABG. What do you think about that, Greg? Do you think we'll ever come to an equipoise in actually the reimbursement?
Well, I think that there's a lot of reasons that the reimbursement tends to be different and tends to be more for surgery than for PCI. I mean, surgery in general is a more involved procedure. I don't think it's unreasonable that there should be somewhat more reimbursement for surgery than PCI, my own opinion. On the other hand, if you've got a very high risk, complicated PCI that's going to require impella support and 6 or 8 stents, then that should somehow be recognized, and there should be more reimbursement for that. So unfortunately, the whole field has been is being driven by, as you say, by reimbursement and by people's self-interests and not putting the patient first. And I will say, not just Excel, but we now have plenty of data from all of these randomized trials. We've got 2 very good procedures, and we need to start bringing the patient back to the forefront of the decision and try to put some of these economic, either personal or hospital-based decisions as secondary. That's our Hippocratic oath as a physician.
Great point.
Professor Vince, your comments on this issue, on Excel, the controversies, and what is your message?
Well, the Excel controversy has had a very significant impact on the interaction between surgeons and interventionalists in Europe. We have been issuing every 4 years combined guidelines, and at some point in time, members of the surgical community have threatened to actually stop that process in the future, which would be really disappointing, and like Dr. Stone said, not placing the patient at the center. I hope this is slowly resolved now with all the data that Greg has shown. And I'd like to ask Dr. Stone the following. I mean, is there an individual patient level analysis of the pooled Hamad study that you showed? Is that coming? Will that not help us and inform better the advice to give to patients, and also give us a better feel on the time dependency of individual endpoints, and not just, like you showed beautifully, the time dependency of the combined endpoint?
Yeah, thank you, William. It's absolutely coming. It took us a long time, I'll be very honest, to get the Noble investigators to agree for a lot of reasons, including letting data out of Europe is not so easy anymore, as you know, because of new regulations. But it has happened, and it is underway, and I would imagine it'll be early to mid next year where we will have an individual patient data analysis of the 4 main trials of PCI left main DES versus CABG. So, and I appreciate everything else you said. Right now the ESC and EACTS have said that they're going to reevaluate the left main guidelines. The one thing I'll just say is my own personal appeal, and I don't know if you're involved or not, but I think the interventionalists have to have a backbone. They have to have a spine, and they have to follow what's right for their patients according to the data and according to the evidence. And this is only 5 to 10% of all the patients that get revascularized, but the surgeons have elected to make such a stink about this issue that I'm concerned, just to let the politics settle down, that the patients are not going to be put first in the guideline process. And I just hope that doesn't occur. I would be very upset, and I'll be very outspoken about it if it does occur. So I hope it doesn't.
Dr. Kahali, unmute yourself. Dr. Kahali, unmute yourself.
Sorry, you're muted again.
Dr. Kahali, you're muted again?
No, but I am unmuting, yeah. So Professor Adnan Kastrati has joined us. So happy welcome to Dr. Kastrati. Please join us in the podium. And, it's a great pleasure for us to get you on this important meeting. I also invite Professor K.K. Shetty and Professor Shatyavan Sharma to give brief comments on this very important issue of Excel trial, and also the recent controversy between the interventionist community and also the surgeon. So there should not be any dispute. There is no dispute, but what are the comments on this take-up, especially in the Indian scenario? Because both of you are past presidents of Cardiological Society of India, and what is your take on the issue? Professor Shetty, please. He was left, I think. Dr. Shatyavan Sharma, you are there?
Yeah.
Yeah, please give your valuable comments,
Actually, I will just briefly ask Professor Greg Stone, has the heart team approach discussion changed after the controversies in the United States? How do you approach the patient now? The heart team talks what language?
Well, I think it varies hospital to hospital. In hospitals such as Mount Sinai and Columbia, we are actively considering left main intervention. And we have very good collaborations and relationships with our surgeons. So we will usually approach the patient together and we'll describe the pros and cons of each procedure from each specialist. But I will say in the United States, as somebody else mentioned, for the most part, we are not doing a lot of left main intervention. It has never become mainstream in the US. And this controversy, we have so much data now to suggest that it is appropriate for patients, that it should be offered more. In contrast, in Europe, I think there's a much better use of the data and it's applied in appropriate patients. So maybe William should comment as well as to how in Europe, heart team discussions have changed, one, based on the data, but then two, also based on the controversy.
Dr. M.K. Das, what is your take on this?
Yeah, very quickly. I think in many hospitals, the interaction within the heart team has suffered from the controversy, and the problem is that a number of quotes went on the social media, social networks, etc. And they live their own life without being actually supported by the data. And I think the presentation and the summary that Greg Stone just gave us shows that some of these quotes were totally fake. Unfortunately, it is sad to see that it affects the behavior of physician. I suspect now that things are falling into place again. And particularly coming up with the data and addressing all the pseudo issues or some issues that, as was done today, I think is helping a lot. So in the end, I'm optimistic. Of course, the emphasis now of the discussion is shifting towards TAVI in patients with intermediate or lower risk, and that creates another reason for discussions. So I really think it is dreadfully important to always come up with the data, and particularly as we discussed, I think if we had a pooled patient level analysis of these major trials, then that would help physicians really to identify which, as you said, Greg, some patients clearly should have PCI, others should have CABG, and to give us the ammunition to make that decision and these recommendations is going to help tremendously. So the answer is data, data, data.
We'll get there.
Thank you, sir. Dr. Greg, just I want to inform you that almost 1,500 delegates and faculties are watching you, and there are several comments in the chat box congratulating your fabulous speech. Thank you very, very much, sir. Thank you. And I would request you, if possible, to be in the podium and to chair the session to draw it further. And I ask our president, Dr. Mrinal Kanti Das, to introduce our great, friend, Dr. William Wins. He is coming from Europe. So please introduce him and tell your brief introduction. Thank you very, very much. Thank you.
Yeah, it's a great honor to actually invite Dr. William Wins, who is a master interventionalist and also has been related to so many guidelines of the European Cardiology Society. And I am really grateful to all the legends to present themselves in this CSI initiative. And I again thank you all. Now I invite Dr. William Wins to present his deliberation. Dr. William, please.
Thank you very much, And it's a good evening to all of you, and a warm greeting to the colleagues in India and abroad. So these are my disclosures. And the topic that I'm going to discuss with you is one that is very close to my interest at the moment. It is about the value of performing post-PCI functional measurements at the moment when the procedure is over and we have a good result by angiography. And I added a question here. I hope to be able to convince you that this is the next frontier in patient care. Now, transstenotic pressure gradients were at the core of the procedure during the very first in-human balloon angioplasty by Andreas Günzig in Zurich. And this is the tracing that was obtained at the time through the lumen of the catheter. The catheter didn't have a free-moving wire, was a fixed wire, so there was a lumen to measure the distal pressure, be it with a poor fidelity here. And so you can see that at the moment, the catheter was advanced through the LED stenosis in this very first patient. Of course, this created an artificial gradient. The catheter was quite bulky. And then the inflation was performed. Pressure went down completely to the level that represents the degree of collateral flow. And what was remarkable is that as soon as you deflated the balloon, even though it was still across the lesion, there was no gradient anymore. And that is the exact moment we were told by Bernie Meyer and those who gave an account of this procedure. This is the exact moment when the surgeon left the cath lab. He didn't bother to wait for the angiograms. He said this is going to work because there was an effective reduction in the pressure gradient across the stenosis, restoring the conductance of the epicardial vessel. So just to tell you that it was there from the beginning and then it disappeared because of the need to make the equipment much more trackable through the coronaries, smaller, very tiny, where it is now such that there was no longer space for an extra lumen to measure the distal pressure. And we had to wait for a number of years until Nico Piles both validated and established clinically pressure measurements through the pressure wire. So what I'd like to discuss with you today is summarized here. And the first observation is actually shocking. And it is the following. When you think you've done a great job and the angiogram looks great, in many cases, up to one out of 5, sometimes up to 1/3 of the cases, the physiology will be not very good, barely restored to normal values. And this has been observed over and over again. This is a pooled analysis that Niels Johnson from Houston did, and it shows here per terciles the level of post-PCI fractional flow reserve in patients with successful PCI by angiographic criteria. And you can see, particularly the lower tercile, that there is quite a significant number of patients where the artery looks good, but we haven't achieved much in terms of restoring the conductance of the epicardial vessel. So Niels was able to link these post-PCI measurements with later outcome from this pooled analysis of nearly 1,000 patients. And there was no surprise, at least to us, no surprise to see that if you have a lower FFR at the end of the case, you are more at risk of having either death, non-fatal MI, and particularly repeat revascularization during follow-up. And this continued for up to 3 years. Now, many other studies have shown this. This is another one from the team in Nanjing. So they looked at prospectively at a significant number of patients. And it shows here again, from left to right, the fractional flow reserve and the relationship with 1 year TVF. You can see that the lower the fractional flow reserve at the end of the case, the higher the risk of target vessel failure in this particular case. In their study, they found a threshold around 0.88 for FFR. This study is contemporary and was performed with DES. If you look, for instance, at target vessel revascularization, which is the individual endpoint that drives this TVF outcome, you can see that there is a very significant difference. You're much better off with a higher FFR at the end of the case than with a lower one. So this table is a tabulation of a number of studies that have looked at this. And I think it is robust now to state that there is a strong association between the post-PCI physiology at the end of a successful case by angiography and clinical outcomes. Studies have looked either at MACE or at the vessel-oriented composite endpoints. This is all studies with mostly DES. Follow-up times vary, but usually 1 year or longer. And you can see that the difference in event rates, depending on the cutoff value that was selected in the individual studies, that varies, but usually is around 0.9. You see that there is a very significant increase in risk for events if you have a lower FFR when you're leaving the cath lab. So that is to me, a shocking observation that I think we should be, remembered all the time. We know that pre-PCI, the angiogram is not always telling us the truth. Well, it so happens that in a number of cases post-PCI, it's the same story. And if we wanted to evaluate the quality of our work, we would actually have to perform both the angiogram and physiological measurement. I can also state that there is a strong association between the post-PCI FFR and outcomes. Now, what is new is that in addition to using the pressure wire, with or without hyperemia, post-PCI or pre-PCI physiology can also now be computed from imaging, be it the angiogram, that's called QFR, or other techniques. We've also recently validated the computation of FFR from OCT, it's called OFR, or from IVUS, and it's called UFR. So this is an example of how it can be calculated online in the cath lab from two angiograms. On the top, you have two angiograms of this right coronary artery. It has a tight stenosis. The 3D reconstruction allows you, together with the TIMI frame count, to compute in the lower left corner of the slide, the QFR, in this particular case, computed at 0.54 and measured for validation using the FFR wire and hyperemia at about the same level, 0.56. The comparison of all the studies that looked at invasive pressure wire FFR-based versus computational FFR are robust and show that there is at least 3, if not 4 technologies that can do this in a very accurate way, such that it can be used for clinical purposes. You also have a very nice graphical display there at the lower right part of the slide, where you can see the diameter function over the entire vessel with the very low there in red, and you can co-register that anatomic information from the angiogram like a GPS, if you wish. You can co-register those location in the coronary artery with the FFR value, and you can identify in this particular case that the pressure drop is very localized where you have this tight stenosis. So this, obviously, the availability of these computational image-based techniques will allow better adoption of physiological measurement than the case when you have to pull the wire and adenosine. So with this armamentarium at hand, we can now identify the root causes of suboptimal PCI physiology. I mean, you did your best, you measure or compute the final FFR, and it is 0.78, or which would be very bad case, or it is better, but something like 0.85. Can I do something about it? In order to improve this, I need to understand where is the obstacle. Is it in the stent? Is it in the rest of the vessel that has not been stented, or both? So I'd like to show you now that it is actually possible to identify on the coronary angiogram by co-registration where the obstacle is located. And there is basically three major patterns as published here in this paper by Carlos Colette. It can be a focal obstacle. It can be the combination of focal obstacles superimposed on diffuse narrowing, and it can also be diffuse disease, like in the right part of this angiogram here, where there is nothing really that calls the attention or could be stentable, but there is diffuse narrowing. And so if you have the FFR in this case, but you could do the same with IFR during a pullback procedure, you can actually identify on these graphs very clearly where the problem is. Very focal in the left part, a combination of focal drop plus diffuse loss in pressure as you go from as you go towards the apex, and in the right part of the slide, diffuse disease, nothing really that can be helped with a metallic stent, at least, to restore the conductance of these vessels. And Colette has proposed some equations here that allow you to calculate the contribution of each of these obstacles to the eventual conductance decrease. Now, we know from very long time, actually from 1999, that if the stent is not properly deployed, this will cause turbulences and you will have a pressure loss. So there is absolutely no question that a underexpanded or malapposed, severely malapposed device or an edge dissection can cause turbulences and induce pressure loss. And that is something that we can fix. It is shown here beautifully in this amazing study done in 1999 again. What they did, it is from Nico Peil's lab, they deployed a stent at low pressure and increased the pressure, stepwise, 4, 6, 8, 10, 12 atmospheres. And in between each increase in deployment pressure, they measured FFR. Yes, they did. Not just a bolus, but even continuous infusion of adenosine, so they could measure the location of the pressure drop. And it's absolutely clear here on the top that you can see there is a very significant gradient that disappears as you expand the stent further. So if we have low post-PCI FFR, for sure, we need to check the stent. Now, how do you do that? With imaging, right? And this was done very nicely. And although the purpose of this study, doctor's trial, was not specifically to take it from a post-PCI FFR towards imaging, it's the opposite. So they randomized patients undergoing PCI for acute coronary syndrome to angio-guided versus OCT-guided. And what they've shown on the left is that your final post-PCI result was actually better if you had OCT guidance. And if you look at the quartiles of post-PCI FFR on the right part of the slide there, you can see that the likelihood of having a high post-PCI FFR was much greater if you had OCT guidance than if you had angio guidance. So this is telling us that, yes, the stent the procedure technique matters a lot, A, and B, if it's not optimal, we can improve it with OCT. That's the hypothesis. In this particular case, optimization of stent expansion was the main mechanism for reduced FFR. Now, the combination then seems like ideal. You do your procedure to the best of your capacity, you measure, and in the unfortunate event that the post-PCI FFR is low, you pull the imaging device, IVUS or OCT. In this particular case, and this can be done online, you can see that there is a vessel QFR at 0.82, which is not very good, actually, if you think that the threshold for treatment is 0.80. You can see at this level that there is significant malapposition. The curve here, the graph at the bottom, allows you to identify exactly co-registered OCT versus functional testing, and it's telling me that the drop is due to 0.06. So if I can, the drop inside the stent. So if I can optimize stent deployment, I should be able to increase the vessel OFR to a significant value. And in fact, that's the case here. So remember these two numbers, the vessel OFR, meaning the obstacle, the pressure flow in the stent is 0.82, and the stent OFR is 0.94. Now, after optimization, you see that there is almost no pressure drop any longer. And this brings us to a vessel OFR of 0.86 and a stent OFR of 0.98. So from what I'm told you before, we learned in this case that we did our very best with the stent. It's properly deployed after optimization. And there still is some suboptimal conductance because the vessel OFR is 0.86, meaning there is a combined disease, focal that you have fixed and also diffuse outside the stented segment. So the root causes can be diagnosed. We can identify whether it's in stent or outside the stent. All of that is co-registered with our anatomy, the angiogram, our GPS. Now, what we have also shown, and this was an example, is that the post-PCI FFR can be improved by stent optimization when needed. And what's the optimal value? Well, it's a continuum of risk. It's not that there is a threshold. The normal conductance is 1. But as I'll show you in a minute, this is not achievable in our patients with diffuse coronary artery disease. So anything above 0.9 is sort of what you would like to achieve. Many, many years ago, we did with Bernard de Bruyn measure FFR in absolutely pristine vessels in young patients who came in for PFO or ASD closure. So they did not have any CAD at all. And their FFR in their vessels is located here. So it was in all of them above 0.92. As soon as you start to have coronary disease, there will be some diffuse narrowing, be it non-obstructive. And then you start seeing that if you measure FFR in non-obstructed vessels of patients with coronary disease, you have a wide range of FFR. Some actually are abnormal, although the angiograms look okay. So what would actually be achievable is something like above 0.9, and we would declare ourselves happy. And also we know that this is no longer associated with worse event rates. So yes, it can be improved, the post-PCI FFR, by stent optimization. It may also allow us to identify another lesion outside the initial target that perhaps deserves to be stented. If not, we know that that patient who has diffuse disease that causes a loss in FFR may need more aggressive medical therapy. So we are at the final stage here of what's ahead of us, because what needs to be done now is randomized trials that will analyze the impact of post-PCI physiology optimization on clinical outcomes. It is one thing to show the association. Of course, one needs to be able to demonstrate that by optimizing the suboptimal result, we can have an impact on outcomes. And of course, there is an important cost-effectiveness analysis to be attached to that study. So I would like to offer you concluding statements. I think that post-PCI functional measurements are the next frontier in patient care. More and more, we are living in an era of accountability of our indications and our procedures. There is this concept of value-based healthcare where patient experience is very important. And I really think that post-PCI physiology should be performed because it is the way to objectivate that the revascularization, the intended revascularization has been performed in an efficacious way. Basically, we are dealing with an artery that should have a normal conductance, meaning that from ostium to apex, the LAD should offer only minimal minimal obstacle to flow that will translate in a pressure loss of less than 1, 2, 3, 4 millimeters of mercury at most. So by identifying the epicardial conductance profile of each patient, this will help us to shape their medical therapy and also secondary prevention during follow-up that should, of course, be intensified with lots of new opportunities ahead of us in case of diffuse disease. Thanks very much for your kind attention.
Thank you, sir, for your excellent lecture. It's a super one, terrific exposition of the subject and elucidation of a new concept. Sir, can I ask you that though it is a legion speak, we should not ask question, but this comes in our mind that what are the indications of post-PCI functional assessment? Is it there where we are not sure that the stent is properly deployed by stent boost, because the stent boost technology is also very good, because money is a problem in countries like India, and we can't afford to have FFR in each and every patient. So kindly give us a take-away message, which patients we should select for this post-PCI functional assessment. And then I will ask Professor Greg Stone also about this technology and idea.
Well, thank you very much. Of course, my answer is expressing my lifelong commitment to establishing combined anatomical and functional guidance for PCI. So as much as I think that functional testing should be done prior to PCI in the vast majority of patients, unless you have a functional occlusion or a total occlusion, the same thing. I think that post-PCI functional assessment should be performed in every patient. And it's not just about the stent deployment. That's only half of the story. It's also about identification of diffuse disease outside the stented area. You say cost, of course, that's essential. Now, we have to remember that functional guidance, the use of FFR, IFR, pre-PCI, is actually a dominant strategy. It is a cost-saving strategy. It is one of the few therapies in modern medicine where you get better outcomes and spend less money because you're saving so many stents due to the patients who are deferred. So I think that if you actually analyze the health economics for this pre and post together, you will find that still the combination of physiological guidance pre and post PCI will be cost saving. We're only going to invest part of the savings that come from pre-PCI FFR into a small number, maybe 10, 15, 20% of cases where the procedure is not functionally optimal after angiographic guidance only.
Thank you, sir.
So, William, that was a terrific talk, as always. And we're very, very interested in this concept. I'm sure you know, but probably early next year, hopefully in February, we're going to start a 3,000 patient randomized trial called Define GPS, in which after angiograpically successful PCI, we'll be doing IFR pullback and randomizing patients to either IFR guided, physiologically guided post-PCI optimization compared to just no such optimization. So I do have two questions for you. And I can never remember more than one question, so I'm happy to repeat them if you can't either. My first question is, tell me what you think about when you're trying to do this optimization. Sometimes it's stent related, sometimes it's not stent related. And with FFR, there's an interdependence of the physiology between the lesions. And, Carlos and others have put forth very complex formulas, which no one can remember. But certainly when you affect one area with FFR, that can either make other areas more or less abnormal. So what are your feelings of interdependence of FFR versus other resting gradient methods? Is QFR and OFR and UFR, do those have the same interdependence or not? So that's basically question number one about lesion interdependence and how we practically deal with that in the cath lab. And my second question is, I'm a huge believer of routine intravascular imaging. I do it in about 80 to 85% of all my cases. And I use physiology in every borderline lesion, anything less than 80% stenotic. And I'm waiting for the post-PCI physiology for these randomized trials before I'm saying we have to do that. But I think it's going to get there because I believe this, that we'll show it with adequately powered trials. But as you know, in Europe, only 4% of people do intravascular imaging, and that number is 15 to 18% in the US. Physiology is not done as much as it should be for pre-PCI evaluation, let alone post. How are we? And there's a lot of evidence. There's a lot of data, tremendous class 1 evidence for physiology. And there's more than 10 randomized trials now with 5-year follow-up for intravascular imaging. How can we get people to more frequently adopt these technologies? Does it just come down to reimbursement? We're just going to have to get better reimbursement? It's disappointing that would be the only thing that is keeping people from doing this.
I'll start with the last one, Greg. Thank you. The last one is very simple. How can we convince them, take them out of the loop?
Yeah.
We did this study with Gabo Thot. We asked 400 colleagues to look at angiograms and tell us, would you use IVUS, OCT, FFR, etc., in order to try to identify why is it that they don't want to use it or they don't use it. So everything that's been put forward are excuses. Yeah. And with, it was adenosine, it was the wire that wasn't good, etc., etc. Basically, the bottom line is the physician, we think we don't need it. We think we can make the right decision without it. It's as simple as that. So I think that the future of physiology, maybe don't quote me on this one, I think it is independent from the physician, and it will be image-based. If, along with the angiogram, you have the co-registered physiology, there you go. You have the information that you need, and we're going to use that information to inform our decisions. So I really believe that image-based, whether it is angiography in Europe where there is no OCT or IVUS or very little, or whether it is in your center, translating the anatomic OCT or IVUS information into functional outcomes, it's either or. Which comes first? It depends on your local practice and what you can afford. I would even go further that. I would think that measuring post-PCI should be part of the procedure. I mean, the surgeons, our colleague surgeons, when they place a graft, what do? They measure flow. And if it's no good, they fix it. Right. Why are we relying on the angiogram only? So that is my answer to the adoption question. Your first question is more difficult, but of course it's a very intellectual and perhaps a bit theoretical question. Is the post-PCI physiology, is it reliable? As reliable as pre, knowing that we are post-PCI and perhaps there can be microvasculature disturbances. We can also have some degree of reactive hyperemia that is stable, so to speak, at the end of the case from the repeated balloon occlusions. By and large, I think that it does work. I mean, we have relatively few but good data showing that the post-PCI FFR compares well with the calculated ones, particularly the QFR. I don't think we have it for OFR and IFR yet. The interdependence, yes, of course it is there, but let's change our mindset. We are responsible for the conductance of this vessel here, and it is the LAD from the ostium down to the apex. It's not about this particular or that particular stenosis. I think you do it stepwise. You're going to treat the most severe one, and yes, the one that was mild may become more severe because flow has increased. But then you fix it, you have it. Now, is it perhaps better to use IFR for this purpose that is less dependent on reactive hyperemia in order to avoid this interdependence? Yes, probably. I suspect that if you have very tight lesions, the IFR might be affected as well. You can have some flow reductions even at baseline without symptoms. But by and large, I think it's a good idea to do your defined GPS trial with IFR and take it from there. It will facilitate the adoption of the pressure wire measurement until we have the more widespread availability of the image-based computational techniques. The two other trials, the FFR React and Target FFR, are using the hyperemic FFR. One thing, if I could make a plea for the design of your trial, please make sure you do the health economics globally and not just on the post-PCI part. And I hope I got that across. I think it is key. Otherwise, it's not going to work.
Thank you, sir. Dr. Sharma, your final comments? And I also ask Dr. Devabrata Rai and Dr. N.N. Khanna, short comments, please.
Yeah. Professor Williams, how many percentage of the times after you do the functionally optimized PCI, you have to go again and either do an interventional procedure or modify the way you will give the patient the medical therapy?
Yeah, I think that it will depend on your caseload and the patient, not the caseload, but the type of cases you're treating. In the studies, the FFR is below 0.88 on average in about, a little less than 1/3 of the cases. So it is quite common. But if you're able to co-register it with angiography, and perhaps with the help of Stent Vis, you're able to see whether it's entirely due to obstacles that are diffuse disease that you can only treat medically versus the stent. So I would think that the need to re-intervene on the stent, which is your question, is probably going to be relatively low, maybe 10 or 15% of the cases, particularly if you have done pre-PCI, either imaging or functional testing, because you will have identified the proper length, and you will have identified the proper dimensions as well, because particularly the QFR technology also gives you 3D reconstruction of the vessel. So it is much better anatomy evaluation than just single plane QCA.
Thank you, sir.
So the trial will tell you the exact answer to that question, but I suspect it's not going to be all too often that you need to re-intervene to optimize.
Thank you.
It has been an excellent lecture. Only I have one query. In most of the Indian labs where there is, we don't have those facilities for routine physiological assessment, would you recommend routine post-dilatation of the stents?
I would suspect that with the help of Stent Vis, this would be probably a almost uniform recommendation to have post dilatation. Now, you see the image-based calculation of physiology doesn't need to be expensive. I mean, you don't need adenosine, you don't need pressure wire. So I would hope that this should become available along with the major cath lab companies, the Philips and Siemens and those guys. Yeah. They will make this available to you just as you get your angiogram. And then the only matter is to simplify and generalize the analysis so that it can be obtained in a short period of time in every lab with accuracy, that it's not too much dependence on the analysis. So it's QFR, CathWorks. I mean, there is 3 or 4 systems now that would give you access to physiology from your good quality diagnostic angiogram.
Thank you, Professor Vins, for your superb lecture, terrific lecture. We really enjoyed it. And can we ask you the privilege of your chairing the session for a little time, if possible, if there is no problem. Thank you very, very much, sir. And we'll be expecting you in our future meetings. Same to Professor Greg Stone. He has been there all along your, lecture and for his very, very valuable comments, because he's with all the major studies. And I would ask Dr. Shottavan Sharma to kindly introduce Dr. Adnan Kastrati.
We now request Dr. Adnan to speak on a very important topic, and that is a journey from durable polymer to polymer-free DES. And this is going to be extremely interesting for us to know how the science is evolving. Dr. Adnan?
Yeah. Do you see it?
We see you, which is great. Long time no see.
But you don't see the slides.
No,
we have your mailbox.
Okay. I go again.
Yeah.
And so it has been always difficult for me to get it. So,
did you open the PowerPoint before?
I think you have it.
Yeah, we can see it now, sir. Yeah.
So, Dr. Sharma, thank you very much, and good afternoon to all. It's a pleasure to join you in this important event, and I enjoyed very much the previous presentation of Stone and Weiss. So let's go back a little bit in the history of drug-eluting stents. Here are the two pivotal trials that established the value of drug-eluting stents as anti-restenotic device. So the main problem of bembetastat has been the restenosis, and with the sirolimus eluting stent, with the paclitaxel eluting stent, as shown in these two trials published in New England Journal of Medicine 2003 and 2004, there was more than 70% reduction in angiographic restenosis. They were trials about 1,000, 1,500 patients both. But it didn't take long to have also concerns about the drug-eluting stents. And the concerns were in another direction. They had to do with the thrombosis, with stent thrombosis, as shown in this publication 2004, which showed late stent thrombosis in patients after stopping dual antiplatelet therapy. But the concerns culminated in 2006 at the Congress of Cardiology, European Congress of Cardiology, where not only an increase in stent thrombosis, but also an increase in mortality was shown for the first generation drug-eluting stents. And you could have read at the time also a title like this, drug-eluting stents, is their future as bright as their past? And we started the editorial with this skeptical title, but at the end, we were much more optimistic about the future of drug-eluting stents. At the time also, there were preclinical data from mostly from the group of Virmani and colleagues that showed that biomedical polymers in drug-eluting stent applications cause inflammation to variable degree in proportion to the polymer mass on the stent, and that the perfect polymer remains unknown. But there have been also positive data about the polymers, like in the study 2011. Drug-eluting stents were associated, as compared to the bembetastat stents, with less thrombogenicity, and the reduction in thrombus generation was comparable to the reduction achieved by thinner strut stents. But you have to remember here that the drug-eluting stents used here had not only polymer, but also the drug, so you cannot separate the effects of the drug from the effects of the polymer. The most recent concerns for the polymers have been those with the absorbed stent, with the bioresorbable stents. So you can say that it has to do with the mass of the polymer, because it's a different thing to have polymers for coating and different things to have backbone from polymers. And the meta-analysis here from my colleague, Salvatore Cassese, showed that bioresorbable stents were associated with both an increase in stent thrombosis and also in target lesion failure. So in the last 25 years, we have been focused on the optimization of stent design, and we started with the strut thickness, having the idea that the thinner stents are better than the thicker stents. And this was the first study, ISAR stereo trial, with 651 patients who were randomized between a thin strut stent, and you see here 50 micron, and a thicker strut stent with 140 micron. Both stents had the same design, the same architecture. And this trial, although it was not that big, was able to show a reduction of restenosis with the thinner strut stents and a reduction of target vessel vascularization, both significant in the group of thinner strut stents. And since then, you know that the thinner strut stent has been also the standard of stent technology. You see here the thickness of Taxus and Cypher, which was very comparable to what we used in the control group, 140 micron. And now we have also struts thin as 60 micron. The second research field on which we focused was the structure, the surface of the stent. We have been encouraged by the preclinical data from the group of palmas showing that the rough surface improves endothelialization and that the surface porosity reduces neointima. We launched at the time a very small study, 200 patients overall, who were randomized between a microporous, and you see the picture here, how the surface looks in the stents, and the porous stent, and you see here on the right side how porous is the surface of the stents. Both stents had the same design, the same thickness. The study was very small, but we were able to see, even in this small study, a reduction in restenosis, which was not significant due to the numbers. And in all this study, we didn't see stent thrombosis cases. This, I have to say that this was not only for having better results with the rough surface, but also to ensure a better platform for drug-eluting stents, because the microstructured surface would have allowed more drug on it, would have allowed less polymer on it. And then we started the ISAR drug-eluting stent project with the sirolimus dose-finding study, and it was achieved with this small machine that was close to the cath lab there, and we coated the stents with this machine in the cath lab. The first study, the dose-finding study, was a polymer-free drug-eluting stent study, and you see the different dosages used in the study, from bare matter stents, 0 sirolimus, to 2% of sirolimus, and you see a dose-dependent reduction in the restenosis, in segment restenosis, and also in target lesion vascularization. And with this number, they are not excellent numbers as those shown in the Cypher and Taxus studies, but they are acceptable if you compare them with the numbers we got with bare matter stents. But we understood that alone, having polymer-free alone might not be enough. That's why we started to investigate preclinically the role of polymer coated stents with the biodegradable polymer type, and compared the release kinetics with the polymer-free sirolimus-eluting stent. You see that the sirolimus-eluting stents coming from the sirolimus kinetics coming polymer-free stents was much faster than in the stents coated with biodegradable polymer. On the other side, you see that having a polymer on it, a biodegradable polymer on it, you increase also the vascular tissue concentration of sirolimus. If you look at the inflammation, endothelialization, All the stents had very good data, except for fibrin deposition, which was greater in the stents with the biodegradable polymer coating. After that, we launched the first trial having three kinds of drug-eluting stents. You see here, the control was the polymer, the permanent polymer stent, which was Cypher at the time. And you see on the left side, the biodegradable polymer-based sirolimus-eluting stents, and on the right side, the black ones are for the polymer-free sirolimus-eluting stents. And it was clear that polymer-free drug-eluting stents was the more disadvantages from the three drug-eluting stents used in this trial. The problem was that the release kinetics of the polymer-free was very fast, and it didn't allow for the results we have seen for the permanent polymer drug-eluting stents or the for biodegradable polymer drug-eluting stents. That's why our intention was to slow down the release kinetics of the sirolimus without having the need for the polymer. And here you see the results achieved in the release kinetics for a combination of sirolimus with propicol as compared to the sirolimus from the biodegradable polymer-based drug-eluting stents. The propicol was identified as the best substance to slow down the release kinetics of sirolimus. It is very lipophilic, and you know that one of the studies done with PCI, with plain balloon angioplasty, has shown also some effect, some reducing effect of propicol on restenosis. Here are the animal data for the propicol, for this dual drug-eluting stents based on the propicol, and you see that endothelialization, inflammation were very, very good, comparable to the bare matter stent. And also, fibrin deposition was less than what was seen with the biodegradable polymer-based drug-eluting stent. The proof of concept trial was launched with more than 1,000 patients, and you see the groups here. One was composed from the Cypher stent. The other one was from sirolimus-eluting stent. It was the Endeavor stent at the time. We got the stents we had in use in our cath lab, and the selection of stents at the time was made based on the cost of the stents, so the administration had to play a major role in that. These two stents served as a control for our dual drug-eluting stents. You see that angiographic restenosis was not different from the dual drug-eluting stents and sirolimus-eluting stents, but it was for both of them much better than for the Endeavor stent, the sirolimus-eluting stent. After that, we designed and started the ESAR Test 5 trial with 3,002 patients. It is one of the largest trials in drug-eluting stent field. And in this trial, one of the groups, the 2,002 patients, was the Vivo ESAR Test drug-eluting stents. That means the sirolimus propicol-eluting drug-eluting stents. And the other group was sirolimus-eluting drug-eluting stents. At the time, it was the Resolute stents, not the Endeavor, not the first Endeavor stent. We had a 6 to 8 month repeat angiogram in this trial, and also we looked as the primary endpoint for the 12-month clinical events. Here is the definite and probable stent thrombosis for the two groups. It is very, very low for both of the stents used in the trials, and you don't see any difference between the two stent platforms. Here are the results of the very large follow-up angiographic sub-study with more than 3,300 lesions, and you see that the late lumen loss was very, very similar between the two drug-eluting stents. So we had the chance also to look at the 10-year outcomes from this trial. And here are the data regarding the primary endpoint. It was the device-oriented endpoint, having cardiovascular death, having target vessel myocardial infarction, and also target lesion revascularization. And here also, up to 10 years, the curves run very, very overlapping with no difference between the two drug-eluting stents. Here are the results regarding all-cause death. And you see it is very high up to 10 years because you have to remember that all are old patients. But you don't see any significant difference, although numerically you may say that the sirolimus and probuccal-eluting stent was a little bit better than the sirolimus-eluting stent. Here are the data regarding the stent thrombosis with the two drug-eluting stent types, and it is less than 1.5% up to 10 years, excellent results, and there was no significant difference between the two groups. Let's look at the other trials that have assessed the 10-year follow-up of randomized clinical trials with the drug-eluting stents. You have here first trial, CIRTAX trial, which was a trial of first-generation drug-eluting stents, Cypher versus Taxus. Here is the stent thrombosis rate up to 10 years. It is about 6% for the both drug-eluting stents. If you look at the SORT Out 2 trial, which was also a trial comparing Cypher with Taxus, that means first-generation drug-eluting stents, you see much higher stent thrombosis rate at 10 years. Cypher, it is about 8%, and Taxus is about 10%. But it's no surprise because we know that the first-generation drug-eluting stents were associated with a higher risk of stent thrombosis. If you look at the ESA test 5 trial at 10 years, I have shown already this data. The stent thrombosis rate with about 1.5% at 10 years, it's very, very low. But let's compare it because both trials I have shown were with the first-generation drug-eluting stent. Let's take the group of second-generation drug-eluting stents from the ESA test 4 trial, which was the Science stent. And at 10 years, here we had also a very low stent thrombosis rate, a little bit above 2%. That means that the stent thrombosis rate seen with the polymer-free dual drug-eluting stent, ESA Vivo stent, was a little bit better than with that. You know about the most recent results of the Onyx 1 trial, which was a comparison between the Onyx drug-eluting stent, permanent polymer-based drug-eluting stents with the BioFreedom polymer-free drug-eluting stents. The stent thrombosis rate, as reported at 1 year, was about 2%, also for the BioFreedom stent, which is another type of polymer-free drug-eluting stents. But we miss the long-term data for this kind of polymer-free drug-eluting stents. That means that the polymer-free dual drug-eluting stents, Vivo ESA drug-eluting stents, is a technology with the strength of about 25 years of research on stent design optimization. You have seen the data about the strut thickness, about the microstructural surface. Also, it is rich of preclinical studies in this area. It was preceded by optimal dose finding of sirolimus. It was preceded by proof of concept trials with 600 and 1,000 of patients comparing different types of drug-eluting stents. And also, all these trials we have done had also angiographic restenosis as a very sensitive measure of the efficacy of drug-eluting stent. At the end, they are also rich of very long-term outcomes. Both ESA test 4 and ESA test 5 had now published 10-year results. So at the end, I can say that the polymer-free dual drug-eluting stents, although an overall long-term superiority of this special polymer-free dual drug-eluting stents over best of the class durable polymer drug-eluting stents cannot be claimed on the basis of evidence, it might offer the best candidate for a safe early discontinuation of DAPT after PCI. Now, where to now for drug-eluting stents? we have written this editorial with the question, have we come to the end of the road? And I think that more effective and durable prevention of restenosis will remain a target of locally applied treatments even in the years to come. This will still require further improvement in test technologies, including adequately tailored drug release kinetics, development of new antiproliferative drugs, and metal or bioresorbable stent scaffold backbones. Thank you very much for your kind attention.
Thank you, Professor Adnan Kastrati, for being present and delivering such an excellent speech. And we are very thankful and respectful from CSI NIC for giving us your valuable time to come and give the lectures. And this is the Legion Speak session. We learned a lot from durable, polymer-free stent and durable stent, polymer stent, and the difference in vivo ESR and other stents. You have shown the different, and we are very respectful because from your center, German Heart Center, we regularly follow the ESR studies, and we come to learn about developments in the stent technology. Now, Dr. Shotyavan Sharma, I refer to you for your questions and also a few comments from Dr. Greg Stone and Dr. William Wins. And thank you very much, sir, Greg and Dr. Williams, for your kind presence in the podium. We are really very, very thankful to both of you, sir, for giving your valuable time.
Well, maybe I'll start, absent anybody else. Adnan, great talk as always, and I've also respected tremendously your contributions from all the ESAR studies, not just the stent studies over the years, which have, been pioneering and basically always right. Everybody else had to replicate what you were doing, but congratulations. So, I'll ask you this. We were so excited when we went from durable polymers to bioabsorbable polymers. We thought that removing the polymer at 2 months, 3 months would be a benefit for long-term outcomes. And then we got very excited about polymer-free devices because that would be the next step. Polymers are bad, so we would just have a bare metal stent. And most of all the comparative studies have really shown, at least with the contemporary devices, no major differences with either durable polymers, good polymer, bioabsorbable polymers, or polymer-free devices. Do you agree with that opinion? And right now, the polymer or polymer-free device should not be a major consideration, even in high bleeding risk patients with short DAPT.
Greg, you are right, and I think that for the moment we have several drug-release stents with polymer, permanent polymer, biodegradable polymer, polymer-free, which are supported by evidence, by strong evidence. And the problem is that, for sure, our selection will be guided by our taste, by our belief, by the price, for sure, at the moment. But for the future, I would say that our selection would be guided more for the ability of these drug-eluting stents to shorten the DAPT duration, which has not been still done at the measure we can have good data. I think that the victory will be on the side of the stent, which will be able to shorten at most the DAPT therapy.
So that's a great point. So we've seen now good data initially from Leaders Free, and then from the Onyx trial and Onyx 1, and then from Synergy registries and the senior randomized trial, and from the Zions 28 and Zions 90 that just came out. So again, do you think we're also learning that the stents are all pretty good for short DAPT? And do we need to see randomized trials? Are these registries acceptable to you?
I think registries are also good for that. If you have a drug-eluting stent which has been established by large randomized trials with long-term follow-up, it might be enough to have registries with a shorter duration of DAPT. But I I am a supporter of randomized trials. So even in this case, I would prefer to have a randomized trial with a long enough follow-up.
Thank you.
One question to all the panelists, including the experts, in fact, the masters. So much hype has been made over the bioresorbable scaffolds. So what's your message regarding the BRS in future?
I am waiting for the good device in that. For the moment, we don't have it. But I am very optimistic that more research in this area will provide us with a better device. For me, it's...
Ramesh, your comments? Yeah. Yes, continue, sir.
Yeah, I think that for all us as operators, we are not very happy to see all these metal vessels we see very often in our cath lab. So it will be a great thing to have a bioresorbable stent, but we don't have the right technology for the moment.
Yeah, no, I agree with that. I'm also cautiously optimistic, though. We need a thin strut bioresorbable scaffold with better expansion properties. They probably will need to be implanted with intravascular imaging. I do believe that, but if you put them in the right lesions and with imaging, we just saw, for example, in the Prospect Absorb randomized trial, where we could put them in bulky plaques, but mostly soft lipid-rich plaques, not too long, not too calcified, not too complex, with intravascular imaging. And we had 0 stent scaffold thromboses through 4 years. We had 1 side branch thrombosis, but 0 within the scaffold, and very good results. And that's with the first generation BBS, which I would not recommend anyone use. So I am cautiously optimistic that with a better scaffold, we could get, non-inferior, 1 to 3 year results during the bioresorption period, and then perhaps better long-term results once the scaffold is gone. But it's a big development program. No one's going to believe anything other than very large randomized trials to show safety and effectiveness there. And I hope it gets done, but I'm not sure it will.
Thank you.
Dr. Ramesh, are you there in the chair?
I'm
Dr.
here. Dr. Kahali, I think this is a great legend session, and I really am amazed at how, Greg, thank you for staying. And Adnan, I'm from West Virginia University in New York, and to see Williams and Adnan and Greg actually having not lost any sort of vigor in research, despite some negative trials, is really great. And I think that's what Greg is pointing about. I mean, India is making a thin bioresorbable vascular scaffold, and probably this is a great time to start even thinking about having an Indian registry with our even clinical trial with the help of CSI leaders who are all on the podium now to do that sort of a prospect India study with the BRS. I think that'll be a great segue. And look at the post-PCI, Williams. It's fantastic. This is a new rejuvenated interest in post-PCI FFR, and learning more about Excel and learning more about the polymer-free or biodegradable polymer stents. And we still probably have a lot of future to look into these scaffolds and stents. Thank you.
Thank you, Ramesh, for your excellent sum up. And from CSI NIC, I thank you all. And it's our privilege, great privilege, to get Professor Greg Stone, Dr. Jeffrey Popma, Dr. William Wins, and Dr. Adnan Kastrati, who are the legends in the field of interventional cardiology. We salute you, we adore you, we respect you. And please accept the great respect and adore from the CSI NIC. And we'll be expecting, because we missed you in our Chennai meet in April 10 to 12. Ramesh also couldn't come, but he always comes to us. Thank you, Ramesh, also for being with us complete 2 days. And I really thank you very much, and to all of you. And we are at the fag end of the session. And I would ask Dr. Professor P.K. Dev and Dr. Minal Kanti Das to comment about the final, comments to conclude the session. Thank you.
Dr. Dev is
Dr.
there.
Das.
Yes. As the president of Cardiological Society of India, I can simply say that it was a superb 2-day virtual conference. In fact, I am really thankful to all the international masters as well as from our own India who immensely contributed to knowledge sharing as well as enlightening us. And in fact, I'm also thankful to the two stalwarts of the NIC, Dr. Dhiman Kahali, who is the chairman of the CSI NIC, as well as Dr. Debabrata Rai, who is the interim treasurer. Actually, they have done excellent job by burning the midnight candle to make this conference successful. And I am also thankful to Dr. P.K. Deb, who has been our guide all throughout. He has been the past president, and he's really mentoring us forever. I again offer my thanks to all the delegates who have sat here in front of the computer for 2 days in the background of two pandemics. One is the COVID-19 and the other is the webinars. And really, I'm thankful to everyone. And thanks, everyone, once again. A happy Puja festive season. Actually, it's a festive season in India, and also it's going to start everywhere in other parts of the world. And long live CSI. Jai Hind.
Thank you. Thank you very much.
Sir,
Yeah.
Dr.
Dev, you please give the concluding remarks. He is the past president and mentors of ours. And I also thank the 1,500 or delegates and the faculty for being with us for long 14 to 15 hours on both the days. From very morning, our US friends joined from very early morning, Subhash, Ramesh and others. And I thank the legions. There is no language to express our gratitude and thanks. And I will be expecting all of you, all three of you, during our future meeting, maybe in 2021, the physical meeting probably we are going to have. Thank you very much again. Dr. Dev, your final words. And Dr. Devu.
My dear friends, in fact, in April this year, we missed to organize a show in Chennai due to unacceptable conditions of COVID-19. So at that time, we decided that we'll have to do something maybe in later months of this year. Then something should be done, and NIC must continue showing its show. So I am now happy man because in fact we succeeded, and the conference, it came up to our expectations, even in the height of the COVID-19 infection. I am happy, but I believe that next year it will be much more organized and much more attractive and much more well talked about show. I accept that this is an excellent program this year. I'm happy, but I want to be happier. I told you earlier that I'm a compulsive dreamer. I love to dream. I like to dream. I dream that next year the conference is much more attractive, much more elaborate, much more expensive. Even if there is COVID-19 or COVID-20, whatever, we will do it again and do it in a much more spectacular way. You are happy this year. I'm also happy this year. And I love to be happier next year, and I'll make you happier next year. Thank you. Thank you,
Dr. Debabrata Rai, one or two words from you. You were greatly instrumental. Thank you, Dr. Dev, for your great comments.
I must thank all the foreign and our Indian faculties and delegates who have taken leave from their weekend holidays to join this meeting. I should extend my thanks to Raghu, who has been instrumental in maintaining a seamless transmission all through these 2 days. And my sincere thanks to the participating companies, Concept Medical, Shahjahan, Medtronic, Torrent, and AstraZeneca. Their contributions are very much appreciated. And last but not least, I should express my personal gratitude to our great friend Ramesh, who has been of great help to us all through. Thank you, Ramesh.
So thank you very much. And with your permission, we want to conclude this great meeting with the expectations Dr. Greg, Dr. Ramesh, Dr. William Wins, Dr. Jeffrey Popma, and Dr. Adnan Kasrati, and all the international faculties. We had total 25 international faculties. Dr. Golam is there from Bangladesh. Dr. Fazila Malik is there from Bangladesh. So we would be expecting to have another successful conference next year, and we'll be having this educational initiatives. And thank you, Professor Stone, for being with us for such a long time. We know how valuable is your time, and I also thank my great friend Ramesh Dagubatti, who has been there from early morning yesterday to today, and helping us in all the ways. And I thank our Dr. M.K. Dash and Dr. P.K. Dev for helping us, and also the faculties, our national faculties, for their excellent lectures. And I want to conclude the session and the meeting. Thank you very, very much, sir. Thank you. Jai Hind. Thank you. Long live CSI. Long live NIC. Long live NIC. Thank you, sir.
Long live CSI.
Thank you. Thank you. Thank you. Thank you. Dr. Professor William Wins, you are there. Thank you very much, sir. And we'll be expecting you in our meeting. We hope to have a physical meeting after the advent of COVID-19 vaccine. And we'll be expecting you. You, Professor Kastrati, Professor Stone, and Dr. Geoffrey Popma, and many others. So you are great that you have been with us for so long. And with folded hands, we again want to tell we are very much grateful to you, sir. So conclude the session.
Thank you. Thanks, everybody.
Thank you.